Sir, case discussion.
Hello, good morning everybody. This is second day. I request Swapnil to be here as a moderator, and I request Dr. Kakatkar sir to present his cases.
Well, good morning. I think people are still coming out of the yesterday's musical night, which was a very, very excellent performance by all the Solapur orthopedic surgeons. So, I think let's start with our case discussion session. Well, I think we'll make it interactive so that everyone gets involved, whosoever is there in the hall. So this was a 49-year female, and this was her injury. So can we ask questions to the dais people also? Yeah. So,
So, how many days since injury?
this is a fresh injury.
Fresh injury.
So how will you manage? Standard, I think standard procedure.
Standard procedure, but
What will you do?
a CT scan just to rule out the intra-articular element.
There was no intra-articular fracture. It means there was no coronal split. There is an intra-articular, but there was no See, basically this patient has come to me quite late, so I don't have any previous records with me, These are all the X-rays of the patient taken outside. So this was the patient, and suppose it comes to you, how will you manage? We take it for granted that there is no coronal split, it is only an intra-articular with supracondylar.
Transolecranon bicolumnar fixation.
Bicolumnar fixation.
Bicondylar.
Anybody else, any different views? I think it's a very standard approach.
We use a tricep splitting.
Yeah, I think there are different ways of approaching this. If there is no coronal split, for me, I think I would fix it by a triceps tongue approach because I can get an excellent exposure without cutting the olecranon. Trap, yeah. Yes. Even by paratricipital, I think you can get this. Yes. So this was what was done. I'll show you the previous picture again, and this is what was done.
Sir,
So what has happened?
intercondylar element has not been addressed at all. And it is only posterior plating, it should be actually orthogonal plate. Buttress from the medial side and posterior side. And intercondylar element has not been addressed, it will definitely fail.
Anything else that you can notice? This is the previous X-ray.
Fragment also appears to be lateralized, sir.
What is?
Proximal fragment appears to be lateralized. Post-op X-ray.
Proximal fragment appears to be?
Lateralized.
There is something more that has happened. Can you
Posterior to the distal fragment.
see just look at the first X-ray, and now this is the second X-ray.
Does the medial column, what happened? The medial pillar seems to have disappeared.
The medial column has disappeared. I don't know what exactly was done by the first surgeon, but this is what was the picture. And then, this kind of a fixation is not going to last at all. So, this was what happened. The patient came to me 6 years after the index surgery. And this was the picture. The forearm and the arm were at 90 degrees when the patient was standing. You can see this particular initial picture. So this was like this, and all the implants were floating. So we just corrected it, and as a stress view, we just try to see how much correction we can get. So we could get it almost to the straight line, but then this is what is the condition. So this is at the end of 6 years that patient came to me. Now what will you do?
So,
Yes.
I mean, you have to go ahead and fix it. Obviously, you have to plan it carefully. This is a situation where I might use parallel plates rather than orthogonal plates because the uh, medial side is really small. So I'd like to get screws across from the medial side. And you need to use bone graft copiously as well, and you would have to reconstruct or recreate the olecranon fossa at the end of it. So, and whether you add fibula or not, or just bone grafts, that's a choice you have to make on the table.
Dina, what will be your way of looking at it?
Say, like anyway, the articular area seems to be good, so that's why there is a good way to reconstruct it. So once we get the alignment, so on either side of the parallel plating would definitely be the best choice.
Shiva?
The distal fragment is too small. So just by putting two parallel plating, how much hold I will get in this after 6 years in this osteoporotic bone, I don't know. So I might consider two parallel plate and one additional posterior plate also, 3 plates.
See, the main challenge in this was going to be reconstructing the medial column which is missing. So, when I looked at this X-ray with this correction, what I realized is that the lateral side is now having a big beak-like projection, and medial side there is nothing. So, preoperatively, we planned that because there was definitely a lot of shortening of the triceps, so we will go by a triceps tongue approach. We'll excise this part and try to use it to reconstruct the medial column. We'll be able to get the alignment, then put some additional grafts and then do the fixation. That was the preoperative plan. And luckily we could execute that. So you can see this was the projecting lateral side. So we took it out from here, shifted it on to the medial side. Medially I put a plate like this, and the lateral plate I put on the posterior side, and this entire gap was filled up with iliac crest bone grafts. And as compared to what I expected, the bone quality was not very bad. So putting a locking plate, we could get a fairly good hold onto it. This was the post-operative X-ray. You can see the bone grafts put here on this side also, and the lateral side we have shifted to the medial side through which this particular screw has gone. So this is at the end of 5 months. Everything was consolidating well. At the end of 3 weeks, we started mobilization with the slab. After breaking the slab, we started doing the movements. At the end of 6 months, this was her picture. At the end of 1 year, this was the picture. Both the columns have healed up, and this was her movement. So, if you do a proper pre-operative planning, in the difficult situations, you can get very good outcome. Another case, 42-year male, this was his original injury. You can see there was a small crack seen here, a fracture here. So a segmental fracture of the shaft of the femur in a road traffic accident. So, DIAS, how will you proceed?
Sir, X-ray PBH is there?
See, unfortunately, all these cases I have received later on. So this was what was with the patient, you know.
Sir, retrograde femoral nail.
Retrograde femoral nail. Okay. And you will pass the nail up to
Above the lesser trochanter.
above the lesser trochanter. Yes, any other views?
Distal femoral fracture is an unstable fracture if you are doing a prograde nailing. If you are doing prograde nailing, you have to add polar screw or add a multi-locking distal one. Otherwise, my choice will be to put a retro nail. In addition, I might think of putting, if the patient is young, then it is 45 years, I think.
42.
42,
He's 42
yeah.
years.
Then I don't mind putting a additional locking plate from the side, just 2-3 screws distally and 1 or 2 screws proximally, just this augmentation.
Yeah. Hip was okay. There was no problem in the hip. But unfortunately, you know, the first surgeon who treated, this was the X-ray taken on which he took a decision.
Yeah, so he didn't get an X-ray of the pelvis separately. I think that should be a lesson for everybody.
Ideally, you must get the X-ray of the pelvis as well as you must take X-ray of the knee also properly. This was what was done. Comments?
The surgeon should go back and do MS orthopedics or whatever it is once again.
See, if you see here, the fracture which was undisplaced, you can see some staples here indicating that probably even for that open...
That was displaced, not undisplaced. Go back. No, it was displaced. The lateral view shows it was quite displaced. Yeah, see.
No, not too much of
No.
displacement.
It's a
Well, once you
yeah.
get
That
the
is
guide
displaced.
wire inside, I think there shouldn't be a major issue for whether you go by antegrade or retrograde nail. I think
When you are shifting the patient from the ward to the OT to the orthopedic table, it gets displaced. So it's accepted.
Okay. So this was what was done, and you can see there was open reduction here also. An attempt of distal locking was done. You can see some staples here, but then maybe it was not possible, so it was given up. So this was the post-operative picture. Then, at the end of 5 months, this is what happened. The nail entered into the knee joint. He went to the surgeon told him that, well, let at least one of the fracture which is joining, let it consolidate, we will not do anything. So it continued. Then, this was at the end of 1 year. His knee was painful because of this jutting nail. There was an overriding here, and this fracture had started consolidating. So this was the picture at the end of 1 year. So at this stage, what will you do? No, then you have to do more felicitation because there is something more to
Again,
come.
the plan doesn't change. You can do a distal femoral nail, a freshening of remove this, do a distal femoral nail. Since it is 1 year old, I don't want to continue with the same nail at this stage because it can break any time. So I'll put a different nail, and preferably, since anyway knee has been, entry has been properly done from the knee, that's where I take the distal femoral entry. I will take the entry from there and do additional plating and bone grafting.
So this is, this was a picture at the end of 1 year. So the surgeon decided to operate him, and this was what was done. He removed the nail. He said that the proximal site has joined. So we will do the fixation of the distal fracture now. And this is what was done. Then he continued with the same surgeon. This was at the end of 1 year after the second surgery. This is what happened. There was valgus. Because of the adductor pull, I think that valgus got partially corrected and the implant came out from the proximal side. So, this was the picture. He continued with the same surgeon, and this was the picture at the end of 4 years. This was the time that the patient landed up with me. Okay, I have got now shortening and this plate is hurting me. And he was able to manage walking with a limp on that, you know. So now what will you do? There was no infection. All throughout, luckily, in all these 4-5 years, no infection. No, now the problems are that he has still no union. There is a shortening, there is some virus, and there are broken implants. So we have to address all these problems. So I counseled the patient. I said, we can...
1 minute. Ask the panelists what they will do.
Yeah. So what will you do? So these are the problems and this is the picture. So how will you tackle it?
Freshening of the fracture site, retrograde nailing, possibility of a plate and bone graft. The screws may or may not be possible. It will be difficult.
Can you speak in the mic because everybody cannot listen?
Yeah, the plan is the same. The freshening of the aids, retrograde nailing, additional plate and bone graft.
Will you be able to address the shortening along with this particular procedure?
We will accept the short. I will accept the short.
Anybody else having any different views?
How much is the really shortening there? Sir?
Is about an inch of shortening.
We can address it later, sir, not at the same time.
One thing at a time, that done well. Get the union first, think about
Yes,
the
Swapnil.
shortening later.
Take the mic.
Removal of course, all the implants, freshening of non-union site, put a retrograde nail with long plate with fibular graft inside to maintain the shortening if it can be done. If it is not done, at the same time you can opt for 3 rings Elizero fixator on the tibia and you can just do the corticon and can increase it. That will be a little bit more easy comparing getting the 1 inch shortening at the fracture site maybe.
Any other views?
Why would you lengthen the tibia? If the knee is not mobile, I can go with that. But if the knee is mobile, I would rather deal with the same bone rather than if you have to deal with it. That's another question.
The femur doesn't appears to be the cause of shortening, this fracture. Is there any proximal problem?
No, no, no. See, there was a comminution there and you can see in the second surgery probably when they were doing all this, some bone must have been excised.
Another option can be IMSC without distal proximal interlocking, put a LRA, slowly distract and then go for bone graft.
Then go and then you do
Yes.
the locking proximally.
Yes, and bone graft.
So, like Dr. Chandak yesterday told cast theory, so we had to aim at all these 4 points. So I used a distractor. After freshening the bone ends, we used a femoral distractor, distracted the fragments, put an intramedullary fibula with the instrument that I showed you yesterday, that railroading like thing. And once the fibula was there in the proximal and the distal fragment, temporary K-wire was passed through the fragment in this direction to keep the fibula stable, and then we put a long plate and iliac crest bone grafts. And this is at the end of 6 months. This is the function at the end of 6 months. This is a follow-up at the end of 1 year. This is a 2 years follow-up. So he has got full function, good length, and he is extremely happy. But then a simple situation, how it can be made complicated, and how you have to...
Kakar, can you go back to the one slide? Just to add a point. Please see that whenever you put a locking plate, underneath the plate, callus hardly forms. It only forms on the opposite side because the little instability and the fracture is able to collapse on that side. So, there is a good article which says that with locking plate, the callus formed at 12 weeks is 0 millimeter cube, whereas with a nail, it is 360 millimeter cube. One of the article is there. When I talk about IMSC, I quote that article. I just wanted you to see that even after 2 years, underneath the plate, the bone has not formed. Because it is too stiff a construct there. Just information, that's all. You can continue, sir.
Yeah.
One more question to all faculty. Whenever we are doing such a difficult or multiple cases in supracondylar fracture of the femur, and after 4 years you have fixed this fragment. So, obviously in the first previous cases, usually the range of movement is less. Okay, if there is an infection or there is stiffness or there are multiple cells. What is the tip and tricks to increase gain the range of movement? Anything we do during this last surgery to the soft tissue also?
See, in this patient, luckily the patient was walking all throughout, and he had a very good range of movements. He was walking with a limp all throughout these 4-5 years' time, So, getting the range of movement was luckily not a major issue. But otherwise, I think one has to think in terms of doing adhesiolysis. If there are lot of adhesions, and if you are able to get a very stable fixation, then you should do adhesiolysis, because many a times the quadriceps gets completely plastered to the femur with repeated surgeries. So you have to do adhesiolysis, number of times you have to do arthrolysis, because then intra-articular adhesions also have formed. And then if you have been able to achieve a stable fixation, try to put the patient on a CPM within just 1 week's time, so as to get at least 90 degrees of movement. That is what normally we follow. Yes. Yeah, sometimes, that pie crusting like thing can give you, but it doesn't really work much in quadriceps.
Sir, how much length you could achieve, sir, correction?
We could get a complete normal length with the distractor,
So
femoral
1 inch
distractor.
distraction you could do it with the distractor
Yes.
after 5 years of...
But you need that strong femoral distractor,
Kakatkar sir, what is the acute distraction? How much we can go in this level? Is there any limit to which you can distract, or?
Well, you can't really put a limit, but then we were keeping the measurement in front of us, and we were trying to get the normal length as far as possible, So after
My question would be based on like how much of neurovascular stretch can be accommodated at this
you
level?
can do it up to about an inch.
So I think this is a different situation from a congenital shortening.
Yeah.
Where you have that problem. When you have a traumatic thing, then the neurovascular was originally the full length. So getting it back to the same length is not such a big deal.
Yeah.
No, but sometimes
It can be a problem, but
Yeah,
you have to
sometimes
watch
if
that.
it is having too much of fibrosis
If it's very
and
fibrotic,
the
it's a problem.
neurovascular bundle is involved in that fibrosis, then maybe stretching it out can be a little dangerous. You can land up with either a nerve palsy or you can go into a vascular spasm.
But in congenital shortening, it is a
Yeah,
problem.
congenital shortening,
even
one has to be very careful. Because if you try to do stretching of the tissues, neurovascular bundle will be the first one to give way.
the reason I asked is sometimes neglected cases that come in. We try to stretch it to get to the length, And post-operatively, they have severe pain of neurological stretch. That's why I asked this question.
I think it's an important point that we should remember that, stretching of the neurovascular structures in these cases of shortening, one has to be a little careful. Sorry. So this was a 28-year male, came to us in this situation. Interlocking was done. He came with a discharging sinus and there was a sequestrum here. So, infected non-union, this was almost, I think, at the end of about 9-10 months after the index surgery. So how will you proceed? Aditya. First you, then the panel. Okay, I think we'll ask the panel first and then…
Get rid of the implant, debride, and I would go for an Elizaro here because there is a sinus, active sinus drainage.
But you will do an ring fixator by…
Debride, firstly thorough debridement, sequestrectomy.
But the fracture is not a transverse type of a fracture. There is a big sequestrum here. So if you put a ring fixator, how will you be getting the alignment of the…
So firstly, you can dock it acutely. And then
Acute docking?
Yes, and then later on…
But I think the distance is, because if you exercise this much, acute docking, all the soft tissues in that area, it's all bulky muscles. So will it be possible to do acute docking?
I would rather go for an implant removal and put a cement spacer, antibiotic cement spacer, and fix it with a normal external fixator. Later on, we can definitely go in once the infection has subsided and go for a fibular graft along with a good fixation by internal modality like a plate.
Okay. Now, Aditya.
The foci of infection need to come out, that will be the first thing. Fixations multiple options are there later, so that sequestrum comes out. The posterior cortex will probably be in continuity. That should be intact, so then there should not be a problem.
There is some cortex remaining
Yes,
over there.
Yes, so posterior should be fine, sir. The other thing that would be important is when we ream, a lot of medullary biofilm may go down. So it's important to remove that. Either have long grabbers which go in from the top, or if you're planning to nail later, the nail would go down, so you can join these, expand this whole distal hole, make a distal vent or a blowout window. So all that medullary biofilm actually comes out. Otherwise that remains inside. So
As a nidus, it will remain inside.
yeah, so that would be the main focus. Then on that you can address it in many ways. Elizaro, antibiotic coated nail followed by a revision nail. So that would be a surgeon preference. So that's…
Okay, Aditya, what I do, I'll tell you, but whether I want you to, what I'm doing is correct or not, I want you to do, I'll tell. So anyway, we are doing interlocking, the whole, some material comes out. But what I do is, I put a drain tube distally, inject povidone iodine with the hydrogen peroxide, and that also brings back all the material toward the fracture site, and the leg will be elevated at that time. So distal fragment, whether using povidone iodine or hydrogen peroxide, because hydrogen peroxide nobody uses anywhere in the world except in India probably, because I was working in Germany and England. Even if you put a drop of hydrogen peroxide, they used to shout something will happen, as if so I want you to yes, but Germany, they were totally against that. Even sucking, what we normally do is put a drain tube and suck it out. That also, once I did that, I used the suction tube to suck out, immediately the boss shouted me at that time. So anyway,
we
what I'm
also
doing…
do that, sir. So basically, whether you use a suction tube inside, there are mechanical metal aspirators, long tissue grabbers, so all of that needs to come out. And we also use peroxide quite frequently. So,
But then how do you use…
Such cases, or pushes the infected material inferior. The hole which you told, you should make, it should be just as a routine interlock hole, or should be a, that is what, because the biofilm is thicker and sometimes it may get clogged up.
So, I'll step in about pulse lavage. There is infection consensus meeting for joint replacement Philadelphia recently to 2024. The consensus about using pulse lavage in infection is use it on a low pressure mode. There are two pressure modes. One is the high pressure mode where you can flush everything inside and the infection can get disseminated. Patient can land up with sepsis. So instead of that, if you use it in low pressure mode, it is desired.
But this low pressure concept came long time ago.
Yeah, in fact, this low pressure
Still-
thing
yeah, it's still
is
there.
something which is recommended even for primary debridement. Because they don't recommend using with high pressure for the debridement because number of times the contamination goes more deep because of a high pressure pulse lavage.
We use the simple syringes or chip syringe. Pulse lavage is an add-on. It's low pressure. And even like Sir was saying, even during reaming, those things can happen. So we don't use a tourniquet during reaming. And after every ream, we make sure the tissue is pulled out. So it's not continuous reaming. So with every ream, there's a wash. Then again, you go to the next size, again there's a wash, and that distal hole is a little wider than the interlocking hole. Otherwise, the tissue doesn't come out. And actually, keep putting scoops, keep putting arteries, keep removing tissues from the top, from down, wherever. I mean, that tissue needs to come out. That's the idea.
Like what Shiva said, he put a feeding tube or anything.
Correct.
And elevate the leg and flush the limb with the syringe.
But there'll be big tissue pieces. In fact, you'll find the longer the infection, you'll have nice thick chunk of tissue that will come out. So a lot of times you have to have those special instruments or a distal window, whatever.
And all that are
Aditya, a question about hydrogen peroxide. There are a lot of controversies about using hydrogen peroxide. Do you think the hydrogen peroxide that you use is a sterile solution?
It is supposed to be sterile, but so far we've not regretted using peroxide. We've not tested it in the lab, but we've not.
Yeah, Aditya, sir, actually,
Sir,
if you see the bottle, it is written that it should not be used for medicinal use or clinical use. It is for laboratory use. It is written that should be
Yeah,
used
but
for laboratory
nothing
use.
grows in hydrogen peroxide, I can guarantee you that.
Aditya sir, where exactly do you put that window distilling and how big is it?
Just like this is over, here we could just expand it a little, use a nipper and widen it a little, and it should be enough to put your scoop. So maybe a centimeter and a half, 2 centimeters maybe, and a little wide enough to put your scoop in or an artery, something to grab the tissue out, something for the tissue to come out.
And do you put a drain in it? Do you leave a drain inside?
Inside that distal hole, no.
Anyway, I think this was what was done as the first stage. Sequestectomy was done, the wound was cleaned up, and the implant was retained, and we put a vac. But as expected, the infection was not getting controlled. So we went ahead, removed the implant, thorough cleaning of the entire marrow, and we put an external fixator. And we put a cement spacer into that gap. And this was with the cement spacer. And once the infection got controlled, you can see, as Aditya was saying, the posterior side started showing some continuity. The quality of bone on the posterior side started showing improvement. So the cement was removed and this was the gap left. So instead of going in for refixation, we just put bone grafts into that cavity. We could get a nice soft tissue closure, and at the end of 3 months you can see the bone has joined up. So not every time when you do revision you have to put in an implant again. If the bone is forming after putting a cement spacer, and luckily the fibula was already united, so there was a stability, so we did not put any implant again, just put bone grafts and immobilized him, and the fracture healed up. This is a 60-year male My own case, we did an interlock. And at the end of 6 months, this was the picture. So what will you do?
Infected, sir.
No, there was no infection. Non-infected, but it started showing hypertrophic non-union. So what will you do?
Stability.
How?
If you are a nailer like me, then you, anyway, since it's a hypertrophic non-union, just 6 months old, I'll just exchange the nail, or even I just add polar screw to give stability at the fracture site, and I might think of putting a fibrillar nail also inside so that it will be little more stable.
Why there is instability?
Because, yeah.
He has locked proximally, locked distally.
See the nail,
See, the
canal is
proximal
wide.
locking,
No, no.
because it was a very short oblique or almost a transverse fracture. So proximal locking from day one was only dynamic. We had not done static lock. And the patient was encouraged weight bearing. In spite of that, he landed up with hypertrophic non-union. Yeah, normally the standard recommendation is that if the fracture is in the 6 to 7 centimeters from the distal end, along with the lower third fractured tibia, then you should stabilize the lateral column also.
Kakatkar sir, I want
Yeah.
to just add a tip. I'll come up on the stage. If there is a pointer, Saminder.
Yeah.
What happens is, we normally do proximal locking and remove the jig before doing the dynamic locking. If you see the proximal locking, it's already in the lower part. There is hardly any gap below that. So what happens is, the bolt you have put at the proximal end of the hole, once you remove the jig, it gradually comes down, and then you do the distal locking, it's already in the static mode. So always what I normally do is put the proximal bolt, put a static Steinmann pin, then remove the jig. Once you have put a static Steinmann pin, nail cannot go up. Then you come from down the fracture side, then do distal locking, then you remove the static Steinmann pin. Just this is a tip because it's very useful.
But
What
then,
diameter is Steinmann pin
no,
you
but
put?
then I never do proximal locking first. I always do the distal locking first, back slap, and then do the proximal locking. So that particular factor is not there, you know. Whether it is femur, whether it is tibia, always distal locking first, and then only we do the proximal lock. So that particular error is not possible in this situation. So we discussed with the patient. Yeah.
What diameter Steinmann pin you pass?
What?
Diameter Steinmann pin.
Usually 4 millimeter, it's a 5 millimeter hole, and the dynamic locking allows about 5 to 7 millimeters of collapse. So 1 millimeter difference doesn't make much.
So I think there are some advantages and disadvantages of what you said, because you have to retain the jig through all that distal locking, which can be a problem. So if it's a simple fracture in the mid shaft, I usually just go ahead and lock the proximal and then do the thing. But in something like this, I would be careful about locking the distal first and then doing the proximal lock.
Yeah, we do all our tibia fixations on that angle frame.
Yeah.
And we adjust the C-arm in a little
Yeah, but
oblique
you still
manner.
can't take the jig off till you...
No, but we never take out the jig before doing the distal lock.
John, this is in continuation of your say that even there is a fracture in the middle third there. You do a...
Yeah, nowadays we're doing suprapatellar nailing, so it doesn't matter.
Yeah.
No, so even for that normal nailing also, what I do usually, put the nail, if it goes into distal fragment, I fold the knee completely and put the foot onto the table and then start hammering. So automatically it gets jammed at the palm. And second thing, you can see the rotation also if you put the foot onto the table, which is there.
I agree, but in the distal fragment fractures like this, you can get displacement.
No, I'm not talking about distal fragment.
Yeah, so that's why I'm talking about this particular case. You will get displacements if you're not watching it every moment. And I would probably use a polar screw in something like this to make sure that that doesn't happen, so that the nail goes center.
So the problem was instability, because of which it started showing hypertrophic callus. So we discussed with the patient. I said there are options that we can do bone grafting and then put another small plate. Or he said that, can you avoid second surgery? I said, we can try just giving you a plaster, avoid, because his ankle used to move, which was causing a little rotational instability. And then a controversial thing was putting a bone marrow injection. So we injected bone marrow and just put him in a PTB plaster and allowed him walking on the PTB plaster. The moment we stopped the rotations of the ankle, you can see within next 2 months, the fracture united. This is at the end of 5 months, we have removed the plaster, and this is at the end of 6 months. Everything
So did you
is
inject
united.
the fibula also?
No.
But that was also united.
That is probably, I think, the rotation stopped and both the bones united. So the message from this case is that if you treat the instability, every time you need not do a revision surgery to treat that particular fracture. Yes. Yeah, but this is a retrograde thinking that if we could have stabilized the lateral column on the day one, maybe this situation we could have avoided. Not 10 centimeters. It is 6 to 7 centimeters from the lower end. If there is a fracture, along with the fractures in the lower part of the tibia, then you must fix the lateral column.
Whether it is 6, 7 centimeter or 10 centimeter, that is the problem.
No, 6 centimeters. 6 centimeters.
What I want to say is that when you were giving anyway plaster, removing that one bolt on the top, would it have added further rotation?
I don't think so.
So it would have helped in reducing the gap.
Yeah. See, this was a bilateral compound injury of the lower end of the femur. This was the right side, this was the left side. This was a case when the locking plates were coming quite new. That time I have done this case. So bad soft tissue injury. So once we got control on the wound, I will not go into the discussions because we are running short of time. So this was what was done. We did a locking plate and this was his post-op picture. There was a lot of comminution. Only one side we put a plate. It was a learning for me, so I thought I'll just share it with you. The density of the screws was not maintained. The length of the plate was not maintained. Because that time the locking plates were coming new and number of things were not known to us also when we were using these implants. And both the sides I had to revise twice because the implants broke twice. And then, if Shiva, you remember, I think I had presented this case in our trauma experts meeting. And then a lot of discussion went on, and then the length of the plate you have to maintain and the density of the screws. So at the end of 2 years, after doing 2 revisions, we got the union, So this was one of the learnings of locking plates. This is another case, 35-year male. He came to me 4 months after the index surgery. This was done outside. He had a non-union here and a broken nail distally. Probably he was a shopkeeper, he used to do all the activities with his hand, and proximally there was no locking. So this is what he came with. So we removed the nail. It was difficult to remove the distal part. Because of that broken small screw, we couldn't engage any instrument into the broken piece. So we decided to leave it there. We did plating and bone grafting. The patient was completely non-compliant. After he was discharged from the hospital, he disappeared, never came back. He came back at the end of 6 months, and this was his picture. So then I said, you never came back to show? He said, I was doing work, so from the next month I started doing all my activities in the shop. And this is how he came back. Then we had to counsel him. I said, we will operate you second time provided you're going to follow all the instructions. Intramedullary fibula, and we had to revise and put another long plate. You can see the intramedullary fibula I have passed right up to the GT, and we did bone grafting, and ultimately this united. Is there any time for one more case? Yeah. So this was another infected non-union, because most of these cases I get from outside, you know. So this was the patient who came with a big gap. So we put a fixator, we triangulated the fixator, and once the infection got controlled, I stabilized the lateral column by putting a plate in fibula, and this was a gap. So the fibula maintained the length, and once we got the infection under control, we use a vascularized fibula plus iliac crest bone graft, and at the end of 1 year, this showed an excellent healing. You know.
This
So
is before the masculine came or?
This was much before that. You know. Yeah.
Yeah, 16.
Another case, fracture humerus. This was a lady from Madhya Pradesh. She was treated there for a bad compound injury with bad soft tissue trauma with these kind of nails, rush nails or elastic titanium nails. The first surgeon did this surgery and it refused to unite. So he went in and he operated her with a plate and did this fixation. Unfortunately, she landed up with bad infection. So the surgeon decided to remove the implants, and she was just left alone like this. And then she was just managing with it for a long time. And at the end of almost about 4 years after the first surgery, she came to us. I said, well, we can offer you surgery again. So we did intramedullary fibula, we did iliac crest bone grafts and fixation with a plate, and there was again activation of some low-grade infection, but luckily because I think we had put plenty of grafts and it was a stable fixation, so the bone united, and you can see her soft tissue condition, and she had excellent function. This was a 40-year male, comminuted subtroch fracture. This was fixed like this. This was the first surgery. Then the surgeon thought that this was not good. So he went in and did a revision like this. So the patient came to me at this particular stage. This was 3 months for the next surgery. So what we did, we kept the same DHS, this DCS screw inside and just put a DHS plate, put bone grafts, and luckily the screw was quite centrally located in the head and neck. So keeping the same screw, we just changed the plate, did valgus, and this is the picture at the end of 3 years, and excellent function. This was a 48-year male. This was a neck femur fracture. DHS derotation was done outside, got infected. So the patient came to us at this stage. So we removed the implant, put a cement spacer, and after putting the cement spacer with antibiotics, we got control of infection, and then at the end of 7 months, we had to convert it to a THR. So I think I'll stop here because we have to continue with this session further. Thank you. Thank you very much.
Thank you very much, sir, for that wonderful cases. I request, who are the chairpersons for the next? They are the same people. Okay. I request Asif Chidukar for his talk, non-union in upper third tibia severe ONE. Then we have Jugalbandi by Dr. John and Deen Dayalan before they leave. So,
घसरून पडतो तिथे काढ नाही चिकटपट्टी. काढतो काढतो. Good morning, everybody. Thank you for this opportunity, Solapur Trauma Mate, presenting in front of the giants. So, my topic today is dealing with the non-union of stress fractures of the upper tibia in severe osteoarthritis. And how I came about this topic was we have a vibrant WhatsApp society, Solapur Orthopedic Society. I've been posting cases that I've done. And there were multiple questions asked. And that got me thinking, even I did not have many answers for that. So it made me think, it made me create this presentation. And so today it is stress fractures of tibia in severe osteoarthritis, and they land how they land into non-unions and how I go about it. So we all know stress fractures are repeated microtrauma happening over a prolonged period of time. And earlier they were been classified into fatigue fractures and insufficiency fractures. So fatigue fractures when they happen in the normal bone, like the athletes or the military personnel, and insufficiency fractures when they happen, the stress is normal but the bone is abnormal. Now endocrinology has classified this into 4 types: fatigue fractures, insufficiency fractures, atypical fractures like biphosphonates and prolonged proton pump inhibitors, and 4th is the pathological fractures when they happen in infected situation or a tumor-like situation or metastasis causing fractures. And in osteoarthritis what happens is there is a severe varus or valgus which causes asymmetrical loading of one side of the area, and the metaphyseal-diphyseal junction is usually gives way. This can be certainly created due to underlying osteoporosis also. So this is one of the patients who had bilateral upper tibial stress fractures with underlying severe osteoporosis. How do they come to you? They come to you in a delayed manner because there is a lack of suspicion. Pain over the upper third tibia is usually ignored, or it is attributed to arthritis or a degenerated meniscus or a loose body. And many times not ordering long length radiographs is also the culprit. So when you see an X-ray like this, most of the surgeons are thinking about the quality of destruction or the quality of osteolysis, but what can get missed on the lateral view, if you closely look in the center of the picture, it has already started to give way. The treatment earlier was cast and knee. It has got historical importance now, and with more joint replacement surgeons rising, anybody and everybody can come up and say, do a standard total knee arthroplasty, put a long stem, and the matter is over. But when I started digging deeper into this, I realized that the literature has given many options. The first option is the first stage where you do a total knee with a long stem, just like so, or when the patient start presenting late and when the surgeon has matured a little bit and he does a lot of non-union trauma meets in Solapur, you start thinking of treating the non-union like a non-union. Or going forward, many people started saying that the rotational stability is not given many times depending on the location of the fracture, so they started adding plates to it and then throwing the kitchen sink. So let us look at what the different situations are. So if there is an acute mobile stress fracture in severe osteoarthritis and the patient comes to you early, it is reasonably easy to deal with it by putting a long stem, not touching the fracture site, not opening it at all. But when I started looking up the literature, Rashid et al. And Shah et al., they have already mentioned that there is a 15 to 18% chance of non-union when you start dealing by putting a stem for as a blanket treatment for everybody. These are the references for that. And then I could come across one paper which directly compared 62 patients with just putting a long stem as compared with putting a long stem with a proximal fibular resection. Now, most patients which landed up into non-unions were treated only by putting a long stem. What can happen in this situation is the distally tightly fitting stem can distract the fracture site, and one may hope that with walking it can compress, but if that doesn't happen, the patient lands into non-union. And if the patient appears a little late, when the non-union has become stiff, doing a fibulectomy and addressing the fracture non-union on the principles of treating a non-union becomes absolutely mandatory, especially when you're doing a total knee arthroplasty. And then somebody said that direct approach to the fracture site is necessary, and not only that, you should add a plate for rotational stability. But there are again many references that I could pull out where they say that the plate can hinder in compression, and the plate may actually cause delayed union or non-union also. So does that mean that the plates are out? Definitely not. The plates can be used in a situation where the underlying osteoporosis, you are unable to get a good hold putting a stem only, and you can take a posteromedial incision and put a small unicortical plate, try to compress that fracture, and then put a nail inside. So this is what I mean. If you see the lateral X-ray, the stem is not giving good hold, and the fracture is already showing a procurvatum deformity. So a few of the patients that I have done, this is a patient, he's undergoing treatment at the moment. So he came to me within 1 month of this stress fracture situation. So I have gone ahead and put a distal stem. The stem could have been longer, but the neck size that was long would have contributed to problems later on. I had a good fit, and I have made him partial weight bear for three weeks, and after 3 weeks, gradually he will go on to full weight bearing. This is a second case, a similar situation. Swapnil, you had asked whether this short segment fixation works. It definitely works depending on when the patient turns up to you and how the fit is. This is, you can see, the patient has gone ahead and completely united. He came back to me with a fracture shaft of femur. We did his shaft femur, but unfortunately after that he died for cardiac reasons. I could not get his follow-up gait. Now this is another example where bilateral stress fracture. So some surgeon has done a nailing on one side. You can see gross restriction of medial joint line. The patient developed a fracture on the other side also. Now she is convinced that she won't be able to walk with a nailing, so she has not opted for treatment on the right side. The right side has become neglected for over now 8 months. And this is how she comes to me. So the interesting thing is, on the left-hand side, the nail is coming through the lateral compartment. Now in this situation, when you are trying to put a tibial stem along with a prosthesis tibia, it is very important to get the rotation right. And the rotation will be limited by the amount of lateral condyle that is available. So we use these eccentric rods which can align with the tibia. So the rotation on the femur and the tibia gets sorted out by using these eccentric rods. So this is how she came to me. This is a quick video. We did nail removal on the left side first. Right side, because it was mobile, but because it was long standing, I chose to do a standard TKR with a long stem and then opening the fracture site, putting the bone grafts that were available from femur and tibia, and then also doing a fibulectomy. The only decision of contention at that time was whether to add a plate or not to add a plate. Many people, including Dr. Agashe, told me use a plate, but using a plate in this situation was scaring me for soft tissue reasons. To put a nail, I use a figure of 4 position, so that allows me to ensure I can see it on the C-arm and I can ensure that there is no cortical perforation that happens. And this is the stem. I make sure that the cement does not cross the fracture site, use it only for the tibial part. And femur is as standard. Once this is sorted out and once you see that there is a slight gap on the tibia, open the fracture site, debride it, put the bone graft, do a fibulectomy, and left side the nail was removed. This is how she started walking. Then after the insurance cycle was over, she came to me 7 months down the line for the other side. I did the other side also. There was no fibulectomy necessary because the nail had given good stability on that side. And this is the latest gate that I could get for this Solapur trauma meet. And these are her post-operative pictures. Both have gone ahead and united very nicely. So one side I've done a fibulectomy and the other side I've not done a fibulectomy. So to summarize what I have said, if there are extra-articular fractures and if it is an early mobile non-union, just go ahead, do a standard total knee arthroplasty using a long stem and the fracture will go ahead and unite. But if it is a stiff non-union presenting to you late, then there are two options. If you are able to debride bone graft and put a long stem and do a proximal fibular resection and the stem gives you good hold, then don't bother putting a plate. But in certain situations where there is gross osteoporosis and the distal part of the stem fixation, you are not very happy, don't be thinking about taking a posteromedial incision, putting a unicortical plate, achieving compression on the fracture site, and then putting a tibial stem. And I thank you for your attention. Questions?
Objective definition for a non-union in such proximal tibia and arthritic knees.
What is your question?
Is there an objective definition of a non-union? When would you call it a non-union?
So it's a standard textbook definition for non-union.
Nothing specific?
Nothing specific. Nothing specific. So the stem sizes that are available, those sizes are wider than what you get for the tibial nails. So once you get a good tight fit on the distal side, 4 to 5 centimeters, that is sufficient. But it also is dependent on the duration when the patient is coming to you. So it is like a pseudoarthrosis that is being formed. You have to open it, excise, make sure that the debridement is done, do a fibulectomy so that you can achieve compression. So eventually it is going to unite with compression when the patient starts weight bearing and when the stem is stable inside. And if that doesn't help the cause, then obviously there is underlying osteolysis. The distal stem is not giving you good hold. In that situation, take a nick posteromedially, use a unicortical plate and then put a stem. So that will sort out most of the times.
The reason for getting this fracture is the abnormal stress. The moment you get the limb straightened, the fracture unites. The main reason for the stress fracture is actually the walk like this. So the moment the deformity is corrected, because I have done few of these TKRs where there was a cross angulation and there was a stress fracture in the proximal 1/3. The moment you get correction, the stem goes inside, your alignment has improved, the fracture unites. You don't have to bother about anything.
Sir? Just add to that. So I manage stress fractures like this with a suprapatellar nail. I do fibula osteotomy and try to get valgus. At the fracture site, I try to get like a HTO, and I've done 3-4 cases, and all the patients are really happy with that. Basically, removing that chunk of the fibula is the crux of the treatment.
So when they come for arthritis complications, that is the way
They are not ready for anything.
Ashit,
usually this like effect that is that the reason why they don't want to see us?
Probably they have to pay me.
No, the partner.
Question to both Sino and usually they have a posterior defect in the tibia, and when you are putting a long stem, usually you don't get the posterior slope, it is zero slope. Am I right?
It depends on the type of the processes you are using. It is not zero slope always. The way you dictate the slope is looking at the native tibial slope. So not every tibial slope is the same. It varies from 5 degrees to 13 degrees. Usually 7 degrees is what is universally accepted. Now the type of implant that you are using, implant has got inbuilt slope. So depending on the system that you are using, that is the slope you would want to create. So if suppose the next gen system that I use has got an inherent 3 degree slope and I want to achieve a 7 degree slope, then the tibial slope that I would use in the cut would be around 4 degrees. So that 4 plus 3 is going to land into 7 degrees.
It is not a dictum that if you use a
No.
long stem, it is a zero.
No.
Sir, I did quite a few of these. The problem is not so simple. There is a deformity, we have to correct it, and many times there is a malunion also. It can be a non-union or malunion. So the sequential standard operating protocol, my operating protocol is open up the fracture, correct the deformity. Most of the times you'll have to do a tibial tuberosity sparing osteotomy, a step osteotomy. Correct your fracture, use your cuts in the femur to graft the on the...
What is your point? I've already mentioned that. I've used bone graft where it was necessary. If the patient comes to you early, the bone grafting is not necessary.
The point is we have to always supplement with a locking plate.
So that is what I'm saying.
Augmentation with locking plate is mandatory.
Now hear me out. This is your individual expression. I have looked at the literature and the literature says that the using a plate can actually cause hindrance of the fracture uniting. You want compression. The plate can be necessary only in a situation where you have got osteoporosis and the stem is not giving you good hold. In that situation, don't hesitate. Take a small nick, use a unicortical plate, compress the bone and then put a stem. That is what I tried to say.
I ask you one question. What is literature?
Literature is literature. That is what... So I am respecting it, but I am saying where it is necessary and where it is not necessary. That is what I am saying.
I think we've all done lots of stress fractures in
So just a minute,
with the
Dr.
total
Asit
knee
sir,
where we've just
Dr.
used the
Asit
long
Chidukar,
stem.
We would like ask Dr. Damodar sir to felicitate Asit sir.
Oh, okay, sorry.
The next talk we have on non-union lateral condyle by John Mukhopadhyay sir. When John sir speaks on kids fractures, next talk on non-union lateral condyles by Dr. John Mukhopadhyay sir. He's the big boss in kids trauma, especially the elbow. When he speaks on such topics, not even the parents, the kids also get convinced. So, and we have another talk on non-union lateral condyle in the afternoon. We'll skip the last talk, so we have enough time to discuss. So, over to you, sir.
Sir, you wanted to say something about this?
Yeah, so I just said that we've done a lot of stress fractures in the proximal tibia where we've just used a long stem and it's worked. But there are certain situations where you, especially if the deformity is lower down or the fracture is lower down, then you need to plate it. But if it's close to the thing, usually the long stem takes care of it. Yeah.
I have one case where the patient was not affording, so I put a cast for 3 months, means 2 months.
Yeah. So that.
I had primary care after 3 months.
Yeah, so that's you're waiting for the fracture to heal and then doing this thing. So that's another way of dealing with it. Okay, so because if he's already needs a total knee and he's got a stress fracture, then it makes sense to do the knee.
Yes, sir.
Okay. So I think lateral condyle fractures are a mystery to us, and things have changed a bit since we started doing them. Like today, not all these fractures need open reduction and internal fixation. You can treat some of them conservatively, and you can, but then if you treat them conservatively, you need to x-ray them regularly in the first 3 weeks because they can displace even in the cast. And the second thing is this concept of in situ fixation for a lot of these fractures, which early on we would do an open reduction, make sure we've got the articular surface exactly right and fix it. So today, A lot of these sort of late presenting lateral condyles, you just do an in situ fixation percutaneously, and they seem to do just as well clinically. So those are the two things that have changed significantly from the time when we started doing it. But unfortunately, we still see all these problems because they haven't been either diagnosed early or they haven't been treated properly. So one of the problems is the misdiagnosis, and that is still there. Because if you look at this X-ray, this was in a young child, even in retrospect, it's hard to make out a fracture. Okay, but 7 or 8 days later, that's the X-ray. Okay, now you can clearly make out a fracture, and this is what they say is an oblique view, which was done by chance, which is the song oblique view, which you should do in the first place to rule out one of these fractures, which is relatively undisplaced. And there are further classifications of this based on whether the lateral side opens more or the medial side opens more. And those are few things which decide whether you're going to fix them or not. Now, when they come late, okay, they can have a varied presentation. Okay, so they range from near normal to severe disabilities. This is a young child who the original X-ray was that. I think you can make out a fracture on the lateral view there. But he comes 3 weeks later with this position. So what would you do? There's a pediatric surgeon in the panel, so I'll ask him.
So how late is this?
This is just exactly 3 weeks.
3 weeks old, you can definitely go ahead and open reduce and fix it.
Okay. So that's what I would have done at that stage. Okay. Luckily, this patient didn't come to me at this stage. This is him at 6 weeks, and this is him at 3 months when he came to me. Okay, and that was his function at 3 months. Okay, so he's gone on to unite this fracture, and this is what, if this patient had come to me at 3 weeks, I would have said, okay, open reduction is necessary. So we still don't know everything about the lateral condyle fracture, in spite of all the learning and teaching we've done over the years. Okay, now the basic issues that they come to you with are either deformity, instability, pain, ulnar nerve neuropathy, or very rarely stiffness of the elbow. That is one of the rare things, but we've had a few patients where we've actually had to do an arthrolysis. So this is a 17-year-old girl with a tardy ulnar nerve palsy, valgus deformity, but no pain or instability. So what we would do in this case is to deal with the problems, okay? So her problem is the deformity and the tardy ulnar nerve palsy. The non-union does not seem to be causing her a problem. So we went on the ulnar side. You release the ulnar nerve, you do a ulnar nerve neurolysis and an anterior transposition. And then on the same side, because we're already there, you do a closing wedge osteotomy and get the correction of the deformity. Okay, and a little bit of translation which you do to make the axis correct. And that's her at the 14 months follow-up, doing well, full range of motion, and no problems at all at this stage. So her ulnar nerve has also recovered. Rarely you get an ulnar nerve neuropathy without a deformity. This is again a rare situation where if you see this non-union, you can clearly make out, and this is a lateral condyle which has flipped completely. But she came when she was 21 or 22 years old with a tardy ulnar nerve palsy, but no deformity. There's absolutely no valgus deformity that you can make out. So you can get tardy ulnar nerve palsy without a deformity. You can get it more often with a deformity, and this is a rare situation. Again, here all we do is just deal with the ulnar nerve, transpose it, release it, and she goes on to do well. Okay, now, so basically what we have come to learn over the years is that you deal with the problem rather than the x-rays. Okay, so you see what the problem the patient is having, and then deal with that problem. So this 6-year-old girl who came 1 year after the injury, okay, you can make out there's a significant deformity there, or valgus deformity there, and she's got instability, okay? So unfortunately, this video is not playing, but she has got frank instability of that elbow when we examined it, okay? So what we went ahead and did here, what would you do here? We actually went on the lateral side. We took a chunk of tricortical graft, and we put it into that gap there. So once you opened out the gap, freshened the non-union, and then you put in the graft, and then you fix it with these screws across, okay? And so this is the post-op thing. She's got a full range of motion, and that's the immediate post-op X-ray. This is 6 months post-op, and this is 2 years down the line. She's gone on to heal well with a full range of motion and no deformity. So I think here again we are dealing with the problem rather than trying to do just based on the x-rays. So here we've corrected the deformity, we've got the non-union to heal, and she's got a good range of motion. So this is where we've changed somewhat. So this is what we would do earlier. If you had a patient like this presenting to us 6-7 weeks down the line, we would go in, we would do an open reduction. So there's the sort of step that you see in the articular surface. We'd get it exactly aligned properly, we'd fix it, make sure you've got a full range of motion, and then this would go on to heal well. But today what we have realized is we really don't need to do all that. This is another patient who came 6 weeks after the injury. There's a non-union there, but all we do here is just put these screws percutaneously. You just put stab incisions, make sure you put the screws in the right direction, and this again goes on. This is her 2 years down the line. You can see that the fracture is healed and there's no, and she's got a good range of motion. So in this group, which comes to you at about 6 weeks to 3 months, probably a fixation in situ does just as well as an open reduction and internal fixation. And more people are going towards fixation in situ for the relatively less displaced fractures. If it's totally flipped, you have no choice. Okay, so this is a totally flipped lateral condyle who presents to us 5 months since injury. And this is again a difficult situation, because if you look at the literature, they tell you to leave this alone. Okay, but you know that it's going to end up in problems. Okay, there's got some stiffness, some flexion deformity. So here we go in, we go through the lateral approach. There's some debate about whether you should go laterally or posteriorly for these, but we tend to stick with the lateral approach because we like to look at the joint anteriorly. Okay, so that's once we get the reduction of the piece and we fix it with screws. This is him at 14 months down the line, her at 14 months down the line, doing quite well. Okay, another case, 6.5-month-old boy with a 6-month-old injury, lateral condyle. Actually, I have a video of this, but we are not going to go through that. Again, this is 9 months post-op. We did an open reduction, internal fixation, and he went on to do well. I think you have to be careful with these patients. We've got long follow-ups on some of them. Not all of them, most of them are doing well in terms of range of motion. Some of them have the classical fish mouth deformity of an avian of the lateral condyle. So you have to be careful that you do not disturb the vascularity of the lateral condyle when you're doing this surgery. So I think take home, lateral condylar fractures in children have significant long-term sequelae. I think early diagnosis and treatment is essential. However, when they present late, you have to assess carefully the clinical problems and deal with the problems that are there. Consider open reduction and internal fixation in certain situations, but really look at the problem and decide what you need to do. So fixation in situ may be an option, bone graft where necessary, and if they don't have any problems, leave them alone. Thank you very much. Yeah.
So before we take questions for this session, sir, what is your school of thought of to declare it as a non-union, 3 months or 12 weeks or 16 weeks?
So lateral condyle fractures, so that's what I'm saying, this is something that has been evolving for us. Initially, it was one of the few fractures of necessity where you had to fix them. Okay, now things have changed a bit. We do treat them conservatively if they are undisplaced, but if they are displaced, we would fix them, but fix them in situ. Okay.
So non-union per se, lateral condyle doesn't have to be uniting. You can fix the problem, you can forget about the union, and especially you can avoid going intra-articular as well in very late cases.
So if it's relatively undisplaced, you can't fix a totally flipped fragment in situ because...
And even when you open it flipped, you have to stay dead anterolateral. You don't have to dissect more posteriorly to avoid the avian.
Yeah, this is where there are some people, I think the Velo group and Sanjay Swarup in Delhi, they'd like to go posteriorly. But they say that's better, but we've been going laterally all along, and the main thing is to keep the muscle attachment of the lateral, sort of the extensor group to that fragment, keep that intact, and that seems to keep the vascularity. If you end up destroying that, then you are going to get AVN. Yeah. Yeah, sure.
Intra-articular fracture rather than an physeal injury, epiphyseal injury. So, if the intra-articular line is not good, does it get molded in children and they get good results, full function?
So that's what happens. Okay, so a lot of them with what looks like a clear step off in the articular surface in the original X-ray will heal without any problems of motion. Okay, so you have to look at them very differently from what we used to look at them at earlier.
Yeah.
Okay, so we used to fix all of them at one time. The moment you diagnose lateral condyle means internal fixation, open reduction, getting the articular surface exactly right. But over time, what they found is that these patients do well as long as the lateral condyle heals. Okay, so you get that to heal in
So
a
how
reasonable...
can we explain this, that intra-articular fracture with a step and still having full range of movement, no instability?
So
and all
if you
those things?
actually open these, what happens is you find that there is fibrous tissue that forms there, and that gradually gets converted to fibrocartilage. Okay, you don't get articular cartilage obviously, but it gradually gets converted to fibrocartilage over time.
But if it is flipped,
Yeah, flip, then you have no choice.
Then there is no option, you have to go and fix it.
So even if you get them early, you would still try to reduce them. But you can do closed reductions, and you do an arthrogram to check that your reduction is right.
Yeah.
So if they come early, then you still want to get the articular surface. It's when you get them late, over 6 weeks down the line, there the open reduction may cause problems. Okay, so what they found is that if you do a fixation in situ, it seems to do just as well. And that's what's changed over a period of time.
Yes.
Early on, we would go in, we would make sure we've got the articular surface, but that would mean devascularizing that fragment to some extent. And what they found is that you can just put percutaneous screws and do just as well on the long
So
term.
this is an exception to principles of intra-articular fracture where
Exactly,
perfect reduction is the key, as
yeah,
all say. Yes.
it's exactly, it's changed over time, yeah. Thanks.
In fact, sir, staying, not going intra-articular so much so that you can just put an in situ screw. If you want really, if you're not sure about the union, you can put a graft as well with a small incision. Ignore the articular part. It still unites well.
Okay.
But this
is the point which we got from today's discussion.
Yeah, that's if they present late. If they present early, you still want to get reduction.
Basically, take-home message for the non-union lateral condyle. Don't look at the X-ray and treat. Look at the symptoms and accordingly.
Yeah.
So, thank you, John.
Thanks.
Next talk we have on distal femoral non-union by Deen Dayalan sir.
Good morning to all of you. I thank the Solapur team for calling me again. And it has been a pleasurable moment all these 2 days. So this is the last talk that I'm giving. So non-union distal femur. Not moving. So the majority of the distal femur non-unions by now universally all over it has become practice has become uniform. And then like we all know that either it has to be treated by a lateral support when there is a medial contact is good, otherwise you need to have a medial supplementation. So this has been the general principle. So this is one of the patient. So this is the first surgery that has gone in, and then you can see that this has ended up with the non-union. And then obviously the reasons are that there is no good contact or compression. And then of course the lateralization of the shaft makes it like a medial void as well. So that has to be kept in mind. And then this is the second surgery that has gone in, and again you can see that it ended up with the non-union. And at this stage, the question was to how do we establish all these principles that we all talk about in a non-union. So that is the contact and compression, alignment, stability, and then the stimulus, biological stimulus. All these that you need to give has to be established. And once you have to do this, so this is the way I have gone in to do it. And you can see that the more the distal non-union that you get, the medial fibular support would be sufficient. Whereas when it goes on to the metaphyseal diaphyseal junction or above, then you always plating is a good technique to go ahead and do it. And this is what we did. So the medial fibular strut graft, and then establish a bit nice contact. And also in every non-union scenario, we use a Muller's compression device to achieve compression. And then the shaft is something that need to be kept in mind. Never lateralize it, always try to medialize it. And then keep a good medial continuity. And once it is done, then you can see that it slowly goes on to heal well. And this is at 1 year, and then he gets a good function. So this is another patient for whom again the similar scenario where there is a non-union, and you can see that this non-union again, the medial void has to be managed, and that medial void is again managed with the fibular strut graft. And you can see that there is a small graft that is kept between the shaft and the plate, so that you always try to medialize your shaft so that the medial cortical continuity get established, and then you can see that finally it goes on to have a good healing and then a good function. So this is one more patient for whom you can see the similar concept is applied. So again you can see whenever there is a lateralization of the shaft, it also means that your medial continuity is not there. So again you have to do the same principles, and at the end of the same principle, what is important is that medialization or lateralization does not mean that you either push it up too far or too in, but the alignment has to be right. So once you get your alignment right, then it will go on to heal. So all this has to be kept in mind. And again you can see that this is, if there is any splaying of the condyle, again it will result in a medial void, and that also we need to take care. And then once it is taken care, like you have to nicely use a separate screw to get your metaphysis aligned well, so that the circumference of the distal portion at the metaphysis and the circumference at the shaft at the fracture site must match each other. And then when it matches each other, then your situation would become better, and then the alignment, everything can be taken. Actually here there was more posterior void also, for which the fibular strut goes more towards the posterior side, and then you get all these sorted out. So it is the establishment of the medial contact, either by the cortex itself coming together or by the fibular strut graft, and then the alignment you must take care of it. And then once the alignment is taken care, and then the stability and biology can be given to this, and then that is what we have written it up in injury journal, and that is been published as well. And see, like this is a medial void that we always talk about. So and then once it is all these patterns are taken care, there won't be a problem. So as Shiv Shankar has said in the morning, like you will see always that the stress or the flexibility or the strain pattern in such a way that the healing strain pattern would be more on the medial side, that is opposite to the plate. So when there is a void on the medial side, there will be an excessive elasticity, so it will not heal. So make sure that there is a medial cortical continuity, then it would go on to heal, and that is the concept. So if there is a medial void and you are not giving when the void is more towards the diaphyseal areas, it is better to plate it, and that will give a good result. And then this is the solution, 2 types of solutions you have in this, and that is also we have written it up extensively, and this is again one more publication on that part. And so that is algorithm also we have made sure that it is, if there is a medial void of less than 2 centimeter and more than 2 centimeters. Less than 2 centimeter would be a metaphyseal strut would be sufficient, whereas if it is more than 2 centimeters, the plating is needed. So all these like the various ways by which it all goes on to have this non-union scenario to be managed, we have written it up. But if there is an inadequate bone stock of in patients more than 65-year-old, then you will have to think in terms of an arthroplasty also, especially in recalcitrant non-unions. So various ways by which you can treat these non-unions. By far now it is accepted literature, and then also it is universally practiced nowadays, and I thank you for this opportunity. Thank you all.
Thank you, Dina. Be there only, Dina. Since he has leave, any question related to all the talks he has given, we can ask few minutes. Yeah, he wants to go out little. Yeah. So you will have the question. Any question? Bandari sir, you have a question. Asit, anybody?
Sir, because you have to go, this question is on behalf of Bandari sir. He keeps us asking the same question over and over for the last 15 years since I have started practice. Whether one medial ender's nail entered from medial side, tense titanium ender's nail at the index surgery, that is a cause for union or non-union, in your opinion? Please settle this debate for one minute.
No, that means in a distal femur you mean? Sir, no, let me tell you, like, I have also done in few cases, that is only as a mental satisfaction, but there is a good paper, I think Meeraj group has produced a paper where...
Come this side. You prepare the
So they have also published a paper where ender spin is extremely useful in these scenarios. So I think the literature is there where ender spin is useful. So I think we have to accept it. No, sorry, because see, majority of our orthopedic practice is more often it is also individualized. So like, I have my own opinion, or I have my own interpretation, but thing is like, when there is a literature, we always try to respect the literature. So the ender spin is useful in some of these medial void situations, and Meeraj group has published it, so I think we will accept it.
Yeah. So what I want to say is that most of the cases primarily you saw or you showed there was only lateral plate. Adding one pre-bent endus arthritis at tense, going up to the lesser trochanter, it takes hardly 5 minutes. But in at least more than 50% cases, it can serve the purpose and you don't need a second surgery of medial bone grafting and plating. So add that. You are not anyway going to add medial plate on the first day.
Sir,
if you are adding medial plate, that is the best thing. But if you are not going to add, you can add this and see if at all it works. Just like what we were saying about bone marrow injection. You give it, whether it helps or not, it is a small procedure.
Sir, I think there should not be any controversy on this. If your mind feels, you can do it. So there is no problem about it. So, because, we have so many patients we see in our day-to-day this thing. We have seen like bicolumnar plate that we do, we have seen failures. Nail plate, we have seen failures. Ender spin with this thing, we have seen failures. So I can bring in one paper, one X-ray and show the audience that this is not working. That's not true. But literature-wise, if you see it, so many patients and decide, that will be the way we have to look at it. Suppose if Bandari feels that it works, then he must say 100 patients, he must bring in and tell what is the situation.
That's where we are lacking.
That's what. So I think if it is written in literature, we must respect it. So I think it is ender snail definitely is something that you can practice.
Sir, that is more so valid because that point is more so valid because the column is posteromedial. The medial femoral column is posteromedial, and if the fracture extension is a bit higher on the medial side, plating becomes difficult. So in that case scenario, ender's nail on the medial side with the lateral plate at the index surgery is a very good practice.
Sir, I have
And actually,
objection.
we'll accept with that. Actually, it started when Dr. Pradeep Kothare himself suggested me in my first case. I had done lateral plating and I added the tens after about 4 days when we were going to do acetabulum. That time he said you add that and it helped.
Into this,
I think we should
I think
accept
I
it and
remember
leave.
Professor Wheeler in the advanced AO courses, he used to always say that in orthopedics you should never say never.
Never, yeah.
So every individual I think has his own experience. So don't say never, you know.
Okay. On behalf of Solapur Orthopedic Society, I thank Dr. Deen Dayal and I request all of you to give a standing ovation for the knowledge they have shared, and definitely will be much more better treating our next non-union case. So thank you very much, Deena. Yes, you have spent your 2 days with us and we are indebted to you.
Thank you, sir.
Now, the last lecture by Dr. John.
So I'm going to add to this controversy on distal femur fractures because I never use a second plate or a second implant. Almost always there are only very specific indications for me to use a second implant, and that is in periprosthetic fractures where you can't get enough hold from one side, and in some fractures where the posteromedial condyle is totally separate because your plate from the lateral side, your screws go anteriorly, okay, because you have to miss the notch. And so you're not getting a hold on that medial fragment, and that is posteromedial, not medial. If it's medial, your plate can hold it. So comminution is not an indication for a second plate. We've done huge, still, because in a young patient, nothing, just bridge. Okay, and yeah, long plate, use a 13-hole, 14-hole plate, but don't do anything to the...
So you are getting away because you are fixing the ends of the bone.
Absolutely, yeah.
So if it is a short segment and you follow the same philosophy, it will fail.
Yeah, if you use so all our failures are short plates.
Right.
In fact, we've even published on non-unions with a single plate.
Message, yeah.
Okay, without having to use a second plate in every case. There are certain situations, yes, you do need a second plate, but in majority of cases, if you can get adequate compression, you can get a lag screw. So some of these we put a lag screw from the anterior cortex to the posteromedial fragment. So we do that, and we've done a lot of non-unions which we have dealt with a single plate. Of course, the second plate becomes more often necessary. But in fresh fractures, if it is a young patient, the comminution is not an indication for a second plate. Okay, and we can show lots of cases of them just healing with a bridging plate. Okay. The only problem is we don't have plates which are long enough for some of these fractures, where they go really high up, and we ideally need 15, 16 hole plates, and especially if it's a tall patient, so there you have an issue, but they're putting a second plate is difficult, but you can actually pass a MIPO second plate on the medial side as well. Now there's been dissections to show that you can pass it minimally invasive, go right up, go anterior on this thing, and you can avoid the medial circumflex vessels or the femoral vessels there, and you can avoid that and go anteriorly and go on top anteriorly and fix the screws there. So you can do that if you really need to. Okay, so why is the forearm different? We're going to talk about forearm non-unions. One is because there are two bones. You have the superior and inferior radioulnar joints and the interosseous membrane. So a forearm fracture in an adult is considered an articular fracture. Okay, so unlike a lot of these diaphyseal fractures, the forearm fracture is considered an articular fracture, so you need to get perfect reduction in terms of length, rotation, and get perfect alignment as well. So this is a 45-year-old male who was injured in a scooter accident, no comorbidities. That was his original X-ray that he had. Unfortunately, the top bit is blacked out, but you can, and this was what was done. Okay, so anyone from the panel wants to comment on this? You think this is adequate? Okay, so this is obviously inadequate fixation, and unfortunately this one carried on watching this patient over a period of 9 months or 11 months before he came. This is 6 months and this is almost a year before he came to us. Now at this stage, what do you think is the solution or the problem? It's not infected, that's the only good thing about it. Okay, plating, bone grafting, but what is important in these is, see, if you look at the distal radioulnar joint, you need to get that adequately reduced. The proximal is okay, it's not a problem, but you can have dislocations or subluxations in that as well. But what is important is that you get this right. Okay, and these are his clinical pictures when he came, okay? So you can see there's a deformity, okay? He's got some restriction of supination, okay, but his pronation is okay, and he's got this deformity there. So when you're doing this correction, you need to make sure that you get all these right. And unfortunately, I don't have the immediate post-op X-ray, but this is 3 months down the line. So you can see now the distal radioulnar joint is in place. You have to get the radial bow right, and you have to get the ulna. So all the lengths have to get restored. This is him in the follow-up. This is 3 months, 6 months, and this is 2 years post-op. You can see this has gone on to heal well, and he's got a good function with slight restriction of pronation, but full supination, and functionally he's perfectly okay. So he's fine, he's happy, he's got a good range of flexion, extension, wrist motion, etc. Okay, so now this is sorry, what's happened there? That's not, yeah. That was, I was copying and pasting from another presentation, and this is what happens. Okay, this is a 15-year-old boy who fell from a tree. This is an open fracture where we've used the mascale technique, but it was treated elsewhere, and this was the first X-ray that is available to us. So the ulna was nailed, and the radius is in that position, okay? So what do you say? Yeah, okay, those are the proper X-rays. That was the earlier X-ray. This is what he presented to us with. Yeah, so that entire distal block of that radius, except for the articular surface, is sequestrated, okay? So this is what you need to recognize, and this is one of the issues with these distal radius open fractures, where some people advocate that you can just get away with not doing anything to the wound. I think you really need to explore the wound to make sure it's not a more serious wound than you think it is by just looking at that puncture wound that you see. Okay, so this is what, at surgery, you ended up having this large sequestrum which we had to take out. We had to debride it, and we used this antibiotic block. The ulnar side was okay, so although the ulnar length was a bit off, we left the nail because it added to the stability. We did not want to totally destabilize the situation. So this is where we used just a block without fixing the radius because the distal fragment was really small, and we didn't want to put in external fixator pins there. Okay, so this 8 weeks post-op, the wound and sinuses had healed well. There are no local signs of inflammation. ESR and CRP had come down to normal. So the next was the stage of the second stage of the mascale, and the question was how to fix it adequately. Okay, so you had this long segment defect. So what we used was an iliac crest, which we shaped so that it was almost straight. What happened there? And we used this long plate from the LDRS set, okay? So this was the longest plate that we had available, and we used that, and we fixed that. This is him 2 months post-op. You can see how the graft is gradually incorporating. What we also did was we actually excised, did a sleeve resection of the distal ulna because that was long, okay? So now it's down to the correct length, okay? We didn't fix that. This is 6 months post-op. And this is him at 3 years post-op. He's got back a reasonable range of motion. Obviously, there's some restriction of his pronation, but his supination, etc., okay. And a reasonable range of motion at the wrist. Last case, this is a young man in his 30s, forearm fracture came to us about 4 days after the original injury. That was an open injury. You can see the signs of the puncture wound there, but it looked okay. And we went ahead and did an open reduction and internal fixation. So we plated the radius and we plated the ulna, and that was the post-op view there. So any comments on that? This is one of my cases, so don't say bad things about it. Okay, so unfortunately what happened was this, there was infection which persisted, okay? So here we probably did not, so here we left it alone to heal. And interestingly, the radius healed, but the ulna sequestrated. The open wound was on the radial side, but it was the ulna that you had a sequestrum of, and we ended up having to debride that, excise that. We didn't do a masculate. This was a bit earlier, so it was in 2005. So today we would put a cement block there, but we didn't do that. And then we put a crest graft. So you can see the graft there in the middle picture there. Okay? And then we put a graft and we put it plate on that. This, again, you see you have to pay attention to the length and the distal radial ulnar joints. And that was the fixation with the plate. The radius luckily had united, okay? Although there was, and this is him once the fracture's gone on to heal, okay? So that the fracture's now healed well. He's got a reasonable range of motion. He's got good flexion, extension, etc. So I think to take home, non-unions forearm are not always simple. You need to rule out infection. So if there's been a previous fixation, always counsel the patient for infection. You have to pay attention to rotation movement, and you can consider sleeve resection of the distal ulna is an option, especially if you've got gross restriction of pronosupination. I think I'll stop there. Thank you very much, and thank you to Solapur Orthopedic Society for inviting me. This is my last talk, and we have to go to Hyderabad to catch the flight now.
Question. Yeah, Aditya. And Asit, if you have any long-standing question.
Question on non-infected cases, aseptic non-union. Is there any way, do you have a preference of radius first, ulna second, or do you open both and reduce? Second is, to recreate the radial bowing, a lot of people say that fix on the radial side, not on the volar side, because then you don't get the ideal bow. And the DRUJ, at what stage do you assess it? Do you finish the fixation, then look at the DRUJ?
So the questions, one is that we do the simple side first, if you have a choice. We tend to expose both sides before we do the definitive fixation. And the DRUJ we assess at the end of fixation, but obviously if there's an obvious mismatch in length, we would shorten the considered bone and make sure that it comes roughly in the same position and then do the fixation.
So and the radial plating, so do you prefer the...
So I usually go anterolateral with the plate. So I usually go anterolateral, especially if it's more proximal. If it's more distal, then I'll go anterior. Yeah.
Sir, thank you for the presentation. Now, when a surgeon says that I treat both bones like intra-articular fractures, I think that comes from AO school of thought.
Absolutely.
Right. So my question to you is, if at all you are concerned about the radial bow and you can put a radial nail which is small size, which can get the bow, put a plate on the ulnar side because it is subcutaneous, it is easy to fix. That combination, or because you are concerned of rotation, putting a radial nail is not a good idea. Radius rotates all ulna, so put a plate on the radius and put a nail in the ulna. Can we not take advantages of both the procedures rather than calling us proponents of one theory or antagonist of another?
So I think the only situation where I would do that is either you have a gross soft tissue injury and you're worried about not being able to close both the wounds. Okay, so that happens in the forearm fracture if they have a lot of swelling and a lot of soft tissue injury. So you have to be careful about that, or in open fractures. But otherwise, the exposure is pretty simple. I mean, I think once you get used to it, the exposing the radius right up to the radial head is no big deal, and exposing the ulna is not difficult for anybody. So I think you have to just get used to the approach and make sure you find the right planes to go through.
Okay. Probably the, no, no, 1 minute.
So for me, it would be, for a straightforward adult fracture would be fixing both and making sure you get it anatomically right. So I have done nailings, but in open fractures and situations where there's soft tissue, I'm worried about, but not in simple forearm fractures in adults.
Just add to that, don't mix and match. Plate requires absolute stability and nail requires axial collapse. If you put a plate, I have seen more number of non-union. I have done that and I burnt my finger, so I don't do now. Either I put both nails or both plate. So probably the cases where I have one of the fracture which is nailed is gone in non-union is Galeazzi fracture or Montague fracture. It was not an ideal indication, but I have seen that. So I would rather advocate, because my center, Dr. Iyer, has been doing nailing since 1964 and I have seen lot of nailings. For me, nailing is 95% and plating is only 5% of the cases. So with my vast experience of seeing cases over many years, don't mix and match.
So I've seen, I know people who do just simple IM nailing for both radius and ulna, and they seem to get good results. So that's not, I'm not arguing against using the nail at all, but by and large you have to get adequate reduction, get the radial bow right, and you have to make sure you get pronation, supination in a fresh fracture. And for me, the advantage of plating is we start them moving straight away. We don't put them in a cast at all. Yeah.
Sir, what is the, how do you maintain the radial bow if you do the nailing?
See, earlier I was putting thick straight nail LYS and that was making the radius right and pronation, terminal pronation, supination used to be less. But once we started doing tens, we give a proper bend to the nail. So, and also at the end of the surgery, if I operated a left hand of the patient, I give shake hand with the left hand, rotate like this, and also I thump it. If I operated a right hand, I give shake hand with the right hand and rotate and give a thumb. So that makes sure that the serrations in the fracture site will get.
So how many days do you put in?
Slab usually 3 weeks for children and 4 weeks for adults.
Right. Yeah, so that's so we get them moving straight away with the plate.
Would the Talwalkar nail be better than because it has got
it too stiff and it's very difficult to give a curvature to the Talwalkar nail. So I prefer only lambda device. It's a softer K-wire and another one is tense.
So now there's an interlocking nail being developed, a curved interlocking nail
but
being.
But that is having only interlocking at the entry side.
At one side,
but the radius will have entry here and ulna will have entry.
Yeah.
Yeah. Sir, in your presentation, we have seen plate on the radial side. What most of us, even including me, are doing radial plate on molar side. What is your suggestion for us?
So because if it's proximal, you want to put it on the anterolateral lateral side.
Okay.
Because that's where the curve is. So you need to bend the plate and put it on that side.
Right. Okay. Yes, sir. Thank you.
Many times the ulna also has a S-shaped curve.
Sorry? I can't.
Many times ulna also has an S-shaped curve. They are not always straight ulna.
Yeah, so I think the ulna, where it fractures is usually straight. It's the proximal ulna that has got that curve, and there are now anatomical plates designed to deal with that curve along with it. Okay, so the distal part is more or less straight. Okay.
Sir, nowadays we are getting the allograft easily. Is it rational to use allografts in the case of comminuted fractures?
So unfortunately, I don't get allograft easily, so I have not used allograft ever.
Solapur Orthopedic Society has started it.
Yes, he asked me to talk on allografts. I said I've never done an allograft, so I can't talk.
No, we have bone bank here in Solapur, sir.
We have done, we have started it.
So yes, I mean, if you have allograft, so something like a fibular graft, allograft is ideal for that, okay? Because you don't need to, because any surgery, extra surgery you do on a patient has some, and you don't need osteogenic potential for that. Okay, so for the fibula, I would definitely use the allograft if I have access to it. For corticocancellous graft, I would still go for the iliac crest because that's got the best quality. Posterior crest is even better. Yeah.
In a comminuted scenario, if the allografts are available, would it be rational to use in that case in a comminuted scenario, not injuring the patient iliac crest, but if you are accessing easily allografts are available, is it rational to use in a comminuted fracture?
So fresh fractures, I have almost stopped using bone grafts at all. Okay, so I haven't bone grafted a fresh fracture for years. You
It is
bridge, you
comminuted
bridge,
also.
you bridge the comminuted part.
Yes. I think we'll end. The discussion is never ending because that is the reason why we are here still
Yes, sir,
today
yes, sir.
learning. So again, I thank Dr. John
No,
Mukhopadhyay on behalf of Solapur Orthopedic Society.
My pleasure.
for this,
No, no, come on, yeah.
Wonderful
Thank you.
sharing of the knowledge.
Thank you.
Hope you will come back soon here for the next year conference.
Yes, sir.
Thank you very much. Thank you.
Yes. After this session, I think Kakatkar sir is having a lecture.
Kakatkar sir is giving a lecture
Yes.
on metaphyseal non-union because he has to leave.
Yes.
for
After this
Nashik.
lecture, I think most of the faculties are leaving. So
Yeah.
I will like to thank them once again. Thank you, John Mukhopadhyay sir. Thank you, Kakatkar sir. Thank you, Menon sir. And thank you, Chandak sir also. Also, I will like to thank our own Shivshankar sir. Without him, this conference would have been impossible. He has been involved in minute planning of each and every aspect of this conference. Thank you, Swapnil also. Swapnil. Yes. And all members of Solapur Orthopedic Society, there actually we are a single family. Right?
Everybody should clap for themselves, all the Solapur
Yes,
Orthopedic
yes.
Society.
So I have to sort of say that the organization has been exemplary. I think the arrangements were so good that we didn't have to really think about anything. The car was there in the airport with the driver there calling me, etc. That's been, I mean, we've had experiences where you're waiting for the car or the driver is somewhere else and things like that. This was really well managed. Thank you very much.
Sir, the moment the faculty has been decided, the next day,
Yeah,
Shivshankar sir was in the travel office. He himself has booked all the tickets and called me. I had booked all the
and
tickets.
he's also been tracking the flights.
Yes, sir. Yes, sir. Thank you, sir. Thank you, sir.
Well, thank you very much for accommodating my talk a little earlier because I have about 7.5, 8 hours of journey back home. Well, I'm going to talk to you about metaphysical non-unions. These are very challenging situations because the fragments of the metaphysical non-unions are very small and they're very porotic, and it is usually only the cancellous bone which is there. And the muscles which are attached onto these metaphysical areas, they are quite strong. So these muscle forces acting on them are very strong. Another very important point is that if you see a metaphysical non-union, the adjacent joints are usually very stiff. And that becomes a very challenging problem to get a very early mobilization into these joints. The common sites where you'll end up with the metaphysical non-unions is proximal and distal femur, proximal and distal tibia, proximal and distal humerus, and distal radius. I'll try to cover up a couple of cases. These are the basic investigations that you need, that in addition to the X-ray, in some of the cases CT is very important. I'll show you one case. Sometimes an MRI and sometimes these additional investigations like PET CT or technetium scan to rule out any infection into that area. The treatment options are, first priority, at least in young patients, will be osteosynthesis. But in cases where you can't think of doing an osteosynthesis, you have to think in terms of either fusion or orthoplasty. In an aseptic non-union, you try to achieve good reduction of the fragments, try to get good alignment, try to get good contact and compression, achieve a stable fixation, and try to get all these CAS principles that we have been discussing for last 2 days. So by either bone marrow injection or bone grafting or by doing corticotomy or by electrical or ultrasonic stimulation as it was shown yesterday, you try to improve the stimulation. Some cases, this was a 47-year male, had a comminuted fracture like this. The first surgeon tried to get the best possible reduction, and this is how it was fixed. He continued doing movements. At the end of 8 months, there was an excessive collapse, and you can still see a gap there. At the end of 11 months, the implant failed. And I was involved in the management at this stage. What I could see was that the neck femur part is not showing union, and there is a gap superiorly as well as inferiorly. So we decided to revise it. I changed the screw, keeping the same track. I just put a guide wire inside, put a shorter screw, and then we made a trough on top of that nail, wherein we put a Aliacrest lever to fill up this particular gap, and used another plate and fixed it. This was, in addition, we put grafts on the medial and inferior side as well as in this gap also. And this was at the end of 2 months, this was at the end of 3 months. You can see that this has started filling up. And this was at the end of 1 year. He had complete recovery of his fracture, and this was his function. This is 28-year male. This was an 8 months old injury. This was originally infected non-union. He came to us with this kind of situation. This young fellow had additional brachial plexus injury, and he was going through a tough time because of his prolonged illness. Young married life, his wife decided to divorce him. Then we put him on an Elizaro fixator. We tried to distract and then compress, do accordion maneuver to get the union. We kept the fixator for 1.5 years, but we were not able to see any attempt of healing. So the Elizaro fixator was removed and he was put in a plaster cast, because by that time the pins had started showing some pin track infection. At the end of 3 months after the removal of the fixator, once we removed the plaster, we realized that he has still no attempt of union at all. But luckily the infection part had completely settled down. So after talking to him, we discussed in detail, and then we said that by that time he was quite fed up, and psychologically also he was disturbed. So similar kind of a thing which I showed in my first case presentations, we did distraction with a femoral distractor. We put a intramedullary fibula as a strut, put plenty of iliac-crest graft, and by that time the antibiotic-coated implants were available. So the antibiotic-coated plate as well as antibiotic-coated screws we have used in this patient, and then we put this particular patient on this implant. This is at the end of 6 months, he started showing good union. And I just talked to him, it's about now 5 years. He stays in Banaras and he has his own factory and is doing some business there now. So he sent these pictures to me in the last week that he is doing all his work, and this is his picture. And he has sent these pictures just in the last week to me from Banaras. This is a male, 40 years, 6 months old injury. The patient came to me with this kind of a situation. We just changed the implant. You can see it had gone in complete varus. So we put a valgus reduction and converted it to DHS and put bone grafts, and in 3 months it started showing union. At 18 months there was a complete union, and this is his function. This was a 61-year female, proximal humerus. You can see there was a complete non-union. This was an 8 months old injury. She had multiple comorbidities, uncontrolled diabetes for 10 years, hypertensive, on irregular medications and severe osteoporosis. We did her DEXA, the T-score was minus 3.5. And this was frank mobility in adduction abduction. So we decided to do her fixation, and after controlling her sugar, intramedullary fibula with the same device, I went inside first, we put a K-wire here, got the valgus reduction, and we pushed the fibula inside into the head, then put iliac crest grafts around and put a Philos plate. We put her on teriparatide plus vitamin D, calcium supplements. At the end of 6 months, this was healing well, and this was her function at the end of 6 months. Another 60-year male, this was a distal humerus fracture. He had an old fracture of the proximal ulna which was already fixed outside. Very obese patients, hypertensive, diabetic. This was how the fixation was done outside, and he came to me with this kind of a situation. Similar one which I showed in the early morning in the first case of lower end of humerus. These recon plates used for the lower end of humerus is a day one failure, They always break within a very short time, just in few weeks. So this is how it came at the end of 3 months. All the fragments were floating, the implants were floating. So we went in, revised anatomical plates with bone grafts, and at the end of 8 months, complete union and excellent function. So these metaphyseal non-unions, they are challenging situations. This was a 52-year male. He had a fracture like this, which was fixed in 2015 by some surgeon. It went into non-union. The patient was managing with this, and he was driving his motorbike along with this particular thing. He was a farmer. The implants were removed, and for 9 years, he was moving around with this. At the end of 9 years, he had an accident, and he landed up with this situation. So this was in 2015. I could get his old X-ray. When he came to us in March 24, this was after his second injury. So, just, yeah. No, it has stopped moving. So looking at this scenario, to take a decision, I thought the CT is very important, because what movement he was doing all these years was from his non-union. So we wanted to know the status of his joint. And when we got the CT done, you realize that there is no joint space left. So achieving any movement by doing osteosynthesis was out of question. So the choice was given to him whether he wants to get a fusion. He said, no, I have been driving my motorbike, doing all my farming work, so I want movements. Then we counseled him, and we decided that we will think of doing a replacement. So we contacted the company who manufactures the tumor prosthesis. We excised the lower end of the humerus and did a tumor prosthesis for him. And this is his clinical photographs which he sent me just in the last week. He has got this kind of a function at the end of 1.5 years. So in situations, wherein you have no joint mobility possible, you can think of doing a prosthesis like this. This is a 65-year male shaft tibia fracture. This was fixed with a nail, and you can see this is practically a day one failure. He landed up with me at this stage, where you can see that there is a movement taking place here, and there was a gap, no attempt of union at the end of 6 months. So we decided to revise it. Some implants had already broken, so we left them there, put bone grafts, and at the end of 1 year, this was his function. This is 63-year male, road traffic accident, bad plafond injury, compound, was treated by the first surgeon. He put a nail into the fibula and fixed to get the alignment. But after 2.5 months, he removed the fixator and the patient was put in a plaster and left like this. Came to me at the end of 9 months in this kind of a situation. So a non-union at this site with comminution. Luckily, there was no infection. So we planned to put a fibula, reconstructed the medial side, put some grafts here, removed the nail, we osteotomized the fibula to get the alignment of tibia fibula, get the length of medial and the lateral malleolus right, and at the end of 10 months, this is his union, and this is at the end of 13 months, and this is his function. So the take-home message is, as the metaphyseal non-unions, they have very small fragments and very porotic bones. You have to plan your surgery properly. You should aim to achieve a stable fixation and early mobilization without compromising the stability. Because many times, if the joint has become stiff, you try to mobilize them early and you find that the implants have started walking out. So you have to find a balance between the mobilization and compromising on the stability. And if the situation is that the adjacent joint is not salvageable and not going to be mobile, then you have to think in terms of either a fusion or a replacement. I thank you very much for the patient listening and the opportunity to be with you in this excellent academic meeting. I think coming to Solapur for academic meeting has been always a pleasure, and I look forward to be associated with them in future as and when they have any academic activity. I thank you very much for inviting me again, Shiva and Pradeep and Swapnil and the members of SOS. Thank you very much.
I would request Samaram sir to please honor the chairpersons. We'll have a short tea break of 10 minutes.
Vertical.
This is absolutely.
Yeah, you can start from the trochanter like angle blade and plate and go into the inferior surface and fix it, whether it is possible.
Possible, why not? But then angle blade plate is not, so you will have to put screws.
Yeah,
Screws. So thing is, any screw you put from this region usually is wobbly, does not have a purchase on the lateral cortex. So you need to have screw purchase even if you want to do an intracapsular fixation with 2 screws. The typical thing about this fracture is it heals well.
It's like a transit.
Yeah, you can put like this.
Sir, one thing, before the era of interlocking nailing, if there is a fracture of ipsilateral IT or neck with shaft, we used to put a K nail and pass the 2 missing the nail. You had to pass 2 screws, one above and below. So that could have been done in
all the options, all the options were there. Now, since that has already happened, now what? Now, this is the CT done as patient had persistent pain, and this is now the X-ray at presentation. Now, there was a question yesterday, when to put fibula and when not to put fibula. So after experiencing fibula use in more than 45 patients of intercapsular late presentations or non-union, So wherever there is a void, so this was on table traction. Once we remove the implant, this is 8 months down the line post-injury. So a very vertical fracture. Very vertical, so much it is Powell's grade 3 and beyond. Not even vertical, it is beyond that. So I'll just finish up in this case fast. So whenever we revise this intracapsular non-unions which are delayed presentation, your lower DHS screw has to be low. It is not center, because if you take center, then you cannot put something above. So put your first screw lower down. There was retroversion. Mind well, retroversion is one negative thing for intracapsular result. So never accept a retroversion. Most of the non-unions of intracapsular neck femur either are retroverted or not reduced properly. And 50% of them are retroverted. Retroversion is not uncommon. This typically happens because of posterior combination. Combination, most commonly. And therefore you need to put a posterior screw now as a positional screw, which is non-compressing and fully threaded. And therefore that philosophy is more useful. So this was revised with a DHS CC and a osteotomy. So osteotomy nowadays you need not have a gross vulgarization so that you don't develop a AVN, and that healed well. And we used fibula to fill up that void in the superior part. So anteriorly there is a screw and posteriorly there is a split fibula, and that healed well. This patient healed well without any problem, and we removed the screw. So just answering that yesterday's question, when to use fibula and how to use fibula, some experiences. So this is a patient, as you can see, this is almost 8 to 9 months. You see a large amount of void here. For all those newcomers in the orthopedic field, orthoplasty is a very good option, fantastic option. But if the patient is not willing, and this was a farmer, so look at the field. So this is all void. Now if anything you want to have a good purchase here, plain internal fixation would not suffice. So put a fibula. 3 things it does. The beauty of fibular use is it leads to spot welding. So as you remember, whenever you take 2 iron bars, the first thing a welder does is he does 2 or 3 spot welds. So spot welding is what a fibula does. So by the time before union happens in the neck femur, the fibula gets spot welding at 2 or 3 times. This happens because of the rough surface of the fibula. It entangles that part, avoids rotation, and therefore fibular use has been widely successful. Now if you have, and this was healed, this patient healed very nicely. So that X-ray, and look at this X-ray, the fibula and the superior part of neck develops a good bone, and this was 5 years and this is almost now 25 years, and that farmer is still working in the farm, healed well. Now remember this diagram. Now you are putting a DHS in the lower sector. Superiorly there is only this much amount of space. So if your fibula goes and impels this out, it's not good. So you not, so always this would be the diagram. So DHS, here is where is the fibula, and 1 cc screw additionally. So you need to have a space for fibula. Now if you have space, use full fibula. If you do not have enough space, if the head sector is small or a female, less than 5 feet height, then the space available is minimum. So bevel that part. So this you can bevel out. Or a patient who has post-polio paralysis, his head is small, then also bevel this fibula. So use a split fibula. So yesterday Dr. Kakatkar was telling about the SP nail starter. This is a wonderful device. If you can look at this device, this is a wonderful device. It is exactly mimicking the shape of fibula. So that path can be created by SP nail starter. This is still available with so many old vendors of orthopedics. So you can split fibula, just gently bevel that end. What it does is, it does not lead to distraction. So it goes and stucks up in the femoral head. And these are the few tips. So you can use a split fibula, especially one very advantageous situation is it doesn't allow collapse. So it leads to good healing, void is healed, it also leads to spot welding, and almost union is ensured. Whether AVN happens or not, it's a different. Yeah, I'm
It has got intertang effect.
Yes, it has got an intertine effect. Yeah. So I'll just finish up this because the topic was different. By the time everyone joined, we just. So it makes sense if you are operating a neck femur non-union, same side fibula you use.
Yeah.
For harvesting, it is easier.
No, so whether it delays your weight bearing or something like that because you are removing such a large.
The removal of fibula in an intact tibia is almost no problem.
So it does not.
And
Bhandari sir,
preferably.
question answer later on. We're already running
Yeah,
late.
yeah, yeah.
He has to start his talk. Please.
Sorry. Yeah, please connect. So my talk is on RIA grafting, that is reamer, irrigator, aspirator. So look at the diagram. So this is the RIA device. One channel is leading to saline inflow inside. There is a reamer which is rotating inside the femoral medullary canal, and all these reamings are connected through the tubing into the jar which collects all these reamings. So we always wondered what is the indication for RIA reaming. So this patient had almost 8 to 9 surgeries, continued to discharge, but as you look at here, the surgeon did not had courage to remove the whole necrotic segment. Multiple surgeries, debridement went on, did not heal. Once you removed the whole necrotic segment, then only the infection subsided, and now we had a long segment, more than 7 to 8 inches. For how to take this much amount of graft, RIA provides you an easy solution. So we always wondered if you can utilize this reamings. We always get reamings onto the reamer, and same principle is being utilized in reamer, irrigator, aspirator device. And this is what is the reamings we collect from device. So these are the cases which are the indicated cases where a long segment loss is there, or you have a bad infection and you have a whole sequestrum, and then when you want to reconstruct them, you need large volume of bone graft. So these are the cases where we would use RIA reamings. This is how much amount of reamings you draw from the reamed device. So whenever you need a very large volume graft, this is a RIA good device. It effectively sizes the medullary canal. There are multiple uses of RIA reaming system, known as RIA in short. So you can size the canal. It's a very sharp reamer. So if you have a medullary cavity which is narrower, you can size it bigger. Secondly, it can clear the medullary canal of marrow, reamings and debris, very useful in infected non-unions, and also it can give you graft. So these are three main indications for RIA bone graft. So if a patient has a fat embolism syndrome and you still want to carry out the interlock nailing, this is one device which is to look forward to, because it would not allow further embolization. It removes, it does not pressurize the medullary cavity. So rim or not to rim is many a times questioned in certain difficult scenarios, but if you rim with RIA reamers, the disadvantages of rimming are not there. So since there is good amount of volume of fluid also going in, it does not lead to thermal necrosis. This is another advantage of RIA reamer. So this is how the RIA works. So prerequisite, we measure the canal and size the femoral canal. If it is say 12 mm, you need a reamer head of 13.5. Contraindications, bleeding disorder, obviously you are not going to use it because it would lead to a lot of bleeding. Blocked canal with a previous metal, metabolic bone disease and active metastatic disease. These are the contraindications. The gold standard all of us have is Ilecres bone graft. The problem is the limited amount of size, and therefore this is important. RIA graft, they are autograft and they are osteoinductive. If you want osteoconductive as well, you can get fibula or Ilecres in addition. The concept essentially has a medullary canal reaming enhanced with irrigation and aspiration. So the RIA reamers inside, there is a irrigating fluid which is in front. This is how the device is. So these are the disposables. Every time we need a different reamer head. So this is the reamer head sizes. Minimum available is 12 mm and they are up to even 19 mm. The western medullary canals are quite good. The procedure is simple. You just select the rimming sizes of reamers and take one of the two sizes, whatever. We usually have purchased only long one, and this is how it attaches.
Into the tube assembly. The fingers on the reamer head flex as they are inserted, then spring back to secure the reamer head to the tube assembly. Into the tube assembly.
So this is how it attaches.
The reamer head flex as
This is attachment. You understand the mechanism of flow and tubing attachment. Once that is done, connect irrigation, connect suction. So this is connecting the aspiration. Trolley is set now ready. So you insert the guide wire. On the guide wire, you insert the assembly. Your aim is to rim absolutely going up to the distal end so that you get maximum amount of rear rimmings. Avoid hitting the medial cortex, otherwise the reamer would eccentrically rim. So you have to avoid this. Use drill function rather than reamer function. So this is how you start rimming.
gradual advance retract technique. Advance the assembly until resistance is felt. Then repeat.
And
when reaming to the intended depth is complete, withdraw the rear assembly from the canal and stop irrigation.
so this is the technique we otherwise also use for any reaming. And this is those who want to have a good reaming technique, go forward, come back a bit, go forward, so that you are not over generating the heat. This is usually, this is the flow of reamings. So you are, so this is how the reaming happens. So these are the reamers. Mind well, since you are aspirating from the medullary cavity, hypotension can happen. So watch for it. 1 or 2 units of transfusions are to be kept ready. So this is now the whole procedure being completed. Now the amount of reaming. Look at the diagram. This is the amount of reaming which is happening inside. So a cortex which is good thick is the best source, and in adults that is no problem. Very elderly you would avoid it. You have to go up to distal end. If you want to increase from 60 cc to 80 cc, one more guide wire and you can ream extra also. So how it looks post-operatively, just have a look on the picture. This is the reamings. So routinely when you ream a femur, you don't see any void. But since you are removing bone, you will be seeing voids here. And if it has gone for eccentric, as this is a picture, if eccentric reaming happens, then that is something which can lead to a stress fracture in the future follow-up. So this is what is to be avoided. So this is the reaming jar which is full. You remove the graft, and this was a patient, 2 or 3 cases I will just see. So whole necrotic segment removed. This is the amount of loss. Cross leg flap, and this is the cross leg flap now is with antibiotics bone cement spacer. Spacer removed. This is the large cavity. You fill the reamings. So once you fill the reamings, the next day itself you feel that whole column is now built up. This is immediate next day. The reamings look like this. So once this is there, good incorporation. In the follow-up, this patient had a stress fracture because this was a long column, as you can see here. So that can be done with a MIPO plate. So they may be protected. So this is how the leg is. The advantage with fragment transport of Elizarov is, since you are not fragment transporting, the equinus which happens very commonly with Elizarov technique is not happening in rear reaming. So that is one good advantage. So these are a few cases where large grafts were needed. I will just go on showing the post-operative picture. So when you have a large segment which is exposed, again this is a good technique. So this was a patient with LRS we have done, and this is the graft. So immediate next day, even large segment can be reconstituted, and they do not gravitate down. They remain there in the tubings. So this is how the rear reaming is happening. So I'll just take up the last case. This is a patient who had an accident, as you can see on the road traffic side. The whole bone was ejected out. So the whole distal femur was ejected out, and there was a large amount of bone loss. So split fibula and rear rimmings, and they can be kept. This patient had multiple surgeries. So again, nail, a bad infection, the whole segment loss. You can see the amount of debridement we can do, that everything was removed, and a whole large segment can be reconstructed with rear rimmings. So this is how the reconstruction went. And so in last, I would like to summarize is, so it's a large volume graft source, 1. 2, it does not lead to embolization. 3, can be used in infected scenario also. These are the main advantages of rear rimmings. I will stop here for some questions if they are there.
Dr.
Since we are running
Chandak,
time. Yeah.
is there any Indian jugaad available for this rear rimming?
So far not. Nobody has done it. The other company which has also come out with this is Zimmer, which has a device available, but I don't know yet any Indian jugaad available for this. But I think it can be done.
Second thing, in the fresh cases it is quite okay. But
Dr.
in the-
Vaibhav, question answer session is at the end of the session, please.
Okay.
This is something different.
something
talk, that's
related
why,
to this.
yeah. It
This
can
is
be
something
taken
related to
in.
this,
Yeah.
so that we can
Yeah.
be in the same flow. Second question is, this is okay in
Let's
the
respect
fresh
the
case.
opinion of
Let
the
us-
chairperson.
Chairperson say
Yeah.
later on. Yeah.
Thank
Thank you so much.
Chandak sir. So we are going to the next talk, which is on metaphysical non-union by Dr. V.R. Kakat.
That's over.
Okay, so there is
Pradeep
a slight
Patil.
change in the sequence. Now Dr. Pradeep Patil, I am requesting him to talk on handling humorous non-union, a challenge.
Thank you.
डायरेक्ट बारावीच करायचं याला काय आपण इथं डायरेक्ट बारावीच करायचं आपल्याकडे एखादी काही अडकलं बिडकलं आपण हळूहळू करतो तेव्हा तर खडखड खडखड करतो इथं इथं तुम्ही लहानाने केलं का सगळं निघून जाईल का करायचं
So thank you SOS for giving me the opportunity to share my views. So handling the humorous non-union. So most of the humorous non-topic has been extensively covered in the previous lectures also. So basically humorous non-unions are of 4 types. Firstly, after the failure of conservative treatment, such non-unions are very rare now. Another are after failure of plates, then another do the failure of nails, and last is infected non-union. So I will be covering this in 4 subsets. So basically we should have, in every humorous non-union, we should ask 3 questions to ourselves. The first and the foremost is why this fracture is not united. So when you look at the non-union X-ray, you should ask yourself, is there any mechanical failure, is there any biological failure, or is there any extrinsic causes like diabetes or osteoporosis. Second thing, how to treat, what is your plan depending on the cause of the non-union. If there is a lack of biology or infection or in a change in the fixation modality. So you have to think accordingly. And lastly, the most important, what are the patient demands? Is your surgery is going to benefit to the patient, and is there any backup plan? Something goes wrong in the surgery, what is your backup plan? So everything should be ready while doing a humorous non-union. So as usual, you should know condition of the radial nerve is very important. Elbow and shoulder movement, soft tissue condition, presence of. So these 4 things you should always evaluate before surgery. Fixation modality mostly commonly used are the DCP, nails and excellent fixators. Nails and excellent fixators are very rarely used. In case of a long-standing non-union, so nails does not give full rotational and axial stability. So usually the nails are not preferred in a long-standing non-union. And in osteoporosis, usually you have to use a long plate. Sometimes you have to supplement with the intramedullary graft. You add a new plate. Sometimes you add with a cement augmentation or use of LCP. And the commonly used approaches are anterolateral and posterolateral. But when I go through the literature, it is said that for non-union, anterolateral approach is the best, because you get an extensive humerus to plate. Second thing, your radial nerve doesn't come in the way. Only in the distal portion you have to isolate the radial nerve. But sometimes it becomes very difficult in a non-union where the posterior plating is done. So in these cases you have to go for the posteriorly. And if you are going posteriorly, the most important thing, don't dissect the nerve at the non-union site. Dissect more proximally and then gradually dissect. And always tell the patient, if you are approaching posteriorly, there are chances that you may have a neuropraxia or a radial nerve palsy. Maybe there are chances of palsy. Then, as if you go all the cases of non-union, the most common, most of the humerus non-union can be preventable. The first important cause is the use of improper fixation techniques, means improper reduction, not using the principle correctly. Seconding the wrong technique, means using a wrong implant at the wrong side. Some of the cases, if you consider this a fracture shaft humerus, there is a big butterfly fragment which is outside, it is not connected to the main bone. So here your interlocking may not work. In these cases, you have to go inside, reduce the fragment correctly and fix it. In some cases, there is extensive comminution. You can use a long plate, but something in such cases, you can also use a biological plating. In cases where whenever there is an open fracture, instead of going plating, if you simply nail it, it becomes very good. So select the case of a humerus, not the techniques which you know, which is, you select the techniques which fits for that surgery. So some of the cases, non-union after failed osteosynthesis. So look at this case. This case, there is a fixed distraction at the fracture site. It is not properly fixed. So this is going to fail. So in this case, the cause of a non-union is improper fixation. So, and what happened to this patient? This patient went to another surgeon. He tried, if nail works, I don't know what happened. He removed the plate and put nails. So this is definitely going to fail it. Then at this time he consulted me. That was his first picture. So I suggested him the surgery, but he doesn't turn up. He went to another surgeon. He removed the nail and it was a frank non-union. So again he referred to me. Then this, so I opened the fracture from the back side, then excised the bone fragment, put the fibula inside, use a long plate, metaphyseal plate. This was the size of fibula, and whenever you are using a fibula, try to fix the fibula in either 1 or 2 cortices. It gives good stability. This was his post-operative picture, and this was a follow-up X-ray. She is united very well, and these are her range of movement instead of having rotator cuff injury also. So another case, intramedullary nailing after failed nailing. So this is humerus fracture. This was not nailed properly. This is going to fail. This was his picture. So in a case of a non-union after nailing, while using an implant, you should try to fix a plate beyond the humerus, beyond the distal interlocking hole, because this is a potentially weaker area. So this CT was done as it was a non-union. So in this case, I have done in a single setting in the lateral position so that I can remove the implant and put the plate from the back side and also take the graft. So this is how we remove the nail, fix the plate, and this was a non-union, and again excise the bone with the saw, then put the intramedullary fibular graft, and here I use the pointed clamp to have a compression at the fracture site, and this went on union. So another case of non-union, same fibular graft here, as it is an oblique fracture. So I used a interfragmentary screw passing from the fibula also, then fixed with the plate, and united very well. So another subset of cases of non-union is infected non-union. So this is a case where the patient was treated with the plating, got infected, and the primary surgeon put a beads, and the patient presented to me with the help of with the history of a discharging sinus. So initially it is in humerus non-union infected, the stage approach is very important. So initially you go inside, do the proper debridement, and put a temporary fixator either in the form of intramedullary nail or external fixator. Sometimes in humerus it is always not possible to put a vancomycin rod. In some cases I simply put a rush rod and fix it. So as it was done previously, I push. Here in this case I am able to put an intramedullary antibiotic coated rod. So and then later on it is revised with the help of open reduction internal fixation with the plate, and this went on healing, and this was his range of movement at the end of 1 year. So another case, humerus non same presented with the infection. So in this case I am not able to pass a antibiotic coated rod. So fixed with the intramedullary nail, debrided properly and augmented with the external fixator to prevent any mobility, and revised later on with the help of a long plate, and he went on union very well. So some of the other cases were done around 20 years back when I started practice at Solapur. So this was a non-union, very long non-union 70-year male. So at that I don't have any option, but I made a shorter nail from Yogeshwar and used, and luckily that got united. So that is again another case, humerus non-union, done in 2009. So here the two rods were passed and the patient was having radial nerve palsy. But when I explored, you can find the radial nerves were actually into the fracture. So I had done a reduction, the plastic surgeon done the cable grafting, and the patient went on union. So regarding the post-op protocol, you have to protect for a longer time. You can start mobilization as the patient, you can see the union at the union in the follow-up X-rays. Important thing about the removal, if there is a specific indication, then try to remove the implant. If there are no any complaints from the patient, don't try to remove the implant. So in conclusion, in all cases of humerus non-union, think always what is the cause of a non-union, then what are the fixation method available for that non-union, supplement with the graft, intramedullary as well as a iliac cancellous bone graft, and always evaluate the patient demands. Thank you.
Thank you, Dr. Pradeep Patel. May I request Dr. Raut sir to please felicitate Dr. Pradeep Patel. He is going to leave now. Dr. Milind Joshi, ready on the top? Gap non-union.
So, open कर की दादा. So, तिथं काय दिसेना की. So, still, I think it's good morning, or it is past 12. Okay, so we know that generally the gaps, we have seen n number of cases. I'm going to just show 3 cases. In femur, the various techniques which one can use to bridge the gap is, in femur we generally use a muscular technique, and it doesn't mean that you won't use Elizarov, but then, and in tibia, Elizarov is definitely useful, is more useful. The other techniques which have been talked about, just now Dr. Chandak sir showed us how to use RIA grafts in a long defect. Then yesterday Dr. John sir showed us the tibialization of fibula. So this, I am just going to share 3 cases. This was a young male, and I was involved after 6 weeks of the treatment, which was initially done by a orthopedic surgeon and a plastic surgeon. It was a grade 3C compound segmental fracture of right tibia, and they had done debridement, an external fixator was applied, a local transposition flap was done, and a segment of bone was excised. And so you can see that this was the comminution. The surgeon had removed the middle piece of bone, and then that's the clinical picture in fact, and then he removed that middle piece of bone. The story is at the end of 6 weeks, he had applied Elivero fixator, but then he involved me what is to be done. So I entered at this particular moment, and I realized that acute docking was just not possible in this case. Because the skin was cicatrized, there was a rotational flap done over there, then I had a limitation of how much fibula I could get. The problem was I could get only this much fibula because I did not take a separate incision for fibula harvesting. And then I use a antibiotic cement spacer inside, and this is how I could get alignment. Now, if you carefully see in the lateral view, in the lateral pointer, so in the lateral view, you can see that I had to take the distal fragment way posteriorly so as to be able to close the skin. Otherwise, it was not possible to close the skin. And then, so a fibula, the distal end was put in the medullary canal of the distal fragment, and a cement spacer was kept. At the same time, I did a corticotomy above because it was an infected scenario and I wanted vascularity to improve also, and I had shortened it. Some docking I was able to do. It's not moving forward. Yes. Okay. So after 6 weeks, what I did was I disengaged the entire frame. I passed the wires through the fibula, and I started taking that fibula, started taking it anteriorly. You can see that with the translation device, this is being pushed forwards. And then I removed the fibula, I had removed the spacer, put in fibula, removed the spacer, and put in iliac crest graft as well as allograft over there. Then when it was aligned properly, then the distraction continued, and this is how the cross union also took place. This was a 5-ring construct. In fact, you can see that when you have put fibula inside, it takes very long time for it to consolidate. Therefore, what I did was because it was fairly or largely consolidated, I removed this 5-ring construct and converted it into a 3-ring construct because it was it is always more cumbersome for the patient, and it was too early to allow him unprotected weight bearing. So he was quite comfortable with the 3-ring construct. So that is how he went on to heal. So this is him after that 5-ring construct into a 3-ring construct. So this is how he united. These are his clinical pictures, and at the end, this is his walking video. So another case, this is a straightforward case of pathological fracture with a sequestered ulna, which was the spacer masculae was used, and then we harvested a ulna. This we have, all of us have seen enough number of cases. After 2 years, I have been able to remove this K-wire also. Now, this is my last case. This was a young male who was treated initially in a government hospital and with a uniplanar fixator. Then when the wound was still, there was infection, a surgeon did a nailing and he put antibiotic beads there. Then when it was not uniting, he dynamized it. And finally, because of persistent infection, it was something like an atrophic non-union. So when he presented to me, the picture was like that. He had a discharging sinus with a scar, a very bad scar. So I removed that nail and opened it. And you can see that when I did my complete debridement, this was the picture. And then I had to take a incision on the lateral side so as to be able to close this particular thing. So the nail was removed. This is how I could achieve this closure, but I wasn't happy with this, and this raw area split thickness graft was put. But when I when I showed this to my plastic surgeon, he said that you can't, this scar is also really not good to go in again. So what we did was we went in again. He harvested we counseled the patient properly that this is a lengthy procedure and we want a good soft tissue cover. Therefore, we put a spacer over there and a cross-leg flap was done. And then this is the patient, this is after division of the cross-leg flap. Then after 6 weeks, we went in again and introduced a fibula there and corticocancellous grafts. So now this again is again a corticotomy was also done there. And so this, because I had removed fibula, he was going in valgus. So I believe that when you remove lateral structures, they tend to go in definitely valgus. So I tried to correct it. I was successful in partially correcting it also. So this is him walking with that firing construct. Here also what I did was once he was fine and united to a large extent, this is one way of dynamizing. So I changed it from a 5-ring construct to a 3-ring construct. There was no abnormal mobility on table, but I just wanted to protect him, and then he went on to heal properly. He could join his work also with this, and then this is his final union. There is a mild valgus because of loss of lateral structures and contracted scars. So he sent me this walking video. Thank you.
Thank you, Dr. Milling. Would you like to give another talk also this time?
Oh, no problem.
Nail plate fixation
Yeah.
in continuity.
So we have been hearing about the combination of nail and plate. So we generally, so it is said, Dr. Babulkar, Sushrut Babulkar says that you use best from both the worlds. The nail provides you an axial stability and the plate provides you rotational stability. So whenever it's especially in junctional fractures, this is more important. So because there are high stresses, and we all know that in the proximal tibia, distal femur, the medullary canal becomes funnel shaped and the rotational stability is not adequate when you use, even if you use multi-lock nails. So in a case of non-union scenario, when it's not only the biology matters, the absolute stability definitely is required, and you exploit the synergistic effect of this. So we'll directly come to certain cases. This was a middle-aged lady who reported to me. This was a closed, uninfected non-union. She reported to me after 18 months. Now, we don't need to dig out what is wrong, but then I explained her that there could be infection inside, though her parameters were normal. So what I did was, obviously the implant had to be out. I opened it, did removal of the sclerotic ends, shingling, bone grafting, then put a nail from above, locked the nail proximally, put a derotation plate, put a derotation plate, and then use a Muller's compression device to compress the non-union, and then I added a plate. Then I did the distal interlocking. So after compressing the fracture, I did the distal interlocking. So you can say that this is the iron lady, and this went on to unite nicely. This is completely consolidated. I had to request her to come for follow-up because she has no complaints at all. Now, generally what happens is when there is a soft tissue injury, which is extensive, one of the fractures has a tendency to go in non-union. This is a floating lower limb, an intertroch with shaft femur, with shaft tibia, with a large PCL chunk. So imagine the soft tissue injury. Here a single implant was used. Maybe there is a little varus, but then there is a positive reduction over there. Retrospectively, I do feel that the nail could have been little longer, and today I would recommend to take a proper length of opposite limb also, so that we can manufacture or get a customized nail with 3 interlocks. So what happened to this guy was he was fixed like that. He was not showing signs of union at 7 months. That time I told him that it is better to add a plate to this and do bone grafting, but some orthopedic surgeon told him that we have a fantastic injection which will avoid this surgery, and he was put on teriparatide. But I had phone number of that patient, and I contacted him, called him, and at 1 year also, when it was not showing signs of union, I was fortunate to convince him to add on to a plate and do bone grafting, and he united uneventfully. This was a young adult male who had a ipsilateral femur, which I am not going to talk about, but this was a comminuted fracture, which was a grade 2 compound. After debridement, this bone became open, so a rotational flap was done. But from the comminution, that tells you about the amount of soft tissue injury. And he was nailed. At the end of 8 months, I was not happy with the signs of union. I presented this case in SOS meeting, got advice from people, finally decided to add on to this plate, and opened this, did bone grafting also. He united nicely. After 1 year, I removed his plate, and this is how he is united now completely. Now, I have removed distal interlocking bolts so as to allow his tibia to prevent from stress rising effect. This is another patient with a compound femur mid-shaft fracture with ipsilateral tibia which is comminuted. The patient had blebs on the day of surgery, but because the femur was compound, we had to take him the next day, and I fixed only the femur on day 1. I explored this wound, and these 2 pieces were having no attachment, muscle attachment, because he actually reported to me after 72 hours. So I had to remove, I decided to take it out. Now, so it was fixed without shortening, and these bones were left there. I had put a Malicot drain to drain out what if there is anything, any collection remains. So after a few days, once the edema subsided, I did a biological plating for the tibial fracture, which did not trouble me. Now let me tell you about my experience with allograft. Here, after 8 weeks, I put allografts over there, and now I am convinced that in such scenarios, allografts are, if you are using allograft, at least use 50% autograft, at least. And then this again proves that because it did not unite, and then I had to go again, added a plate, again bone graft and allograft, auto and allograft combination, and he united nicely. That is his function. Now, this is a very old case in 2014. He was he was 110 kgs. Today, if this case comes to me, I would definitely add a plate combination. Now, here I was wise enough to use 3 interlocking bolts, but today, again, I feel that I should have put this back so as to reduce the you can handle this gently and put this fragment back. So what happens is it unites, the fracture unites at one end and at other end it doesn't unite. So it was a non-union over there. Actually this fixation was according to the standards in 2014 it was okay. But then a CT proved that it is a non-union. And I was taken up by a surprise when I advised him exchange the link, and then on table the proximal end came into my hand, and fortunately I could procure the instrument for removal of the broken nail. Because I had the nail size known to me, I this time used a long PFN, did bone grafting over there at the proximal non-union site and shingling, and use a long PFN this time, but still this did not unite. After the surgery, I went back to the console and again gone through the all the images, and that showed me that the nail was broken. So it is good idea to go to the console and see it rather than just believe the radiologist. So I added a plate. This was united lower down already. So only this had to be, again I did bone grafting there, and then he united well. This is a male who came to me, it's a subtrochanteric fracture, a high subtroch fracture, who came to me with, at the end of 9 months. So I said that I will attempt to salvage, and then I put a plate like that and did a bone grafting. I had 3 screws above and 4 screws below. He did really well. So I will just, what is the time left? So I will just, I'll escape these cases, and in fresh fractures, I have started using this technique. This is a young lady in supracondylar with intercondylar fracture. Here I use a nail from above and a plate from below, and because I don't want to violate the joint also in a young patient, and this is her function. Again, this is the last case which I will show. I was not able to get a proper reduction. So I always tell my patients that when there is a segmental fracture, you can expect non-union at one level. So you tell them on day one, this is my mistake, I should have used polar screws and try to get good alignment, but this is the alignment which I could get. So after 2.5 months, before allowing it to fail, you intervene, add a plate and do bone grafting. And so this is how he allow kara. This is the last slide. पुढे जातच नाही ते. पुढे का जात नाही. So this is the X-ray to show his union. Thank you.
Thank you, Dr. Joshi. May I request Dr. Damodare sir to please come on the stage and felicitate Dr. Joshi. But I want to ask one thing.
Yeah, you can.
Question and answer at the end.
Huh.
Next speaker is Dr.
नाही तर नितीन काय प्रश्न विचारून देत नाहीये, पण सगळ्यात शेवटी सगळं विसरून जातो ते. सगळेच विसरून जातात सगळं 10 लेक्चरच्या शेवटी.
So next talk is on Perfecting the art of pathogen detection, a surgical perspective by Dr. Aditya Menon. And next speaker is Dr. Pradeep Kotadia, who is going to talk on infected non-union femur. Please be ready.
Thank you, sir. So there'll be a disclaimer before the slides come up. This is going to be slightly controversial. There'll be a lot of concepts which will be challenging to the beliefs that we've grown up on. You might get offended with some of the things that I say, so my apologies in advance. The idea of this talk is we believe in changing concepts in trauma. We've gone from piriformis entry to GT trip entry to again back to medial. We've gone from single midline incision and dual plating in proximal tibia to separate incisions to just front, now front and back, or only back. Yeah. And I'm glad I'm taking this talk because we've had quite a few discussions on infected non-unions, but we've not had a single culture report on any of the slides. Whether that is important or not is what I'm going to question and challenge and have a discussion on. And it's more relevant because 5 years back, probably Dr. Amar Soni would not be giving a talk on arthrodesis following TKR. And he showed case after case after case, which shows that infections are increasing, infections are a problem. Gone are the days that the bugs were simple and massive excision would do everything. So question is, do we really need to bother with pathogen detection as surgeons? So far, we've not discussed a single pathogen in the last 1.5 days. Do we need to start discussing those things and we are discussing infected cases? The answer can be yes or no. Most would say no. That is why we've not discussed it, because that is what we've been taught, that bugs don't matter. We are surgeons. We'll operate. We'll excise. We'll do massive excisions. And by and large, in cold cases, osteomyelitis is generally a cold case. It's not an aggressive infection. We do massive excisions. We put ring fixators and they do well. So the other answer is I don't think so, because some would say, ठीक है, सब करने के बाद भी infection वापस आता है. Why does it come back in spite of doing something, in spite of doing aggressive surgery? So maybe we need to find out what the bug is. Maybe it matters. My answer is yes, it does matter, and I hope to convince you all that in quite a few cases, quite a few scenarios, it does matter. Scenarios like this is a young male, open fracture, treated from the lateral side, didn't do well, there was no infection. He had a non-union, so they revised, now plated from the medial side. Again, didn't do well, didn't unite, there was no infection. Came to us for a revision, and what we found intra-op was frank infection. One culture showed staph epidermidis, which is a skin pathogen. We don't even consider it. So probably he was given multiple antibiotics earlier also, even though there was no infection, antibiotic to jata hi hai. So he was given antibiotics, and maybe that is why he didn't have any infection. If we had just treated him with this, he would have gone on to heal with, obviously mechanically you do the right job. But what he also had was this. It's a fungus. It doesn't get treated with anything other than an oral antifungal. We found this, treated it, he did well, united. This patient, young male, bicondylar fixation, fixed very well. Unfortunately, he had an early post-operative infection. Is anyone here willing to raise their hand and say, I will do massive excision in this case, and my debridement will take care of everything at 2 weeks post-op in a bicondylar? Anyone? Put an Elizar or do knee arthrodesis? So we know we are going to be restricted as far as our debridement is concerned, because we want to retain that implant. At the same time, we want to debride and get rid of that infection. Then we say we depend on body immunity and maybe whatever antibiotic that we give. Now question is, what antibiotic are you going to give? This is what this patient had. 3 gram-negative bacteria, all carbapenem resistant, meaning linezolid nahi chalega, piperacillin tazobactam nahi chalega, meropenem bhi nahi chalega. So kya chalega? It's a newer antibiotic and a combination of a very old antibiotic. The idea is not to say that newer is better, even older is good, but if you know what you're dealing with, then you can titrate the treatment and get the best possible outcome, and that implant could be salvaged. He's doing extremely well, went on to heal, no issues. Now, over the last 4-5 years, we've collected our data and we've seen what are the bugs that we're dealing with. Staph, which we think is the commonest, yes, it is the single most commonest, but look at all the other bacteria. And look at others, the extreme right. There are so many names, I don't even know how to pronounce them. That is the issue that we're facing, whether it is a sterilization issue, open fractures, whether it's, I don't know, autoclaving issues, whatever it is. We're seeing a lot of infections, and this is not just us at our center as a referral center, but a lot of others are also facing this. And problem is that there is no one Brahmastra for these bugs. There is no one linezolid with cefixime combination or ferropenem, which is a favorite drug of ours because it's an oral meropenem substitute. Nothing will do because the resistance patterns are also different. So it may be the same bug, but if the resistance pattern changes, the antibiotic changes. And you can't do massive excisions. You can't do massive debridement. In every TKR, if you do tumor processes or massive excision and arthrodesis, you won't have too many knees left walking around. So yes, I think we need to bother with what bug we are dealing with. Let's see how we can find out what that bug is. Simplest thing I said yesterday also, involve a medical specialist. Anybody who does not have an orthopedic degree beyond their name is somebody you should involve before debridement. It helps. It's easy. People say, कि यारे हमारे पास access ही नहीं है, हमारे पास नहीं है. There are teleconsults now, there are WhatsApps now. You just need to open your eyes and ask. It's like saying, I cannot do minimal invasive surgery because I've not been trained in, but we all eventually learn, whether it's minimal invasive, endoscopic, arthroscopy, we all learn. Here you don't have to learn anything. You just have to find out who's there in your vicinity, in your district, in your taluka. It can be in another state also. All you need is to find out who that person is, and they will help you telephonically. That's all you need now. They will help you with the history. They will help you with what are the possible bugs, what is the investigation you should do, and what antibiotic to start after surgery. They will help you with all of that. It will reduce your headache. Second question, second point is antibiotic-free period. Now, this was discussed yesterday also. Is it important? Yes, it's important, especially in slow infections. Again, if you can't do massive excision, or you've done massive excision and still the patient has come back, or he's had multiple surgeries. We've seen cases with multiple surgeries, multiple debridements have come back. Why? One, yes, surgical debridement. Two, maybe there is a bug which the antibiotic is not addressing. Possible. So, if it's a chronic stable infection, wait for 2 weeks, wait for 3 weeks. Now, I get asked, patient chale jayega. ठीक है. Proximal tibia with blisters आएगा, तो we're not going to operate on day 1, even if the patient wants it. We're going to wait for 2 weeks. The patient says, नहीं, मैं और किसी के पास जा रहा हूँ, आप आज operate नहीं करो, तो जाओ. Become somebody else's headache. I'm not going to operate on a hemorrhagic blister in a proximal tibia. I'll wait, because that makes sense. So this makes sense. We just need to accept that this is what we need to do. We cannot do this in every case. Early post-op infection, don't wait. You can't wait. You have to go in early to salvage that fixation. If the patient is heading into sepsis, you cannot wait. In fact, you have to start antibiotics as soon as the patient comes. Send blood cultures before starting antibiotics. See if you can aspirate that area before starting in the casualty, in the OPD, wherever. And then start the patient on antibiotics. So there are certain exceptions to every rule. When you start, if you can give an antibiotic-free period, tell them. If you get fever, you get pain, you get excessive discharge, or your range of movement, if it's a joint infection, starts reducing, come back, we'll operate immediately. Idea is 1 is better than 0, 5 is better than 1, 14 is better than 5. So go as long as you possibly can without antibiotics. Third, and probably this is the most controversial point, it's an absolute no. Absolute no. Now, if it... Correct. It's an absolute no. I'll give you exceptions also to that. Never say never. I agree. If the patient is not medically fit for surgery, or the patient says, I don't want any surgery, मुझे सिर्फ antibiotic दो, document it, clean that area thoroughly, absolutely sterilize it as if you're going to take an incision, probe that sinus, go deep inside, and take a deep sample. It will be painful to that patient. Explain to the patient this is going to be painful. But आपको surgery नहीं करना है म्हणून मी करतोय. तुम्हाला सर्जरी नको आहे, मला लिहून द्या आणि मी हे करतो. Because 4 out of 5 times you may be wrong. But if you can get a deep sample, those are the only exceptional cases. Even we have done it. Patient is in the ICU, not fit, you want a sample, either aspirate it if it's a joint, or get a deep sample, not a swab from the skin. And 100% after cleaning that area in a pre-operative manner. So typical infected non-union, we know we are going to operate. The patient where we are going to operate, can you imagine you've sent a swab from OPD, maybe got something or not got anything, which may or may not be correct, you've wasted the patient's money. And we are always talking about money, so then why are you wasting his money? If you're anyway going to operate, send intraoperative samples. So don't do this. Don't do this unless in those exceptional scenarios. And intra-op, this is the only place for that swab stick. Only place for that stop stick in an intraoperative scenario. If you're going to operate, send tissue samples, don't send it in a swab stick, send it in containers, I'll show that. So you have to be prepared. Like we prepare with implants in trauma, be prepared in debridements. Use a sterile skin marking pen, use any paper that you have to mark which areas you're going to take the samples from. Now this is something which takes time to train. We also took time to start telling our staff, teaching them. So we have to be proactive. Like you teach them how to prepare a trolley, tell them how to do this. Keep sterile containers. If you don't have it in your setup, speak to your laboratory. They'll send it. They don't charge. They're going to get business, right? They don't charge you for these containers. They're sterile containers. Cut them and they open onto your trolley, but they stay shut. Till you get a sample, open it, put that sample, lock it again. And on top of that thing, with that sterile skin marking pen, mark it. This is from tibia intramedullary or femur intramedullary. It can be used for tissue, pus, whatever. So label it separately. The other thing which Chandak sir mentioned yesterday was, 12 minutes ho gaya? Done? Okay, I'll quickly. This is blood culture bottles. Again, they are available in every laboratory. And they are like, it's a laboratory on wheels. So they are blood culture bottles in 2-3 brands. You aspirate and you directly inject into that bottle. So it's actually, the bacteria start growing in that bottle as you're operating. So it is even before the sample has been sent to the laboratory. The microbiologists also do this. So you might as well do it in the laboratory, in your OT. You just need to call for the bottles. The other thing that you need to remember, so any infected fluid sample, it doesn't have to be pus, it can be deep medullary fluid, deep hematoma from the non-union site, or any collection. Aspirate all of that from multiple areas. Clean that, so that has a rubber cock. Clean it with an alcohol preparation, sterilium or whatever, and then inject, because that rubber plunger has bacteria. So clean that, swab it, and this stays outside the trolley, because this is an unsterile bottle. So their staff is to clean it and inject it. So there are plus bottles also, which if the patient is on antibiotics or it's a chronic infection, call for these bottles. Again, tell the laboratory to call for these bottles and send it to you. They will send it. If they find you being proactive, they will 100% be proactive. It's just that we have to be proactive. Everything is in our hands. We surgeons decide whether that tissue is going to grow or pus is going to grow something or not. Again, tissue sampling, this is something that's been discussed. Nothing from the sinus tract. Sinus tract goes for histopathology. From above the implant, the biofilm under the implant, non-union site, medullary scraping. In a nail, go wherever that nail has gone. Canal, cephalomedullary screws, scrape out those screw tracks also. And send multiple samples. I know you're already thinking of costs. That costs a lot. I'll come to that. List of tests. This is what we send in every patient. In spite of having ID physicians who tell us these are the possible pathogens, we ask for all of these tests in every case. It comes at a cost, but the chance of us missing what that bug is down to, I'll tell you the percentage what it is down to if you start following this. Again, I know this comes at a cost. I'll tell you how to reduce the costs. Because each has a role. If we've thought it is a staphylococcus infection, it's turned out to be TB. We thought it is TB, it has turned out to be staph. We thought it is bacterial, it turned out to be candida. And we're not even talking about non-tuberculous mycobacteria because they are the next big problem in India. So let's not miss that bug because the treatment and our success depends on that. So cost per sample, depending on where you're practicing, can be very variable. So if you send multiple samples, the cost can be 40, 50,000. So collect multiple samples. At the end of the surgery, put them into 1 or 2 containers only. So you can have only one tissue sample from various sites. Don't throw it away. Uska extra charge nahi leta. Microbiologist does not charge kilo ke hisab se. If you have 50 kilos, send 50 kilos in one container. Send one blood culture bottle, send one tissue sample, and also send an extra sample. So I'll tell you why. So if you have all of these tests, which I'm saying you should do, divide them based on what you think is the most logical thing. If you think it's only bacterial, send only bacterial tissue and blood culture bottle. That's it. That's only 2 samples, minimal charge. Send an extra sample of pus and tissue or fluid and tissue to the laboratory saying, if we don't grow anything in the next 2 to 3 days, in 2 to 3 days you will know if something is growing or not. You can do additional tests if required.
You can add gene expert. So the basic I would say is bacterial and gene expert and histopathology. Don't forget histopath. Do not ever forget histopathology. These are the three basic things that we must send in India because TB is very rampant. And plus what you also get is NTMs. So histopathology will get you that NTM. The rest you can keep as SOS basis. So it reduce the cost. But you've already, if you've not sent an extra sample, you get nothing and the patient comes back with an infection. The patient has spent money on culture, spent money on surgery, and you're back to square one. So that comes at more of a cost than this. So send an extra sample and which can be processed later. There are certain selective scenarios where you can choose to send multiple samples on day one. I mean, ask for multiple tests on day one, post-arthroscopy, repeated fractures, open fractures, because fungi and other things are more common there. As far as dilution, cultures, don't dilute. At the most 1 or 2 drops. So you know if the transport time is minimal, just 1 or 2 drops is fine. Nothing more. Don't float it in saline. That too, if you're going to send it the next day. Raat ko operate kiya hai, add a few drops for next day so that it just remains moist. Histopathology in formalin. Formalin is not in cultures. And don't forget to follow up. So just list down the tests that have been sent. Because when the patient follows up, it's very difficult to remember. And keep looking at your own results. What are you getting? Is this protocol working for you? पहले नहीं आता था, अभी आता है. पहले 1 मिलता था, अभी 2 मिल रहा है. So keep looking at that. We've looked at our results. Again, there was no rocket science in all of this. It is just following a simple protocol. What we've also added is a biofire joint infection panel the last 2 years. I've not spoken on that because that's not the most important thing. The important thing is to get the protocol right. And we've reached up to 90% over the last 5-6 years, implementing a protocol, slowly adding things. In the last 2 years, there have been only 4 cases where we've not found the pathogen, and that really, really helps. Yes, we are a referral center where complicated cases come in with 3 or 4 bacteria, fungi, but then it becomes more important for us to find out what they are. So that really helps. So this is not rocket science. It can be done anywhere in India. So form your own protocol, keep a blood culture bottle, keep those tissue containers, ask the test based on what you think is most logical for that patient. Get help. I can understand this is a team in a tertiary care which may not be reproducible, but physicians are available on the phone. Start making a team. So next time you're faced with a situation like this, that surgeon followed the right thing. He'd send multiple samples, but he didn't send it the way we should send it. He sent 2 swabs. This is the first swab. And all that pus finally in the kidney tray went into the dustbin. So all of that pus goes in containers, goes in blood culture bottles, certainly not in swabs. So he took a second swab. So next time you see a scenario like this, you know what to do. And I'll summarize with these tips and tricks. Thank you.
Thank you, Dr. Menon, for a wonderful talk. May I now request next speaker, Dr. Pradeep Kotadia, to give a talk on infected non-Indian fever.
This is just continuation of Dr. Aditya lecture. Before I start, I would like to ask Dr. Aditya only. The problem what we face, polytrauma, admitted in the ICU person, physician gives fantastic antibiotics and we do surgery. Many times the chance of infection increases when the patient comes from the ICU to the theater. The chance of infection are not more with routine cases, but they are more in the ICU setup. So what is your take home on that? How should we manage or how we should proceed in that?
Absolutely, sir. I hate ICUs.
Yeah.
One of the reasons is that because the antibiotics are all over the place. Most of the times the patient...
As soon as the patient goes in ICU, they start meropenem.
Absolutely.
That's the first antibiotic. TG-cycline, they start.
There is nothing you can do to stop that. We can just follow our aseptic protocols and hope for the best. I mean, giving an additional higher antibiotics perioperative will not help.
Because the literature also says the chance of infection increases when the patient comes, we operate on patient on the ICU.
Because what that antibiotic does is kills off all the simple ones and only the resistant ones stay in the patient.
Yeah.
And if that patient gets infected, it gets infected with those. So there is nothing you can do.
You can do nothing. Yes.
What is
the percentage of incidence of getting tubercular and NTM? First, what is the percentage of getting tubercular and non-mycobacterial tubercular percentage of getting culture positive? And are there any clinical criteria or signs suspicious to make you, yes, this could be?
Regular tuberculosis, post-op is extremely rare. I mean, I think maybe you had 1 or 2 after TKR, and they were probably, or after THR and TKR, they were probably an old TB hip or knee to start with, which got missed. NTMs are extremely common. In the last 2 years, we've done about 8 NTMs infecting joints. We've had 10 or 12 NTMs infecting arthroscopies. So anywhere, post-arthroscopy, the first suspicion is NTM. Because the NTM comes from water, and that water forms a biofilm inside the scope, and the scope is not autoclaved or cleaned with a brush. So post-arthroscopy, our first thing is NTM. TKRs also, unfortunately, we started suspecting NTM, especially if the patient has minimal symptoms. And patient gets better after debridement and then starts with an infection. That's typically NTM. So minimal symptoms, no fever, with a sinus, that's typically NTM. But there is a subset of NTMs who behave very aggressively. They get a lot of infection, a lot of destruction. So it's both ways. But post-arthroscopy, post any procedure, I would.
Speaker is waiting for his talk.
प्रश्न अजून विचारायला परवानगी.
Yes.
Speaker is waiting.
Sir, if it's a aseptic non-union which I am operating, and intraoperatively I find some fluid, I always send it for culture. I do my internal fixation, and after 3 days the report comes that this bug is there. So the only way I have what is left in my hand is to give appropriate antibiotic. That's it.
So this is a 28-year male, mentally retarded, dumb fellow, which is there, came to me in 24 with this picture, the pan diaphyseal, you can say intramedullary osteomyelitis of the femur, which is there. When I saw him, he had abscess, which is huge on the medial aspect of the thigh. There is abscess on the lateral side of the thigh. Also, there is an abscess at the nail insertion site. So 3 big abscesses which is there. Without any constitutional symptoms, the patient presented to me. The history goes like that. Accidental fall in 2018, had a fracture shaft femur, treated by a routine interlocking intramedullary nail. Nothing to say comments about the fixation. Symptom free till 2024, except some swelling in the left thigh. For that swelling, he went to some other surgeon where they did ultrasound and they found there was some abscess like thing. They did incision drainage with 2 incisions after the report from the ultrasound. They send the for culture and sensitivity, which they reported as a sterile. There was nothing has been known. So this is the area when he came to us in 24. Again, he came with so much of abscesses. I did ultrasound, which showed, I think this is a report in 2000, which showed there is a lot of abscesses which is there. So you can see the screws loosening, completely osteomyelitis of this fungal. So on 18/11/24, I came into the picture, I examined the patient with so much of swelling, no constitutional symptoms except mild pain, hematology normal, nail was in situ, MRI could not be done, USG done. USG showed a lot of abscesses which is in the soft tissues which is there. So I decided to operate on these patients again. What I did, plan was incision and drainage of the abscess with culture and sensitivity as a protocol for any infection, radical debridement like a tumor surgeon, removal of implant, intramedullary reaming which has been done. When I opened, I could get this type of material from everywhere, from complete thigh on the lateral side, the material from the medial side. This was the material which came completely from that area. This was the debridement which we done completely, and I could definitely see there is, you can say, so much of cavities in the bone, and on table, I could see that the fracture which was there was mobile on table. So it was a frank non-union which is there. So this you can see the incision which is from the nail insertion site right up to the knee which is there. Big incision, big surgeons. So take long incisions, do a radical debridement, take out everything. We send it for culture. The selected organism was a Candida albicans. It was a fungal infection which I could get from there. Now the thought process started how we should deal with it. So we, after talking to Dr. Agashi, one of my colleagues you know from Hinduja, so we just came to there. We decided that we use an antifungal antibiotic coated rod. Not only rod, because the bone quality is not good, we thought of doing a combo fixation in this patient, a nail and a plate finger. So I just went to the literature about the voriconazole, whether it is thermostable, whether we can use the beads of them, and from there I could get the information, yes, you can use that in a cement as well as you can use in the beads that antibiotic which are locally giving more concentration of the drug. So with that, we also got some literature support regarding the voriconazole where you can mix it with the that is bone cement. So we did nail preparation on that with voriconazole. We did a plate preparation. This is a plate which we prepared, a locking plate which is a long locking plate with all the cement from outer side and inner side, keeping the holes proximally and distally empty, remaining fees. This is the plate which is prepared completely, antibiotic coated, and we use this combination fixation on 20th November 2024. This is a combination fixation after radical debridement, wound absolutely settled very well. Then we again opened and we did this fixation completely which is there. So this is a 6 weeks follow-up of the patients. Antibiotic voriconazole was continuously going on, IV antibiotic which was going on along with that. 5 months post-operative, you can see the bone which is getting united, forming good callus. You can see some callus underneath the plate also. This is 8 months follow-up, a very well consolidation of the fracture which is there, and the wounds are healed with a very good function of that. He also has a walking video, completely walking with the help of a stick now, because he's a mentally retarded which is there. So now the fracture has united. Now I would like to ask our expert who is here from the Hindu Hospital, how we should suspect that this infection is a fungal infection, not a bacterial infection. How many cases, at least in my 45 years of practice, I've seen this is the first case which is a challenging case. How many cases they have seen, number 2? So I would like to know from Aditya. So any drugs are known to give rise to fungal infection? Mentally retarded?
Hello. So one clue would be patient had no symptoms.
No symptoms.
So no fever, minimal local symptoms. That is telling you it's a low-grade pathogen with a lot of abscess formation, but at the same time it's like a cold abscess.
Okay.
So something low-grade. So NTM would be one thing.
Okay.
Standard TB, very rare, but could be, and fungal. So something which is slow-growing. So one of these is the commonest possibility.
Okay.
You can never rule out staph also acts like this, but the first thing that gives you a clue is that. Second is that X-ray, which showed scalloping. So you've seen very rare fungal infections in our experience in post-fixation have been maybe 2 or 3 maximum. And Candida. Candida is the commonest.
Yeah.
We've seen aspergillus and mucor post-arthroscopy.
Okay.
Post-arthroscopy infections, but not post-op.
We are not able to find out what is the source of this infection. Whether there is any drugs which causes fungal infection more in the mentally retarded people?
No.
No. Okay. I'll just move further. These are the some references and other things which I got it. Now I would like to ask Aditya and other people, what next? To continue with the same fixation? Because we always say, once you have to remove the antibiotic coated rod and plate and do a definitive fixation. Whether to continue with the same one, to take out all the implants and leave, take out all the implants and insert a implant which is there, interlocking nail, what should we do?
Healing, why touch this? It's already healed, why touch?
So whether that cement is going to give problems, which is there.
No, it's all theoretical.
So let it be there like that only. Okay, anybody? Dr. Chandak, what do you feel?
Unless it starts discharging again, and commonly they discharge after a couple of weeks or months.
So this
then is the time where you have to remove.
It's almost 8 months which has been his quiescent which is there.
I think forget about it.
Forget everything.
The fixation is on the full length of the bone. I think you should not touch. It is a segmental small fixation. Stress riser would be the problem. So
Shiv Shankar sir, what we should do? 8, yeah, 14 months. Yeah. Aditya, you are putting your both hands up.
See, cement after antibiotic is
Illusion after illusion.
nidus for reinfection. It may not be fungal, some other infection can happen. So it's better to. It's difficult. Anyway.
Yeah. So thanks to Agashe, Milind Doshi and Chidgupkar, because this patient kept on moving from place to place and I was the person who was visiting everywhere for that patient. So the patient moved from places to places like this. So thank you. Thanks.
Sir.
Yeah.
May I request Dr. Nilendra Bhole to come over the stage and felicitate Kotadia sir. Dr. Bhole, please.
Thank you.
Sir, please. Dr. Swapnil Kotadia, please come on the dais. And may I request President of SOS Aurangabad sir, please come on the dais to felicitate your own member, Dr. Swapnil. He was to be given yesterday, probably missed. So officially, this session is open for question and answer session. Whoever is remaining, you want to ask question, you can ask the question to the speaker. Otherwise, the session will be over. I declare this session as over.
I would respect MJ sir, Milind Doshi sir, to please felicitate the chairpersons.
When we send the culture, the report comes as sterile. What to do?
I'll send you the presentation. Follow the steps.
how much ml do you need to put in the vacuum bottle? Because in our lab we said at least 1 ml.
There is one announcement from Dr. Nilendra Bhole sir. Ratnagiri Orthopedic Society has just formed from this year, and he is the president of Ratnagiri Orthopedic Society. So let's hope that in near future they will organize some conference at beach, Ratnagiri beach. Oh yes. Kotadia sir is there. Yes. So one more society is added in Maharashtra. This thing. So next session is on. I request chairpersons Dr. Shirish Tumbal, Dr. Abhijit Waksaure, Dr. Avinash Kulkarni, Dr. Satyavan Shinde, Dr. Santosh Deshpande to chair the session and start this last session.
We will be having first talk from Dr. Rajendra Chandak sir, decision making in established infected non-infected.
Respected chairpersons and my dear friends, this is one difficult thing to manage in orthopedics when the patient of infected non-union run down with all the money matters who is now, and the tears in eyes of not only patient, in the relatives and everyone. It's very, very difficult, challenging situation. The problem is they have already spent a lot of money and had bad results. And now to counsel them for multiple stages, and then we need a lot of resources for negative pressure wound therapy. Stabilization is next challenge. What stabilization do we provide? Is it going to be nail, plate, X-fix, antibiotic coated nail? And then what antibiotic we are going to use for a good elution, and graft to be added at one stage. And this always perplexes my mind. And the answer is not easy. Now, even if we have multiple years and decades of experience, the decision is not easy. Even the most junior person I would consult, because this requires 2 or 3 or 4 minds to come to a solution. Now, at times, which antibiotic to put in the cement is a big difficulty. And I always keep this chart pasted in theatre, because many times we forget what antibiotics are thermostable. So most commonly we will be using Vanco. All aminoglycosides are thermostable. So gentamicin, vancomycin, tobramycin. The problem is these drugs are available to us in a liquid form. And in cement they are immiscible. In cement they are immiscible. The liquid form of aminoglycoside is of no use in cement. You have to use them in stimulant. Okay? So in cement, you have to use only powder, because what elutes out is from a powder form. So mixing protocol, again pay attention to this slide, is from literature. Cement, liquid and powder is mixed together first. Cement, liquid and powder is mixed first. So when you are mixing that, then add the antibiotic powder. Why? Now most commonly I continue to do first mix cement, because we wanted as if we are mixing atta and namak. So that is what we wanted, that equal distribution should be there. But then after reading literature, I changed. So we mix cement and powder first, and then you add antibiotic powder, because you want this powder to come out as a leached thing. This leaves as many large crystals intact as possible to create a more porous mixture to increase the antibiotic elution rate. Unfortunately, we have to manage all these bad infected cases, and when they come, in a short span of time, we have to give them answer how many stages. So I have prepared a chart of managing infected non-union. So I tell them this requires 5 stages of management, and every stage may end up with 2 or 3 more theater appearances. So 4 मुख्य चरण आहे, 5वा चरण शेवटी राहणार आहे. प्रत्येक चरणमध्ये 2-3 वेळा थिएटरमध्ये जाऊ लागू शकतो. I would always say this sentence to all patients, because then when the next surgeries come or one first stage fails or second stage fails, you need one more stage and then you don't have to have a poor show. Consider all these factors to get a good result. So infected non-union, you need all of these factors. The four important I would emphasize is a good elevation, and this is many a times forgotten. All these infected non-unions are edematous, bacteria-like edema. Remember this. So I would not immediately take up that patient unless 48 hours of good elevation. And I call this as true elevation. On a bolus splint, when you keep a tibia, usually the ankle is at a lower height and the knee is at a higher height. So this gives negative elevation, put it to a positive elevation. And this block of foam, I call it as a positive true elevation. So elevate the limb. As soon as it is elevated, edema goes down and the tissue resistance of that part increases. Tissue also has resistance. You must have noted, once you remove an infected implant and give a period of cool down period, 5, 7, 8, 10 months down the line, patient comes again, he is all fine now. His tissues have now generated a good resistance themselves. The local resistance is also there, humoral resistance is also there, and tissue resistance is also there. Another thing which you have to look into is their low hemoglobin. If they are 7, 8, 9, 10, wait some time, give them ferritin, IV. It increases the, improving the power. Another thing is a venous congestion. So with elevation, the venous congestion also goes down. You must have seen so many venous ulcers, you just elevate them and over a period of 3, 4, 6 weeks they would settle down. So pay attention to these small factors. And of course, the whole envelope, etc., you have to look into. Also, when you debride, so your holes, these holes have a bacterial membrane which you need to curate out, and it is not easy. So there are 2 or 3 good equipments which you can take out, a very small angled cup curate, or there are knurled rods which are available for 3.5, 4.5 and 6.5. So they have a rough surface on them, just take it, put it into those holes. It's something like Kan Khujana. So you just roll it out and then that takes out the whole bacterial membrane. That is very easy. Now, whenever there is infection, I would always pay attention to these 5 things. And whenever I have missed one of them, infection continues. If you have these 5 things together in any patient, I am almost sure that I am going to win over this infection. So everyone would do a good debridement, including the whole dead bone. Then dead space management, local antibiotic delivery with the eluting powder. I have managed gentamicin powder, amikacin powder, and the tobramycin powder. How much to use has been very well given in the literature. And then also stabilize it. Whether you stabilize with a simple X-fix or LRS or infix depends on the situation of tissue. Florid pus, suppurative condition, spreading cellulitis. 3 conditions you don't put any plate or nail inside. Suppurative condition, flowing pus, but low-grade granulation tissue, a smoldering infection, low-grade infection, you can put a nail and a plate. So that definition in my mind is clear when to use a nail or a plate. So many times all of this you decide and then chalk out the program. When you debride, obviously you need to debride extensively, including the sinuses, because this skin does not have a good resistance to infection. So take out everything, debride. Now whenever this large suppurative infection is there, first tackle that flowing infection, this suppurative part of it. You can do it by negative pressure wound therapy, you can do it by rinsing, you can use irrigation therapy, you can use aphthera therapy, whatever you want to use. And negative pressure wound therapy is a boon. So if those who have not developed a knack on negative pressure wound therapy, it's an excellent boon in managing infection. And negative pressure wound therapy you can use in 2 forms, negative pressure wound therapy or vacuum assisted closure therapy. These are 2 good things, you have to develop knack onto it. So go on reducing the size, go on reducing the bioburden, and that helps, because after this stage, from a catabolic phase of patient, anabolic phase starts, and that patient after a couple of or 2-3 days, साहेब आता बरं वाटतं, जेवण करूशा वाटतं. is the phase where his catabolism has gone down, anabolism improves. And I find 4 or 3 things help that phase. One is good antibiotic elution, second is reduced edema, third is a good level of hemoglobin, and fourth is their low vitamin B12. Remember friends, B12 is very important for rapidly replicating cells. B12 is very essential for rapidly replicating cell. So you develop stomatitis, you give B12, the patient would respond. So even so, when you give antibiotics, the GI inner membrane biosome also need B12. So replicating, you need a B12. So look to the their B12 levels also, that helps. A good debridement after a good, say if it is a distal infection, not florid, I would use debridement under a tourniquet, adequate bone debridement, look towards those bone debridement. After you have created a good scenario, now is your stability. Again, this is very important for infection control. So 5 different things you have. A compression plate is very good. In infected scenario, you can use a long plate, don't use at the fracture site, and then compress the fracture. Antibiotic coated nail is an excellent way. Extracutaneous plate is what my preference is many times. LRS, X-Fix and Elizarov. Everything has a role. Now this is a patient where after debridement and once we got this, then we use a plate. And this was shown by previous speakers as well. You can use good amount of. The advantage as compared to stimulant. In stimulant you can use only 1 gram of antibiotic powder. Whereas you need a large area of infected tissue. Here I would use a preference of cement. And in cement, can you please look at this photograph? So this is the actual photomicrograph of the cement we have taken in the pathology. And you can see the crystals onto the surface. I think you will be able to appreciate this. And this is what is eluting this cement or the antibiotic into the tissues. When this is eluted, this locally gives a good MIC level and that controls the infection. So also compression under infected scenario is not bad. Only thing is don't put at the fracture site, go away and then compress. Even if you compress with 2-3 screws in infected scenario, because previous stability is also there, you need not fill up all these screws so that you do not create a bioburden. And this is infection control, remove dead tissue, put plate. Negative pressure wound therapy can be combined. You can combine with VAC therapy. You can do a CI-NPWT, that is closed incision negative pressure wound therapy. The way it helps is it reduces and sucks the edema. The edema is sucked, your bacteria are more susceptible to the serum level of bacterial, the antibiotic which is there. Antibiotic elution you can improve by multiple ways. You need to increase the surface area of the cement. And on the plate there is a layer. Also in all the sinuses I would put them into bullet form. So bullets can engulf the whole sinus and they can be just taken out in the OPD when you do dressing. They can be lye, batasha, peda, whatever form at the site of the nail, on the top of the nail, because at the end of the nail there is no antibiotic elution. So you can put one of these at the end of the nail cap. The aim is good elution. Once a good elution is there, then your fixation depends. Now for these patients, somebody asked yesterday what plate to use. I like to use certain plates which have a good single gap, double gap or a triple gap, so that at the fracture site they are not stressed and then we can fix the appropriately. So this is on opening. At times when you find poor bone, poor soft tissue, mascular technique is an excellent way. What mascular technique does is, so you're forming a chamber and the fibrous tissue is not shrinking in. It creates a vascular good global envelope. So next time when you are reconstructing, in previous era I remember we used to dissect the whole fibrous tissue and then there was a very small space for putting graft. Now here you have a global space and also there is an induction membrane which has lot of good substances, and therefore mascular has become very useful. Whether that cement mantle has good antibiotic remaining or no does not matter. Even the mascular suggested it's not the antibiotic which is eluting, which is important for graft to take up, it is the the chamber which has formed in the membrane. But in infection, we need antibiotic elution. So my idea about this is clear. So masculine can work with antibiotic, can work without antibiotic if infection has been cleared. So this patient did very well. And the use of muscular technique is very useful for multiple reasons. So it gives you an ability to take up the graft very fast. And then the use of antibiotic coated nail. So whether you are using a nail with various knurling on it, as Shiva sir showed, or even a simple nail, I like to use the nail originating from this area, the dagger nail. The advantage is it has a V posteriorly, the cement does not debond from it, and then you can roll this nail onto a wooden board. You form a rough surface board, rough surface nail, because if this is injected into a syringe in a liquid form, it is very smooth nail. Elution, I feel, would be lesser in that if the nail surface is rough. So this was a patient, infected nail, and along with nail, if you add two semi-cylinders which are not bonding to the bone, the elution is still better, and then that leads to a good elution. So this is how I would like to prepare the nail. So I would roll it on a wooden plank, create two hemicylinders, and that patient healed well. Once that hemicylinders you remove, now the tissues are also lax. So patient develops a better range of motion also. This is another advantage of adding two cylinders, and of course your physio and everything continues. This patient did excellently well. Let us take this case where I would be happy with an extracutaneous plate, because medullary cavity you cannot put a nail, and the skin is all scarred and you cannot tunnel a MIPO plate. So I like to use extracutaneous plate osteosynthesis in many of these tibia patients rather than Ilizaro. The advantages are many. Ilizaro also I do, but when indicated, Ilizaro is an excellent technique. But if you want to do without Ilizaro, this is excellent. And the pin tracts, or rather the screw tracts of the ECPO do not get infected. This is one beautiful aspect of it. Patient can walk on it. Since it is actually locked, the infection is practically not. And as you can see the close pictures, they are all fine. These are almost dry. Unless they are into a muscle, they remain absolutely dry. They are very stable. So this is the case. Tibia nail, plate removed, infected. This is poor skin tissue. So even on that you cannot put a plate or a nail because it is the end of the bone. So you can initially infection control, ECPO, extracutaneous plate osteosynthesis, and then you can put bone grafts into it, and that heal. So even at 6 months, 8 months down the line, you can see all the pins are absolutely fine. And this is the way. So this is one way, plate or a nail or an extracutaneous plate. You can choose the fixation what you like. For proximal tibia also this is excellent. You have to take a plate of the opposite side, and the ROM is easy to manage. Patient can walk on it. Either you can use the LRS, that is also an excellent way of stabilization. The advantage with LRS is that it has a low implant hole inside, nail is not there, and then you can put a lot of antibiotic with also. So this is what is with the Elizarov reconstructed. We have already seen this case. And last, I will come to the last slide. Implant removal at times is tricky when it is old case. So you remove whole thing, remove the whole bioburden, the bacterial membrane, the infected membrane, and removing this is difficult. You can also use a brush inside to take out the whole curettings and reamings, and as was said, make a distal window, remove it completely. I like to use this irrigation with gentamicin, with the hydrogen peroxide. Remember only one bad thing about HTO2, since there is a lot of air bubble which is going to liberate, don't pressurize it into a closed chamber. The venous sinusites are open. So there are 2 death reports from India with hydrogen peroxide. It was because of the air embolus. So if you use hydrogen peroxide in a closed bone cavity without tourniquet, then the venous sinusite is what getting this air which is absorbed. That is one disadvantage. Otherwise, the best agent as per the recent literature also in the world, to remove the bacterial membrane is hydrogen peroxide. It is available in two forms, 3% and 6%. 6% is good to use. The nascent oxygen which is liberated removes the necrotic tissues, and this necrotic tissue becomes open to our eyes what is necrotic and what is live. That is another advantage of hydrogen peroxide. When you use hydrogen peroxide, you see a tissue differentiation. The live tissue appears different and the dead tissue appears different, and the debridement after a use of hydrogen peroxide is still better, because you know this is dead, you know this is live. This is advantage. Most of us keep on using it. In literature it has bad precedent because possibly it is not coming from a big company. This is what my feeling is. We continue to use it and it is good. Don't pressurize it into a closed bone cavity is the only recommendation. And this healed well. Last slide I will be taking. So irrigate the medullary cavity in an open way, put saline, put weak hydrogen peroxide inside, and then whatever way you want to manage this patient, that Elizaro is a fundamental good technique to use. In case there is any question, I would be ready to answer them. Thank you so much.
Sir, for the excellent lecture on this. We'll take question answers now at the end of the session.
Hello.
Hello. Yes.
What I do for doing a antibiotic coated nail is, if I am using 4 vials of powder, whatever the antibiotic,
yes,
I mix 3 of them and use the last one. While we make chapati, we just add dry powder and make it dough. That's the same way. I just add more powder on the top and roll it. Whether extra antibiotic is there on the surface or not, I am not sure, but I use that as a dry powder to roll the nail. This is
so good. What it would lead to a very high peak of antibiotic on day 1, which is what you want.
Yeah, that's
so it's good. It's good technique, I think.
whether it works or not, I am not sure.
Yes, sir.
Yeah.
Now they've started saying for some reason that add antibiotics after 2 minutes of mixing. So it keeps changing. So now they say put everything in the end.
Now the second question is that to both of you, many times we put stimulant beads, many times we are worried about if there is a hematoma which is formed this, whether we can use vacuum therapy in that cases with the stimulant or with the antibiotic coated nail or not.
Sorry, I did not, I was focusing on the laptop. I did not listen to your question.
The question is that after putting stimulant beads or antibiotic coated nail, many times we are scared that after surgery, radical debridement, there are chances that the hematoma may be there. So in those cases, we tend to put a vac therapy.
My idea is very clear. The very common problem. My idea is very clear. Drain it from a different plane. Drain it on a different plane. Okay. Say your drainage tube can be away from the stimulant, and it can be in a different plane. So it can be on a superficial plane.
You put stimulant beads or antibiotic coated, take one layer of muscle sutures,
yes,
and then on top
then,
you can put
then
a
put a
drain.
your worry is hematoma should not remain there.
Yeah, that is there.
You can devise your own ways.
Sometimes people say that if you are putting stimulant, it will get washed out because the concentration more in first 24 hours.
So it would be getting washed out through the wound itself. So it is acting and washing out. Or if you are putting a negative pressure wound therapy, put it on intermittent mode. For half an hour there is leaching, and half an hour it is sucked. So you can put it on intermittent mode. That is another way.
So vac is generally if the wound is not closed. Kudade sir? Vac is if the wound is open. So your incision vac? Incision vac is anyway not acting on the deep wound, so it doesn't matter. So that drain tube which is inside, like sir said, can go. I mean, stimulant is supposed to dissolve over 4 to 6 weeks. So the first 24 hours won't matter in that.
Madam sir.
Yeah. Just asking how you mix gentamicin in an antibiotic coated nail, because it's a liquid form.
So everything, these aminoglycosides are basically powder. 1 kg of gentamicin powder costs 60,000 rupees. 1 kg of amikacin is 80,000 rupees. Somehow procure them. I got my own ways to procure powder form.
Because we get the gentamicin liquid form.
Tobracef is one antibiotic, Tobracef, which has tobramycin as a powder, but it is less amount. Tobracef is
That-
available.
That's why we are using only vancomycin.
Yes.
But if gentamicin, you get a powder form.
I got it
Bhandari
arranged.
sir,
So,
we will reserve this question for lunchtime. We are running out of time.
thank you so much.
Yes, thank you. I now call upon Dr. Asit Chadupar for his presentation on pseudoarthrosis tibia, recent advances.
Thank you again. 3 of my orthodox members are going to moderate me. Thank you so much. Pseudoarthrosis tibia. What is the recent modality of management is what I'm going to talk on. पुढे जात नाही.
Hello.
ॲपलचा प्रश्न नाही.
Aditya.
मीटिंगची सवय झाली.
They have to catch the afternoon flight. So on behalf of Solapur Orthopedic Society, big thank you. Thanks to Vikas Agashe for recommending going to Sri Lanka. That's correct. That's one. And thanks to Gadigone who, so because of that, we also got some lectures. So anyway, that's it. No, because every time we invite Agashe, the only reason is Agashe is Kotadia's classmate and we have got a good rapport, but really, Agashe always quotes him whenever he is giving a talk. I had no opportunity to interact with him in such a close manner. Even I was not having his contact number to tell frankly 15 days back. So, but thank you very much. It was so nice of you to come to Solapur and share your knowledge, and really we have enjoyed. Thank you very much. Thank you. Thank you.
करू का चलो. I will try and stick to time. My talk is on congenital pseudoarthrosis tibia and the recent way of managing this complex problem. Before I start talking on what we are doing in 2026, let me just go back and see how it all started. 1891 was the year when Paget describes this condition first. Before the 1950s, people tried to brace it, splint it, or then there was amputation. 50s and 70s was the era of mechanical stability, where people were using rush nails, K-nails, and onlay grafts for this situation. Then in 70s and 80s, the concept of mechanical plus biological to solve this problem evolved because the understanding at that time was clearer that the pathology was in the periosteum. So vascularized fibular graft was first described by Huntington, and it improved the union rates, but the problem of refractures still persisted. Then in the era of 1980s and 90s, Elizarov was gaining popularity all over the world, and here was a condition which orthopedic surgeons dreaded. You could do everything in one Elizarov, that you can correct the deformity, you can do a bone transport, you can compress it, and you can get rid of all the problems. So my exposure to Elizarov was in 2001 when I was doing my internship in Solapur Civil Hospital. Vache sir had passed out and he did a case of pseudoarthrosis using Elizarov technique. I was too young at that time, but he explained to me, I clearly remember that. And this was the post-operative result. Now this boy has grown and he keeps visiting Vache sir time and again. So the problem was sorted out. But the issue was to put this kind of a fixator in a 7-year-old and an 8-year-old can be unforgiving both for the patient and for the surgeon. Plus, considering refractures, people started moving away from Elizarov and they started using these telescopic nails, the Feser-Duval nails. And at the same time, they started using the periosteal membrane to graft it on the hamartomas site. In 2007 and 2010, Drawer Pale got attention that the bone morphogenic protein 2 and 7 was in less quantity in the periosteal membrane, so he started using human recombinant bone marrow proteins. And from 2010 to current is where the multimodal treatment got personalized according to surgeons all over. So, to compress this in 4 points, Benjamin Joseph from India started using double onlay grafts. Choi popularized the vascularized fibula and then moved on to 4-in-1 technique. By 4-in-1 technique, what I mean is the proximal tibia and fibula and the distal tibia and fibula excise the hamartoma, get everything to become one unit and try and make cross union. Drawer Pole added posterior grafting between the tibia and the fibula and started using BMP, and he calls this the kitchen sink approach. And my friend Mandar Agashe has also published a paper on this where he uses the 4-in-1 technique. He uses onlay grafting, posterior grafting as well as cancellous graft in 7 and 8-year-old. This is what the literature says. And this is what I've tried to get it graphically denoted. On the first slide, if you see, excise the hamartoma. Second image shows compression of the fracture site. Third, put your metal work. Fourth, add a periosteal membrane. And the last image shows, try to get a cross-section union between the 4 bones that are there present. So this is the first case. My friend Tarang Khairnar was out of town, and desperate times, desperate measures is when I decided to do it myself. Do it yourself. DIY chalu kela mi. So this was a 7-year-old. Got the onlay graft from the opposite side, one cortex, just like so. Get one single big chunk, you can then half it. Take an anterolateral based incision, long incision, and try to expose the bone from the expose the bone with thick flaps. Make sure that you don't use any bone holding forceps like a typical orthopedic surgeon, because the bone is of very spongy quality. And iliac crest bone graft is harvested either from the medial table or the outer table. The medial table is a little convex, the outer table is a little concave. So it is now considered that you harvest it from the outer table so that concavity can be posted on the posterior aspect. Try ethibonds to 4 quadrants and then post it between the tibia and the fibula. And on top of that, post cancellous graft between the tibia and the femur, sitting on this iliac crest bone graft, and then use the iliac crest, the opposite autograft that you have harvested from the tibia, you use it to pack it over anteriorly. So you can tie it with ethibond, and you can use a plate after you have passed a nail. If the fragment is low down, then it is imperative that you put a nail through the calcaneum, crossing the talus ankle joint and into the tibia. The nail will go as far as possible depending on the curvature of the proximal tibia. And apart from that, you also add a medial to a 3.5 mm LCDCP. I use a pulse lavage. And this is how the post-operative X-rays looked. And the fracture pseudoarthrosis united over a period of 4 months. This is the gait of the patient She is not using ankle foot orthosis, which is very important to use. This is the second case, harvested tibial graft again. Here, after excision of the hamartoma, the bones were completely dysplastic. It was closed. I had to open the medullary cavity. So while opening the medullary cavity also, you have to ensure, because of the curvature, you use a smaller drill bit and make sure that it goes into the center, and then make it bigger by using a awl or something. So if you try to use a awl immediately, then there is a chance that you can perforate one of the cortices. Then again, iliac crest bone graft harvested, ethibonds, put it posteriorly between the tibia and fibula. Iliac crest graft harvested, put in between, onlay graft, tight. This is how the post-operative X-ray looks. This is the video that is sent to me yesterday. Apart from this, it is important to use zolintranic acid 4 weeks before the surgery and 2 months after the surgery. Calcium and vitamin D3 is given as supplements. So to conclude, CPT is a periosteal disease. Low bone morphogenic protein has increased osteoclastic activity is one of the reasons that causes bad results. To improve that, we don't get BMP in India, so we harvest a lot of cancellous graft. So to learn to harvest cancellous graft in a 7 or 8 year old itself has got its own learning curve, but as much as 30 cc to 40 cc of graft can be harvested. Creating cross union so that the cross-sectional diameter at the pseudoarthrosis level in comparison with the metaphysis is important. Intramedullary fixation is essential to obtain and maintain union, and X-union technique in various literatures across has yielded 100% union and no fractures, no refractures have been reported. I thank you for your attention, and I thank Mandar for inspiring me to go ahead and do this technique.
Excellent presentation, Asit. Nice demonstrative cases. Any questions?
Yes, sir.
Dr. Tarang?
The ends of the bone were a little bit broader. They were not pointed.
Sorry? You are saying something, sir.
So I think then...
Can you ask me again?
The ends of the bone at the pseudoarthrosis site was not very small. Many times we get a pencil thinning of the bones at the site. Number two, sometimes it is again with the fibula also. Many times you get a fibula as well as a tibia pseudoarthrosis. So whether the same technique can be used in both these cases. Number three, you are putting intramedullary rod. So that might be one more reason of not getting a refracture, because even Elizabeth Sarovar also says once you remove the fixator, you put intramedullary rod so that the chance of refracture are very less. So whether that is the thing.
So to answer your question, in my vast experience of 2.5 cases and 16 years of practice, but I have learned more reading with the literature and talking to my friend. So the question is, every time you will not get a flat surface where you can compress. So if you don't get that, try and create a flat surface. Many times the fibula may not allow you to get exactly approximated with each other. In this situation, try to get the distal fibula as a part of the distal tibia. So even if there is a gap, that gap can be ignored, but the distal, so the whole fundamental is to increase the cross-sectional area of union. So you try and put as much bone as is possible. So sometimes it could be 4-in-1, but sometimes nature will not allow you to do it 4-in-1. In that situation, you do it 3-in-1. And maybe sometimes it will be in 2-in-1 also. So depending on that situation, you will have to adapt to that situation. But I have not come across this situation. However, that can be a possibility.
What sir was trying to say is probably the ends were not dysplastic as it
could be in pallet type 4 or something. So not taking away anything from the cases, but then if the more the dysplastic, the more dysplastic they are and the more fibula is involved, it becomes really difficult for the union. And if fibula is also involved, then sir, you can do a cross union also if fibula is involved.
So what is your question, Tarang?
No, I am trying to add.
Is there a question for
Yes,
me?
yes. So-
What is the question?
So if question is, or rather asking you as an input is, here is, everybody is popularizing or giving credit to drawer pallet for the cross union.
No. Drawer Pale took it from Choi.
Exactly. So I
Choi started it. And I think you visited Choi last month. You have a picture with Choi. So Choi is the one who popularized 4-in-1. Drawer Pale added bone morphogenic protein, cancellous graft, and this was his addition. So increasing the cross-sectional diameter was something that Drawer Pale contributed.
that is the difference between.
Yeah. Have read it?
Asil,
Yes.
you are removing a part of cortex of the opposite bone of the medial part.
Yes,
right?
sir. Yes, sir.
So does it need immobilization?
No, sir. Because you are taking 1/3 of the cortex.
Okay. It does not need any.
No, sir.
Next speaker. Superior state. No, they take superior state. You suture the superior state, the bone pounds under it.
Yes, yes, yes.
We are running out of time, Arvind sir.
तो ऑर्थोडॉक्स आहे त्याला अलाउड आहे
Asil sir,
Ah.
can you take
Sir,
out, can
ah.
we take out the nail after the union?
No, 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 no.
Because it is going through the
No, 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 no. The nail, if you remove the nail, there is a chance of refracture. The plate can be removed depending if you see my first case, my plate has inadvertently gone into the physis, the one of the screws. I am thankful Tarang did not notice it. But see, I was having no choice. I may remove the plate, but now what people are saying that after the end of 1.5 years, they are using telescopic nails now instead of using a simple nail. But sometimes those telescopic nails are also not telescopic. So eventually now what they are saying is that at the end of 1.5 years, revise the plate, not change the plate. You take the plate out and you put a new plate in. So unless the boy or the girl goes to skeletal maturity, don't try to tamper with the implants.
Excellent. Asil, very excellent. According to the latest literature, what is the refracture, how much?
No refracture, that is what he says.
Yeah, that is because of his BMP and
No
etc.
fracture,
We
no
can't
refracture.
afford BMP. We can't afford
Cancellous
BMP
graft.
here.
Cancellous
Yes,
graft.
yes, no. When would you define it as a successful union? Definitely after union, but how many years would you?
Skeletal maturity.
Skeletal. Okay.
Yes, thank you. Thank
Thank
you
you.
very much. Yeah, I would like to invite the next speaker, Dr. Sunil Agra. Yeah, he will be speaking on masculine technique in infected gap, non-union.
Convert
Good afternoon. Okay, so we'll have a brief talk on masculine technique in infective gap non-union, but some of our cases were actually fresh fractures with huge gap in the fracture site. So basically it's a biological condition where process of fracture healing has come to an halt, as evidenced clinico-radiologically, that is painless non-union, painless abdominal mobility and radiologically absence of callus, and which necessitates change in its modality of treatment. That is the definition for postgraduates. And there are many classifications given for infective gap non-union, like CNM added classification, Weber-Zeg classification, then there is classical drawer-Paley classification for infective gap non-union tibia, A1, BA, A1, A2, A3, B1, B2, B3, with deformity, with gap, with infection. So now I will come to the key treatment goals in infective gap non-union is, one is to eradicate the infection, second is to achieve stability, third is to reconstruct the bone, and fourth, very important, is to address the soft tissues. So what is vascular technique is, it's a two-stage surgical procedure where it is preferred for a large defects. It creates a biological chamber, that is induced membrane, which is very important for absorption of incorporation of the bone grafts later on. And second stage where you remove that cement spacer and followed by you can put a lot of corticocancellous bone graft. So first stage is membrane induction, that is followed by debridement and fixation with a spacer insertion which will induce membrane. And second is a bone grafting, that is after removal of the spacer and then grafting. So this technique relies basically a membranous ability to act as a physical barrier and act as a source of growth factors like EDGF and transforming growth factor and BMP2. So our first case was 26-year-old male truck driver with a road traffic accident. He had a loss of femur at the accident site, so there was a gap. So grade 3B on a medial side. So our aim of surgery here is to get rid of infection, maintain the length of bone, and to give a limb pre-injury status, minimizing the morbidity. So maintaining the knee length as well is important. So this was after primary debridement. And then we put a locking plate. They become a very solid stability. And you can put a, whatever the bone gap was there we put a Vancos bone spacer, cement bone spacer. And then this cement spacer will induce a foreign body reaction which will induce membrane. This was after 3 months. These are subsequent follow-up radiographs. And this after 3 months when we opened it. This is how the whole cement block had come outside. And nicely induced biological membrane was there. And still the solid stabilization by the LCP was there. So there was no movement at all. So we went for contralateral fibular bone graft. So contralateral fibula with lot of autogenous cancellous bone grafts were put in second stage. So fibula gave a very strut, another additional strut to the plate. So that was after 2 months. That was after almost 3 years. The whole gap has been consolidated. And this is now what he walks with, and with almost full function of knee as well as hip. Can squat and sit cross-leg. And he has gone to his pre-injury status, I say. This was another 43-year-old male diabetic after RTA to ankle, simple, actually this was his first X-ray he came with. He had a grossly infected, this was done elsewhere. He came to us like this picture. There was no talus. There was infective sinus on the lateral aspect of the ankle. Bone was completely resorbed. It's more so like a Charcot, actually, Charcot arthropathy. So this case done by Dr. Vache, my associate professor, and debrided nicely and put a cement spacer at the ankle. So cement spacer took the size of a talus. And the next plan is to remove this cement spacer after 3 months and put a TTC nail with lot of allografts and autogenous bone grafts. So this is what the post-op X-ray, now totally devoid of infection. So this was another tibia bone gap, primary debridement done with lot of normal saline, cleaned it, and this was the cement spacer which was created on table by measuring the gap, put there at the fracture site and did a biplanar external fixator. So these are subsequent. So this is how the post-op X-ray looks like. The TBW wire is to keep the stability, give some stability to the spacer. Ultimately, that got converted into a multiplanar Elizero external fixator, and contralateral fibula was put inside after removal of the spacer. Now the patient is walking. This was another young man, 17-year-old man, got crushed between a platform and a railway at Hyderabad, and he had a primary fracture and a primary clinical picture like this. So there were a lot of, it's a bag of bones actually. Primary orthopedic surgeon did a very nice thing. He debrided it nicely and removed all the loose fragments and did a monoplanar X-fix. Actually, he planned for amputation, which the parents were not at all willing. That's why they came to me. So this is after primary debridement, the huge gap of almost 10 to 12 centimeters. You can see with a monoplanar fixator. So this was on-table picture when I took him for nailing. The reason for nailing was to give him a long term, because I knew that with this gap, X-fix has to be kept for a pretty long period of time. With it may not give that stability in long term. So that's why I went for titanium nail, as it has got less induced membrane, that is biological membrane. So titanium nail was put, and first I did a static locking to give additional stability, and then put a cement spacer all across the nail and filled the fracture gap, and put a vac along with it. So this was at the end of putting the cement spacer. It sets in and seen as if it was bone. So at the end of 3 months, he presenting like us, like this. So now the plan is to put a fibula, contralateral fibula with lot of autogenous bone graft and with a flap, cross-leg flap. At present, on the second day also he was walking. At present, he is partial weight bearing with the help of walker, and he is very happy with it. That's a current. This is current clinical picture. No flap. Now we are going to remove the cement spacer and then put a fibula with lot of autogenous cancellous bone graft along with cross-leg flap. So I thank Dr. Gurunath Vache for lending him his case, and all the staff of my department, all the assistant professors, associate professors, and all the residents who are hard working to get all these cases nicely done. Thank you.
Thank you.
Definitely. In next STM.
The next talk will be on subtrochanteric non-union by Dr. Shivshankar sir.
Thank you.
Before Shiva starts, Mane, Ashok Mane, on behalf of Dr. Raghav Barave, is he here in the hall? Yes, yes. Hi.
Ala? Ala ka? Okay. I'll be talking about the management of non-unions in the subtrochanteric region. Again, this is due to absence of Dr. Gade Gone. Friends, non-union of subtrochanteric fracture with no infection is the subject. Majority of these non-union are due to inadequate surgery. It's iatrogenic, I would call. And majority of the time implant breaks as the fracture doesn't unite in time. Common mistakes or common causes are thin nail, mechanical instability, improper entry, that is varus of the proximal fragment, fracture fixed in distraction, static locking or delayed dynamization, delayed weight bearing or non-weight bearing. Majority of the cases, it's combination of many. If stability is missing, you have to give mechanical supplementation. If biology is missing, you have to give biological supplementation. If both of them are missing, you have to give both of them. This one such case, it's not a subtrochanteric but upper third femoral fracture, and because of the static locking and the gap, the nail broke, and I did just an exchange nailing with reaming, and this is after 14 months. You can see that the fracture seems to be united, and the patient came after 7 years in 2010 and decided to get the implant removed. And as you can see, that time we were taking the regular x-rays with the films, and not a good x-ray was taken at the time and removed it, and the post-operative picture shows that the fracture is not very well consolidated, but anyway, since the fracture was united, he was going on to do all the activity, and after 1.5 years he came with a trivial trauma having a fracture. Probably it was a fibrous non-union at the fracture site, so that could be the reason. This time I didn't take any chance, I didn't do any close nailing. I just opened the fracture, freshened the bone ends, shingling, multi-lock proximally. There are 3 locks proximally, 3 lock in the nail in the distally. Everything was done. Within 4 months, you can see that the fracture beautifully consolidated in this patient. Today, if the patient comes to me today, I will be doing an augmentation plate. I am not just happy with a nail in these cases. I will be adding an absolute stability with a plate. As Dr. Tanna says, overkill in orthopedics is not a sin. This is one such case which myself and Dr. Manmat Raut, he is there today here. We operated together long time back. After 10 years the nail broke. That time the patient came. You can see that the proximal fragment is in abduction. The varus is the one which is the culprit. So what I did was, I have used a Steinmann pin to prevent my entry going to the lateral side. I made an entry from medial to the base of the trochanter. This Steinmann pin is lateral to the nail, lateral to the reamer. Then did freshening of the end, shingling, exchange nailing, bone grafting with the augmentation plate. This is the extraction of the broken nail. Then this is shingling being done. Sharp osteotomes are required. You should shingle on either side at least 1 to 1.5 inch away. Don't just remove the periosteum. It has to be osteoperiosteal flap. Then these K-wires are acting now as a blocker from the outside. Then I added the nail augmentation plate, and lastly there is a bolt. You can see that there is a bolt which is preventing the nail going back to the original site. This is the immediate postoperative picture, and this is just at 4 months. You can see that the patient had a good function and good union subsequently. Rao sir, if you have got any further follow-up, please share that picture with me. Another case I operated with Asit Chidupkar. A subtrochanteric fracture was treated with a plate. Unfortunately, that broke, and second surgery was done. Again, a PFN was used in this patient, and there is subtle varus, and after 2 years, that nail also broke here. And here also I did the same surgery. You can see that these K-wires are preventing my entry going more laterally. There was a huge gap posteriorly that we filled with a bone graft. We had to already bone graft obtained earlier 2 surgery from both the iliac crest, so we had to get the bone graft from the posterior iliac crest. So this picture shows the nail being inserted and the augmentation plate being done in this patient, and this is the bolt anteroposteriorly, which is lateral to the nail here, somewhere here it is, preventing my nail going more laterally. This is immediate postoperative picture, and he only came once for follow-up after 1 month. Then I was chasing behind Asit Chidupkar. One fine day he said that patient has died also. Then even then after 2 years I told him that I sent a message. We operated in 17 May. Are you sure about the date? I said, okay, go and search in the paper. Then he gave the patient's mobile number. Then I started chasing the patient for about 3 months. One of my hospital staff was calling, He's not far off. He's just from Gulwanchi, which is 13 kilometers from Solapur. And finally, one fine day he landed, and I took an X-ray. That is 4.5 years after the initial surgery. And these are the scars and the function. And this is how the patient is walking. There is about 1 inch shortening. And this whether the limp is due to shortening or due to both the iliac crest being harvested, because earlier 2 surgeries, both the iliac crest were harvested. This surgery, when I did, I have harvested the posterior iliac crest also. Then few cases I have done with Dr. Nitin Deshpande at Kolhapur. This nail was put, and after few months that nail broke, and the surgeon just removed the proximal culprit. And this patient was like that almost for about 1 year. And then, because she was diabetic and high risk patient, that nobody wanted to touch. Then he called me to operate this patient. I went, and what happened there was, I just reamed the whole canal with 12 millimeter reamer, and I inserted a PF from the top. PFN has got a proximal end 15 millimeter. So while passing that, the bone was so soft, there was a linear split along the lateral aspect of the proximal fragment. I was not at all prepared with any TBP or anything at that time. So what I did was, I just used wire and pressed it, and my reduction was not very good. I should have used this instrument to pass the PFN, but unfortunately I didn't use it. You can see that the inferior screw is not in the inferior part of the head, it is center or superior part of the head. But since we had done the wiring, we were lucky that the fracture started uniting, and this is after 2 years, totally the fracture consolidated. That patient wanted me only to do the implant removal, so I went back again. There was a discharging sinus because of the diabetes, so this time I used stimulant beads and removed the implant, and everything went off well. Another case again I did with him, a subtrochanteric non-union. As the screw position was good, I inserted another K-wire as an anti-version guide wire to know the direction, because that will reduce lot of radiation. So passed the anti-version K-wire, again made an entry much more medially, and then bone grafting added this is after in September, this is 18 months post-operative. The patient sent the X-ray somewhere in Ratnagiri area he is, and he sent this X-ray, and this is the clinical picture he has sent at that time. He is a fisherman, and you can see that he is so comfortably walking, and he jumps onto the boat and start driving that boat. So this is how the function could be restored. You can see that the entry has been changed to much more medially through the piriformis fossa, and this is the end result. Another lady, this patient was operated 8 years back. Suddenly one fine day she started getting pain. Again Dr. Nitin Deshpande called me. I was out at that time. By the time the patient came, it was almost 1.5 months after later. Then I asked him to get a fresh X-ray. So this was the initial X-ray, and when I saw this fresh X-ray, I thought its fracture is trying to unite. The nail has broken and self-dynamism is happening. So this is the X-ray actually. And 22/3/21, I thought that the nail is, fracture is uniting. So I asked him to send a lateral picture. So immediately the next day you can see it, he sent a lateral, this is 22nd March, this is 23rd March. He sent a lateral picture. I was convinced that it is a Pakka non-union. We removed the proximal part of the broken nail. Then through using our Solapur broken nail extractor, I could extract. The nail was very, very loose, so there was no problem in removing the nail. So this distal locking was kept till I fixed the extractor. While rotating, I could easily extract that. Then I freshened the ends, both the ends. I freshened it, then added the plate, then added the nail. This is the nail which is removed. You can see the threads cut in the nail because the nail was so soft. You can read more about the Solapur broken nail extractor in this Tanna's interlocking book, and he has given due credit. I couldn't patent it for various reasons. That's a different story. This is immediate post-operative picture and some zoom picture of the same patient, 2 months picture, and this 8 months post-operative fracture consolidated. If you are thinking how to drill a screw beside the nail, what I normally do is I use K-wires. I just drill with a K-wire. I will hit the nail first, then I'll go by the side of the nail. It produces lot of heat, so you should be injecting water, saline, to prevent the heat formation and death of the bone. So you can do like this and then gradually enlarge that hole with a thicker wires. I don't want to use a drill bit because drill bit normally breaks by the side of the metal. This is Dr. Manmat Rao's case only done by Sudarshan. Childhood femur fracture treated with a plate, and he had a fracture, so it was treated with a locking plate, and locking plate also broke. That was treated during COVID time with a nail with augmentation plate, beautifully executed surgery. And then you can see in due course of time, 1 year later, the fracture has healed very well and patient had a excellent outcome in this patient. This is Dr. Rajendra Chandak case. It was a subtrochanteric high upper third femoral fracture treated with a plate. Then somebody, after it failed, nailing was done and it went into aseptic non-union. That was the time Dr. Chandak used fibular graft, autogenous graft, then iliac crest graft, nail, plate, augmentation, everything was done. And that's what I am telling. In orthopedics, overkill is not a sin. So do whatever best you can do to get the union. He has used the fibula as a plate here. There is a fibula as a plate, there is a plate also and a nail. The last case I am showing, a patient I have operated at least 8 times. Initial 2 surgeries were done by somebody else, otherwise I have done the remaining. This patient was operated with a SP nail plate that bent and the plate was removed and patient was put on spica for some time. And in 1996, the patient came to me for the first time. That time, I used a interlocking nail. I passed a nail from down. It came out through the tip of the trochanter, and there were no bolts at that time. I have used a 4.5 millimeter cortical screws, and unfortunately, I removed that implant as it was giving trouble. Before I confirmed that the union was there, as soon as I removed the implant, I could see that the leg went into varus and shortening was there. So next day I took the patient again and did a stack nailing. 2 canals have been put inside. That also broke. Unfortunately, I missed many of the slides in between, all my digital, thanks to Dr. Bandari. He gave me Trojan virus. I lost many digital pictures at that time. Between 98 to 2006, I lost many. Anyway, yeah. Then I used a recon nail. I was unable to put the recon nail. I made the entry much more medially, but I was unable to retain that. And recon nail also broke after 6 years. Then I did a locking plate. Locking plate was the key of the day at that time. That also broke in 2018. And I was thinking what to do. So this time I did everything. So removal of the implant, freshening of the end, shingling with sharp osteotomy, reaming the canal, PFN fixation with augmentation plate for neck screws, TBP for the neck screws and augmentation plate, bone grafting for posterior iliac crest. So I have added 2 plates. For the neck screw, there is a support of trochanteric buttress plate. For anteriorly, there is an augmentation plate. My intention was the patient is already 75 years, at least let him walk on the implant, if not the fracture unites. So this is immediate postoperative picture, and then this is 2 months, 6 months, 9 months, 18 months. 18 months the patient came to me just before COVID for implant removal. I said, let me get an CT scan done before I take a decision to remove the implant, because I didn't want to remove again land in trouble. Fortunately or unfortunately, wherever he is, I don't know. After COVID, he has never come back to me. And I don't have the guts to call the number and to ask what has happened to him. So overall, after so many surgeries, happy patient. How I could keep, let me talk about what are the mistakes I learned from this case. Wrong entry. If I had taken a piriformis entry on day 1, if I had got a good valgus, all these things would not have been required. That's first thing. Second thing is static locking done. We just read the literature and don't allow collapse to happen. And also the bolts were there, bolts were not there. That time, 1996, only we were using cortical screws, only we were doing. And I removed the implant even before confirming the union in this patient because it was giving trouble. So
as I said earlier, I lost all my images from 98 to 2005 due to Trojan virus. Wrong removal without union confirmation. Again, through the same entry, not analyzing the reason for failure, I have just shoveled in the stacked canaling, that also broke. 2 canals are broken. You can see how much forces the subtrochanteric area will be having. 6 years, after 6 years, these 2 canals broke. I removed this broken nail and also broken piece in between, and with my Solapur broken nail extractor, I extracted the remaining part. So without opening the fracture, I just re-reamed it and shoveled in the nail. Non-union requires freshening at the ends, removal of all the fibrous tissue. You have to do a thorough job. Don't do close nailing in such cases. Don't expect your reamer product to go and help in uniting. So this is another mistake I have done at that time. Again, though I tried to change the entry, as I said, I was not knowing how to retain that entry. So my nail went out, toggling outside. So tried to correct the entry but did not know how to retain it. The nail was toggling, could not pass the second neck screw. Non-union case, close nailing is done. That is another mistake I have done. So he came back in 2011 with a broken recon nail. This time nail removal was done, locking plate was done again with bone grafting. Not a known method, means that is new thing has come in the market. Just because new thing has come in the market, we are using it. Unproven new implant. For non-union, recon plate is not at all a good implant. Your standard DCP is the best implant. Non-union case using locking plate was a mistake. I was unable to get a compression at the fracture site. Required absolute stability by additional plate. If I had put an additional plate, yes, probably it could have come. In 2015, he came to me with a plate walking off. I asked him to get the surgery done. He did not come to me. But in 2018, he came once the plate broke at that time. The things I learned in this case is how to change the entry. This case I already shown, operated with Dr. Manmat Raut. I put a Steinman pin lateral to that and then used a polar bolt to prevent toggling of the nail at the entry site. How to change the entry? Another case operated with again Asit Chedupkar. Things I learned while treating this case. Proper freshening of the ends. By attending conferences, I saw the video by Dr. Tanna, how to do a chiseling. He showed beautiful demonstration of chiseling properly. Earlier I was hesitatingly putting small chisel and taking a very small slivers, but now I take out almost 5 to 6 millimeter long slivers from the bone. Updating by way of attending the conference like this and using a nail with augmentation plate is one which helped. Did 8 surgeries between 96 to 2008. How could I retain this patient? I have not done any surgery free of cost. Involving the patient in your thought process, having empathy toward the patient suffering. I have not done any surgery freely, but charge minimally. I would use the physician sample medicines and something like that. Anesthesia, I'll ask him to take less, surgical charges little less like that, but never do any surgery free. Otherwise, they think that you have done the mistake and it might be against you in court of law if something goes wrong. So never do free. Informing the patient other treatment options as well as what others may suggest at that time. So if you go to Dr. Mehtan or Dr. Kotayat, they will suggest you exchange the nail or do a replacement like that. You tell them these are the options they will give, but I am going to wait. If required, calling senior experts also to show them the case in your presence. To conclude, aseptic non-union, if it is hypertrophic, just put a proper implant, thicker nail or a plate. If it is atrophic with insufficient vascularity, only bone grafting required. If the stability is also not good, stable fixation with bone grafting with a nail with augmentation is good. Plate is also good or a double plate is also good, but I am little lean towards nailing because nail gives stability over longer whole length of the bone and plate gives stability the fracture is begging for. As Dr. Tanna says, overkill in orthopedic is not at all a sin. So even in hypertrophic non-union, if the patient comes to me today, I don't hesitate to put a bone graft. Thank you very much.
Thank you, sir. Thank you, Shiva sir, for the excellent talk. Everyone will be definitely benefited by the ways you have shown. You are truly a master in treating non-union surgeries. Now the next talk will be on limitations of designs of PFN leading to failures by Dr. Akash Manik. Raghav Barve sir is not there, so he will be representing.
वही का प्रदीप का काय नाव आकाश माने
There will be two case presentation immediately following this. Dr. Nitin Patil and Dr. Vaibhav Gandhi will be doing. Then we will be breaking for lunch. So then other talks and other people case presentation will be done after the lunch break.
Good afternoon. Myself, Dr. Akash Mane. My mentor, Dr. Raghav Barve sir, unable to join today. So I am presenting behalf of him over the topic limitation of PFN leading to failure. There is large burden of intertrochanteric fracture in geriatric patient, and about 50 to 60% of them are classified as an unstable fracture. Major concern in management of this patient is because of their related associated high morbidity and mortality. Osteoporosis and instability are most two important factors which leads to unsatisfactory outcome. So we prefer to do uncemented cone bipolar hemi replacement in all unstable osteoporotic intertrochanteric fracture with age more than 75 years. We have got largest series of 80 cone bipolar cases over last 12 years, and my colleague going to present that in Asia Pacific Orthopedic Association conference at Jaipur next month. Proximal femoral nail widely used for intertrochanteric and subtrochanteric fracture as it is biomechanically more superior than other extramedullary implant. Despite of advantage, there are 13% failure rate reported in the literature. Factors which are responsible for this failure is fracture pattern and osteoporosis, which is not in our control, but reduction, intra-op technique and implant choice is in our control. First, we will see evaluation of integrate intramedullary devices for per trochanteric fracture. It start in 1990 from gamma nail, PFN, PFN-A2, PFN-A, PFN-A2, and recently trochanteric femoral nail advance. Currently, PFN and PFN-A2 are widely used implant for the intertrochanteric fractures. We will enumerate some limitations for proximal femoral nail. First is nail geometry. In nail geometry, fixed nail blade angle, radius of curvature, and stress rises are at tip of the nail, bulky proximal diameter of the nail, and stress riser at the junction of nail and blade. First is the fixed nail and blade angle or nail and screw angle. Standard companies, due to lack of inventories, provide only 130-degree of angle implant. Ideally, for extreme coxa vara or coxa valga, we need inventory from 120 to 140 degree of neck shaft implant for 120 to 140 degree neck shaft angle. Second is the fixed radius of curvature of the nail may not met femoral anatomy, and that will rise to the fracture at the tip of the nail. bulky proximal diameter of the nail with little bit lateral entry causes lots of hoof stresses over the greater trochanter, and that will lead to the fracture of greater trochanter. So ideally we need so-called piriformis entry for this nail. Stress rises at the junction of nail and blade. Inherently, this is the weakest point in the PFN, and metal damage while reaming due to mismatch most commonly occurs in local company, give rise further weaken that point, and that leads to the fractures. So before to avoid this, before inserting nail, we can assemble on table and check for the correct position of jig and aperture. Second one is the cutout versus cut through. In literature, there are high chances of back out and cutout in PFN, and there is a high chances of cut through in the PFN A2 or PFN. Recently, there is advancement of proximal locking of the blade that come with some advantage and some disadvantage. Advantages are it prevent uncontrolled blade migration, that is back out, improve rotational stability, control excessive collapse, but this becomes static construct, and that will increases risk of cut through, loss of dynamic fracture impaction, and more stress over the bone blade interface. Fourth one is the Z and reverse Z effect due to the differential loading of the lag and the rotation screw, and that will, due to lack of medial buttress support, osteoporosis, varus reduction, and inappropriate entry point of nail aggravate this problem of Z effect or reverse Z effect. Let's discuss some cases. Case one is the 60-year-old patient with left intertrochanteric fracture. This is post-op X-ray with fair reduction with fair implant placement. This is 1.5 month X-ray with secondary loss of reduction. And this is the 4-month X-ray. Patient come with us with pain since 1 month. We done CT, it shows erosion of the acetabulum, so revision THR was done. This is post-op X-ray, this is 4-month X-ray, and patient is walking comfortably. Case 2 is 90-year-old male patient, history of fall at home, no known comorbidity, having right intertrochanteric fracture. This is post-op X-ray with fair reduction, a good implant placement, good tip apex distance. This is 1.5 month X-ray, and this is 3-month X-ray. Patient come immediately to us with pain. As patient is 90-year-old, we replace it with shorter blade, and patient walking after 1 month comfortably. So we dig the literature. There are many cases of helical blade perforation, and there is a correlation with tip apex distance. So it is advocated that as in DHS we goes till subchondral, we in PFN we have to limit tip apex distance between 20 to 25 mm. We should not come below 20, so that it will increases chances of cut through. Case 3 is 66-year-old female, history of fall, known hypertensive, diabetic, having left intertrochanteric fracture. Substandard reduction we can say, but after 3 weeks there is complete back out of helical blade. Again we go in, taken patient into the theater, make a reduction positive, insert blade in same nail, and lock the blade proximally. This is a post-revision X-ray with positive reduction. This is 1.5 month X-ray, and luckily this fracture healed in 4 months. Again we go into the literature. There is very less. There are only 8 cases of complete back out of helical blade. But there is possibility lag screw and derotation, that is PFN. Due to the back out and Z effect, we are shifted to this helical blade, but there are reports that helical blade can also comes back out. Case 4 is the 61-year-old patient, history of fall from stair, known hypertensive, having left intertrochanteric fracture, managed with good reduction, good implant placement. This is 1.5 month X-ray. This is 3-month X-ray. But at the end of 4.5 months, there is a varus collapse of the head, breakage of the screw. We done CT. That shows no sign of union. So we revise it with revision stem, total hip replacement, patient walking after that comfortably. So take home message or things to learn is PFN is excellent implant for pertrochanteric fracture, but not free from complication. Some complication related to the inherent design limitation, fixed geometry, stress riser at the junction of nail and blade causes nail breakage. Poor bone purchase can cause cutout or cut through. Proximal locking against the principle of dynamization. Dual screw system causes Z effect. So there are some design limitation in PFN. Appropriate reduction and careful intra-op technique reduces chances of implant failure, and surgeons should be prepared to manage complication due to implant failure. Thank you.
Excellent presentation, Dr. Mane. Now there is case presentation by Dr. Nitin Patil sir and Dr. Vaibhav Gandhi sir.
Good afternoon. This is the lunch time actually. Everyone is waiting to go out. Being a last batsman or ninth batsman. This is a 39-year-old male patient having a 9 months non-union intracapsular, was wandering here and there for a window shopping and was referred by a physician to me for a joint replacement surgery. Considering his age, I decided to go for the MRI for the viability, to check the viability of the head, and I decided to conjure the head. So what I did is close reduction, then intraosseous bone grafting was done by this way, which was inspired by Dr. Gadegone's sir's lecture. Previously I heard on that. And I use this funnel, which frequently used for the PLIF or TLIF surgery in spine. I use the same funnel in the track of a DHS reamer, and intraosseous bone grafting was done after curating the, just a minute, after curating this, last slide shows that I curated intraosseously and filled up with the bone grafts and did abduction osteotomy and fixed with the DHS, and this went into good union with a good function. This is a full function. This is abduction and walking comfortably. Coming to the second case, this is my own case, a subtroch with more comminution. I did close PFN with a percutaneous encirclage wiring. He was doing every work in his farm, heavy laborer, came to me for the removal of implant, and at this stage I have not confirmed actually the union, and I did the removal of implants, and immediately post-op I noticed there is a gap. So it was very difficult to explain the patient what to do next? So I decided to put two interfrac screw, and fortunately for me, that united very nicely, and this is the function. Another case, a subtroch fracture operated at ELS came to me after 1.5 years to me. When I found that there is no stability, there was a rotational instability that this went into non-union, and I confirmed this on CT. There is a bone gap, frank. When I opened it, the shaft was rotating, so I did just chiseling, put a bone, added bone drafts and a derotation plate or a bridge plate, and it went into good union. Coming to the next case, this is my case, a supracondylar TY type fracture fixed with a DHS 90-degree reachers. Almost after 1 year, she started complaining of pain, and the implant broke at fracture site. She was not ready because she was walking with a stick, though with limp. But another 1 year, she came with a more pain, and now she was ready for surgery. So I decided for the intramedullary fixation, the dual type of fixation with bone grafting, and it went to good union. Now she is walking without limb, without support. So case landed with me in this stage. There was a fracture at the distal tip, distal locking tip also, and it was in non-union. So I did a thorough debridement of the fibrous non-union, and I added two plates, dual plating, and had a good union. And this is the function. Thank you very much.
Next case presentation by Dr. Nitin Patil. Thank you, Vaibhav Gandhi sir. Nice bunch of cases.
Good afternoon, chairpersons and all the delegates which are remaining in the hall. I am going to present a single case of a non-union of patella fracture, which are of rarest variety. So usually these patients come with the complaints of pain at the site, difficulty in walking with an extension lag and gap between the two fragments. This will be the clinical picture. Usually they have got difficulty in extending the leg because of the quadriceps mechanism weakness. So there will be a lot of gap between the two fragments, patella alta. Let us take a case, Kishori Minde, 61-year-old female. She was operated for fractured patella 7 months back at Ahmedabad. So this was the fixation with K-wires and TBW. That failed. So again, she was operated by another surgeon with K-wire and TBW encirclage type of wiring. That also failed. You can see the difference between the two fragments. The distal fragment has been escaped through the implant. This way she came to me. So it was a kind of compound fracture because the pins were jutting out of the skin. She was fed up of the implants because of the frequent surgeries. So I did a 3D CT. So distal fragment was a very small fragment. Implants were still in place. So the various ways to treat such kind of scenarios are open reduction and internal fixations with bone graftings, with plating, quadricephaly like VY plasties to bring two fragments together, partial or total patelectomy, various suture techniques and Elizaro fixators where there can be distraction and docking. But there are complications of partial patelectomies also, which are like instabilities, stiffness of the joint, extension lag, reduced motion, quadricep weakness, anterior knee pain and patella baja. And complications of ORF, as you know, infection, delayed healing, and tendon rupture. So I followed a novel technique of fixing the patella with a Krakow sutures only, without any implants. So the patient was taken in a supine position with a bolster under knee with 30 degrees of flexion. Fracture site was exposed. All the fibrous tissue between the two fragments was removed, and the bare bone was exposed like this. So we tried to approximate the fragments. You have to take care that you should not damage the articular surface of the femur. These are the two fragments. Then you have to take the Krakow suture with ET1 number 5. You have to start from the distal fragment, start through the bone. That needle has got that capacity to enter through the bone. Starting with lower fragment on one side, taking interrupted sutures, Krakow type of sutures. You can do the imbrication. One end of the thread is kept long so that it can be used to fix the proximal fragment. This way, the same procedure is done on the medial side. So now we get 4 strands of ET1. So this is rock solid fixation, see. You are able to lift the leg with just holding the 4 strands of the ET bond. Now we'll make 3 holes in the proximal fragment. One in the middle, one in the lateral side, one in the left side. You have to take care that the hole should be starting from the articular surface and going towards the superior surface. Like this. So out of 4, 2 threads will go in the center, central canal, and one on the lateral and one on the medial. You can straighten the needle of the ET1, you can pass that from superior to inferior side in the proximal fragment, you can pull the sutures through that hole, like this. Now you can suture the one strand from the center to the left and one strand from the center to the right. And finally, 2 strands can be knotted together with a sliding knot. So it becomes very stable fixation or stable knot. This is a sliding knot. Now these both strands can be tied together. So this will be final construct. Now meticulously you have to close the extensor expansion, which is very important. And I took continuous interrupted sutures. So this is the intraoperative picture, and this is the final intraoperative picture. Then we close the wound. So this was post-op X-ray. Even though the fragments are not in close approximation, this is 4 weeks post-op. When the patient was seen after removal of slab, she was able to flex the knee up to 90 degree. And this was 7 months post-op. This was pictures sent by the patient who lost to the follow-up for 7 months. She had no complaints. She sent those videos from Ahmedabad. No extension lag. So take-home message of this patient is repair of extensor retinaculum is of paramount importance. preserve the quadriceps mechanism as far as possible, avoid patelectomy and instrumentation in such cases. Thank you very much.
Any questions?
Were you prepared if the proximal pole would not come down? What were your measures? And what other things would you think? Suppose the thing was that the distal fragment was very small. In an attempt to catch it off, if you could have splintered or something else, were you prepared with symmetry graft and reconstruct the patellar tendon? That sort of things were going in mind. And third, if the proximal pole would not come down, were you prepared with fixator? 2 pins in the pole, proximal pole patella and in the tibia, and try to bring the proximal pole down and to gain the contracture what had happened because of non-union time period, to bring it down. Were the measure you were lucky that it came down?
Yeah.
To do everything as you thought of.
Yeah, exactly. I had to release some adhesions inside the joint for bringing that down. Another thing, there are pitfalls of all other procedures which I already mentioned, like VY-plasty of the quadriceps plasty, that makes the quadriceps weak. Another thing is putting a tendon through the tendon imbrication to the fracture fragment. So all these things, or patelectomy, they make the quadriceps mechanism weak. And there will be continuous knee pain, anti-knee pain, and that can lead to osteoarthritis later on. So this is a without implant procedure is very good for such gaps which are just 4 centimeters long. More than that, you have to follow the other procedures. I tested now. I show the video now. There was no, because of time constraint, because I was told that I have been given 5 minutes and just 5 minutes for rest. Yeah, very good. So the aim of post-operative protocol is he or she should be having 30 degree of flexion by the end of 2 weeks, 60 degree of flexion at the end of 4 weeks, preferably 90 degree of flexion at the end of 4 to 6 weeks. As per the compliance of the patient. She was an old lady, so she did it late, and because we were worried that twice, thrice this has been failed, so we started little late in this patient, though on table the fixation was rock solid.
Can answer
Nitin?
Yeah.
In long-standing patellar non-union, instead of doing quadriceps plasty, or if you put a Steinman pin or small K-wire, tension it and give a traction preoperatively for 7-8 days, with Elizara apparatus, will it be easier to bring that 2 ends together with this technique only?
Because I don't have any experience with the Elizara, that's why I told that it can be distracted and docking, that is one of... Sorry.
We have to just pull the patella with quadriceps, like we give
pre-op traction. Here we didn't try that because the implant was jutting out. The first priority was to remove the implant first. So there was another operation. We did all the things in one operation, the removal of implant and fixation in this patient. That could have been tried.
Thank you, sir.
Thank you, sir. Thank you.
Thank you. Dr. Sunil Handarmat sir is here. Dr. Mane.
Yes.
Thank you.
Thank you. Thank you, chairpersons. I will like Dr. Sambaram sir to felicitate our chairpersons. Yes. Now there is a lunch break.
Today I am going to present a case of non-union of subtrochanteric fracture. Here is a 32 years old male patient, had a history of fall from bike on 16th of October 2023. He presented with closed left subtrochanteric comminuted femur fracture. He was not having any comorbidities on presentation. It was his X-ray on presentation where one can see comminution at the fracture site and subtrochanteric nature of the fracture. So he was treated with CRIF with long PFN at first setting. The first cause, Shiv Shankar sir had said in the morning that first cause of iatrogenic non-union is the lateral entry. So this cause is obvious over here, where one can see the proximal fragment in the little bit of varus and comminution is there. So post-operative period was uneventful, wound healed well, started weight bearing after 1 month. Only complaint was pain while walking. Repeated X-ray shows non-union. So again, he was reoperated for the same, and it was his post-op X-ray. He was operated with proximal distal femur locking plate in reverse manner. It was done in May 2024, 7 months after the primary fixation. Again, post-operative, there was no signs of infection, wound healed well. Post-operative other events were, it was uneventful, and only complaint was pain. It was again aggravated with weight bearing. He was treated symptomatically for the same, but pain persisted. So at this point of time, he consulted to me in November 2024, 1 year after the previous surgery, 1 year after the first fall. So at the time of presentation, his complaints were severe pain. He was unable to walk and very stiff knee, 0 to 60 degree of range of motion. So it was his X-ray on presentation where gap is persistent, implant is loosening out, distal screws were backing out. So I planned him for the surgery, but before that, there were some challenges because he was operated twice and achieve results or getting results in such previously operated cases is a big challenge. Then again, he was recently diagnosed with uncontrolled diabetes mellitus. So to prevent infection is another major challenge, and obvious the functional limb and full ROM to achieve all those things, it is going to be a challenge. He was investigated thoroughly. His ESR, CRP, serum procalcitonin came to be normal. Diabetes was controlled with insulin. Required consents for bone graft taken and counseling done for risk of infection and possible limb length discrepancy, because I was suspecting because of 2 surgeries, there is a lot of sclerosis and necrotic bone at the edges. So limb length discrepancy was explained in detail. Planned for open reduction and internal fixation with nail and plate with bone graft. So I used to operate in supine position always because I'm not having any experience of lateral position. He was operated in supine on fracture table. Previous implants were removed. Local signs of infection were absent. So didn't take any culture for that. Fracture site, as all know, that basic principles of the non-union treating, all principles have been followed. Edges freshened, shingling done, rimming done in proximal and distal part. Here I did one thing that I wanted to change the entry. So I did, for proximal part, I did reverse rimming, and under AP and lateral CM guidance, I took a medial entry from reverse guide or passing of guide wire through the rimmer and passed it through medial to the medial to the GT. So size 9 expert femur nail was passed. This is routine, and it was supported with proximal femur locking plate, distal locking done in dynamic and static mode, bolts. Bone graft harvested and it was inserted and closure done in lace. It was his X-ray after the surgery where I could manage the entry in the medial to the greater tuberosity, and proximal femoral locking plate was inserted, unicortical screws were inserted, and one thing is that I did locking bolt proximally. I think it gave me a better control of the distal fragment, and 5 months post-op X-ray, bone is started uniting. His symptoms were relieved, and this is his current X-ray. Bone is completely united, and he is walking full weight bearing without any pain. It's his functional outcome. His range of motion is achieved full, and he can sit cross-leg sitting. Thank you. Yes.
You had done in supine position.
Yes, sir. Yes, sir.
You said that you did a retrograde entry.
Yes, sir. Yes.
Supine retrograde entry in a small fragment. Was it difficult or any tricks?
I got traction is relieved, and both fragments were overlapped. From distal fragment, either you can put it above the distal fragment, proximal fragment. Either you can put on anterior or posterior, and slightly pulling it out and done is.
I would also like to answer Shiva also. In a small fragment, supine position, how do you take a medial entry, retrograde entry? I just want to have answer from you also. In a supine. Pradeep.
Fully adduct the limb.
Such a small fragment, sir, such a small fragment and full of muscle bulk there to adduct and with the full muscle mass anteriorly, can it be possible?
Yes.
Is good, I
Yeah.
accept everything is good. I just
Only you can put a spin inside, pull this fragment medially, adduct it. Retrograde becomes very difficult.
adduct it and a small fragment of say 6 centimeters.
Reamer, I didn't pierce with reamer. I passed the reamer, and then guide wire has been passed from that fragment to the medial to the pyriform, medial to the GT.
Passing the Stillman pin or that is too difficult.
Luckily, I was lucky enough.
If you are done in a lateral position, yes.
Yes, yeah.
Put it in lift it up.
Yes, yes.
Intermediate,
Yes, yes.
easier.
Yes.
I think you do next time in lateral position and you'll be more happy.
Yeah,
And doing
I-
lateral
because-
position, you'll be more happy. Everything is in front of your
Yes,
eyes.
yes, yes.
Only
Yes, sir.
we are worried about when you're passing screws in the head and neck, whether the lateral
Orientation.
position will be. You get a very fantastic view
Yes,
if you take. You just get it right.
So answer somewhat extended. When you are doing in a lateral position, ideally everybody what they do, the position what they give Dinesh Kare sir, reflects the limb which is down totally 90,
Yeah.
90, knee 90.
Yes.
And you keep the limb which is to be operated with such that it will be parallel to the ground.
Yes.
Second, when you take a X-ray lateral, you have to give inlet width.
Okay.
That means the CR will be directed 40 degrees to the foot so that you will actually get true lateral view of the head. You see beautifully head, neck and all the trochanter.
Okay.
That is very actually beautiful view. I was also not there unless I witnessed that.
Yeah.
Inlet
Yes.
view is so beautiful.
Inlet view.
True lateral view you will get.
Yes.
Head is seen perfectly circular. Neck is seen. You can go down in center of the neck and go in center of the
Okay.
inlet in lateral. सुंदर है.
The next speaker is Dr. Shirish Tumbar. He is presenting a case of non-union humerus.
Good afternoon, everyone. I will be presenting a single case of pseudoarthrosis of shaft humerus by locking compression plate and bone grafting. Patient was 65 years male with deformity of left arm since 9 months. He was previously operated in 1998 for fracture shaft humerus by nailing in Mumbai. That was a solid retrograde humeral nail. After 1 year of that nailing, that is in 1999, he was told that fracture was not united and it needed revision. Patient had refused the surgery, and later in 2009, that is after 11 years of the first surgery, he had a fall and sustained fracture of the same arm, for which he was treated conservatively for 3 months. But still the fracture didn't unite. And after that fall, he came to our institute after 1 year of that fall. This was the X-ray left humerus in 1999, that is 1 year post-operative, when the retrograde humeral nail was done, we can obviously see that nail is bent and there is non-union, and also the fracture ends are trying to unite, but as there is distraction, there is no union, and also deformity is seen. After that, he had a fall after 11 years of that nailing. So now this is the X-ray which is in 2010, which is showing the pseudoarthrosis, that is non-union site at the midshaft humerus with broken nail at two sides. That is one we can appreciate at the fracture site. Another one is in the upper third, upper third humerus region. The proximal locking screw has broken, and we can see that still there is gross non-union with the upper shaft forming like socket-like deformity, and the lower shaft is forming a rounded ball-like structure. So this was the pre-operative X-ray. Sorry. So management, what we did initially, the main goal was to remove the nail and open the fracture site. The only difficulty was how to remove the nail because it was a solid nail. So initially I took an incision at supracondylar region and took one part of the nail, which came easily. Then anterolateral approach was taken. Fibrous tissue was removed and pseudoarthrosis site was opened. This we can clear cut see the proximal part of the shaft and the distal part of making a socket and ball type. This we can appreciate. So the medullary canal was closed, medullary canal was opened, and the broken solid nail can be seen in the proximal shaft. That part of the nail was removed. This is the part of the solid nail. Then I rimmed and I attempted to take out the proximal piece of the nail which was embedded in the proximal shaft, which was not possible. So I left it and I went ahead with my previous plan, that is the opening of fracture site and plating it. This is the broken solid nail, but still one part is missing. So this non-union site opened, fibrous tissue removed, removing of medullary canal, removal of sclerosed bone was done, and also as the bone was very thick, I had to did shortening around 1 centimeter of that sclerotic bone with saw, and ensured that punctate bleeding was there. Then shingling was done because it was not in proper position to apply the plate. So proper apposition was needed. So this is the final X-ray. That is the 6-hole plate, 3 screws above, 3 screws below, and the plate was applied. Plenty of corticocancellous grafting was done. And you can see the proximal part of the nail which has been left because it could not be removed. This is post-operative X-ray. The non-union site at 6 weeks is showing some callus trying to unite. So this is a healing at non-union site which can be seen at 8 weeks. Good amount of callus is seen. This is 10 months post-op where it is showing excellent union. This is 1 year follow-up which is showing very good union. This is the healed scar over anterolateral aspect of the left humerus. This is the active range of movements. The patient that he was 6. So this is a condition where fracture ends forms a fall joint interposed with fibrous tissue between them. This was pseudoarthrosis where bony union is very difficult to achieve. Will not go in theory. So conclusion is sticking to the very basic principles of management of non-union, that is freshening at the fracture site, shingling, removal of sclerotic bone, rimming of the medullary canal, rigid fixation and abundant bone grafting. It helps in achieving the goal. So in this case all the steps were carried out and non-union site has healed excellently. Thank you. Nail one part I removed through supracondylar because it was a supracondylar nail. One separate incision I took. Then I removed this nail and then at the fracture side the second part I removed. Mumbai केले सर एवढं.
It's a really good case, Shirish. Very good case you have done it. Now only any other than this, any other way people can do this surgery. Any other can.
I think only fibula graft would have been added.
Fibular graft could have been added.
Whether you can do a nail plate combination in this patient, because it's a pseudoarthrosis so very long.
Is it really needed?
Huh?
Is it really needed nail plate?
If it
It is not a junctional fracture.
Even
it
if
was
it's not
mid-shaft.
junctional.
Mid-shaft,
Agreed.
yes.
And even the principle in the non-Indian, you want absolute stability, number one. So nail plate combination, or usually they say it's the better to get a nail plate combination. Like that.
Sir, this was done in 2010.
Agreed.
16 years back.
Agreed. Still. Now, the second thing is regarding the proximal broken piece. If you take a nail entry point from the top,
Yes.
you can definitely push the instrument and you can put it.
Yes.
It is more on the medial side.
Yes, sir.
I saw that is more on the medial side.
Agreed.
Sorry, but you can negotiate it a little bit.
तुम्ही असल्यावर केला.
Agreed, sir, but... No, sir, what is the advantage? No, but this was mid-shaft, clear-cut mid-shaft, we can go anterolaterally. That is more easy. Acha, for supra, no, that was only for plate remove. Acha, okay. You could do that also, but I did like this. Thank you, sir. In many ways, yes, sir. Thank you.
Hello. I request Dr. Neeraj Somavamshi to present a case of humerus non-union.
Good afternoon, everyone. So today we are gathered here to discuss this case that we got in our OPD in MIT Latur 1 year back. Can anyone tell the diagnosis?
It is a frank non-union with implanted reducer.
No, sir. There was no infection. Nothing.
Atrophic type?
Yes, sir. It was,
because the ends are sclerotic, it looks more of atrophic variety.
Yeah.
Ends there sclerotic is
I'll just give a background that it's a 15-year-old case. Actually, the patient had a refracture after the primary surgery was done, so 15 years back. He came to us with complaints that he's having abnormal mobility and he's having pain at the fracture site.
Is there any vertical fracture down or is that artifact?
No, sir, that's the artifact. Oh, yeah, oh, yes. Yes, sir. The screw has, yes, sir.
Screw, so the screw is at the fracture site.
No, sir, actually, तो हे झालं, sir. It was.
Fracture site ला.
So it's actually a long-standing atrophic non-union of the right shaft humerus, and there was refracture with implant breakage, and actually the patient also had associated radial nerve palsy. Yes, sir. Since 15 years. 15 जर जेव्हा refracture झालं तेव्हापासून तो patient तसंच घेऊन चालू होता. So 15 years he's been using his hand in that way only.
आणि fall किती दिवसा?
So 15 वर्षापूर्वी झालं होतं. No, sir. At that time, the primary surgery was only plating was done. Yes, sir. So the plan. So I wanted to ask. Clinical examination, sir. There was visible deformity, And as I said, the patient was using his arm in the same manner. Yeah, so what are the treatment options, if anyone can?
Now explore, remove implants, freshen, shingling, fibula graft, cable grafting. Tendon transfer for radial nerve. Now there is no role of cable grafting. And put a fibula graft.
Okay.
And do plating. If sir wants double plating, maybe sir will sell double plating also.
Okay.
Do absolute solid rigid construct with four.
You're right. Yeah. So actually this is a rare case in which we saw that the patient was having radial nerve palsy along with the other symptoms that we saw. And on exploration, actually we did neuralysis of the radial nerve, that there was fibrosis around it. So, and then we removed the implant. And after that, so these are the modalities that we could have been done. As sir said, that plating is the gold standard that we could do. Along with that, we can do a intramedullary nailing and then external fixation in selected cases. But because the patient does not have any infection, so we won't go with that.
Only to add on is fibula graft in your list.
Pardon?
Fibula graft to add on the list.
Yes, sir. Fibula graft can be done. Intramedullary fibula graft. So, but the thing is, we fixed it using intramedullary nailing. So, after we removed the broken implant, we did bone grafting, and then we used the intramedullary nail. So, this was actually we didn't do plating, so because on plating we would have to do periosteal stripping. So
you have explored the nerve, no? You said
yes,
it
sir,
was
we did.
fibrous. Then you have already explored. Everything is in front of you.
But sir, to again fix it, then we would have to like the vascularity would have affected if we did. Okay.
No. You have already explored the radial nerve. For exploring, you are already dissecting off.
So the thing is, we couldn't extend the incision because the skin condition was not good.
You are only part required for the bone posterior surface here. You are not going to devasculate the whole of the circumference of the bone.
Right, sir. Yes. But the skin condition was also not good, sir. So we didn't. So the rationale for doing intramedullary nailing was that we wanted to have relative fixation and not rigid fixation, so that we could have some micro movement at the fracture site and we could have a callus formation around it. So load sharing fixations was suitable for long-standing non-union, and to avoid extensive periosteal stripping, to provide stable mechanical element, along with that to allow simultaneous biological augmentation with bone grafting. So as I said, we removed the broken plate and screws. We prepared the non-union site. Then intramedullary interlocking nailing was done with bone grafting. And then we followed up the patient to assess his radial nerve function. So these are his sequential X-rays that we did on for 1 month post-op, 3 month post-op, 6 month, and then 9 month. As we can see that there are few signs of healing at the fracture site. This was the 1 year post-op. So yeah, comparatively there was good callus formation. And so post-operative, we immediately immobilized using shoulder immobilizer. Dynamic cock-up splint was given for radial nerve palsy. Early mobilization of the shoulder and elbow was done, and physiotherapy and nerve recovery monitoring was done. Yes, sir. Yes, sir. Yes, sir.
Doing well.
Yes. He said that he had some pain because he tried to lift some heavy weight, and he said he experienced pain. So he didn't have any complaints for 15 years, that he was just, yeah, he was told. Intact plate, yes, sir.
With that trauma, the plate broke and then he had
Yes, sir, we can see that.
Radial nerve injury, you said.
Yes, sir, radial nerve injury. He had wrist and finger drop since 15 years.
And he was lifting heavy weight.
Yes, sir. He was trying to, he was as much as he can.
Just go back to your X-rays.
Yes, sir.
Priya, Shiva, I would like to analyze you also. To be Barka, not criticize him. Success is not challenged in your X-ray. Go back one more step back, because here then he has used a two-screw system. For the two-screw system to be acting properly, at least one screw should be bicortical. Am I right or wrong? at least one screw should be bicortical. Agreed, he has got success, United, all said and done. But comment to be passed.
Definitely a bicortical screw
Yeah.
will have a better stability, especially in a cancellous bone. So, yeah. That's correct.
Sure, the nail has to go a little bit down so
Yes.
that the second screw comes
Correct.
at the level of the calcar area.
Exactly.
Which is there.
All in your X-ray, I saw it is buried more than 5 millimeters.
Yeah. I normally,
More
that's
than
why, so
five-
that I'll have a one bicortical fixation.
In such type of metal, distance to of the proximal tube should be
Little.
about 5 millimeter, 7 millimeter down.
Okay, sir.
So that you could also have a bicortical position.
Right, sir. Okay.
Not to criticize you, but
Yes,
we are
sir.
analyzing ourselves learning. The nail should have been gone much more below 5 to 7 centimeters, and the distal screw of the proximal segment should have bicortical purchase.
Okay, sir.
Otherwise, what will happen in over a period of time, since it is the upper limb, because of weight, the cancellous bone hold will become loose. Again,
Right.
it will land up with distraction. So
Right,
that
sir.
was my thing.
And second thing, I would like to have a little bit more thicker nail. You can see the canal is not completely occupied by the nail. There is some space which is there.
Right, sir.
So in that scenario, if you feel there is not enough, you're not getting enough diameter nail, you can definitely put a plate and get one more
Right.
additional stability.
We are fortunate enough to get good results, but
Yes,
looking at the X-ray, proximal fragment is widely dilated because of the porosis there.
Right, sir.
So, and the screws don't have any means bicortical purchase. You are fortunate, you got the result, success
sir.
is not set. Good.
How many days, after how many days did the radial nerve recover?
So actually, sir, we saw the actually the first sign to appear was that he was having a sensation over the first web space. So that occurred at 8 months post-op, and completely by 1 year.
It is said that after 1.5 to 2 years, then there is no chances of actually after 9 months to 12 months only.
Right, sir.
Maximum is 18 months they have said that there are now cannot recover.
Any mixed nerve, the sensory part dies after 2 years, a motor part dies after 1.5 years. That
Right,
is
sir.
literature which shows.
Okay.
So he may not be having radial palsy, but with the fall, due to confusion, probably the radial nerve may.
Right, sir.
Just go back to the history and recheck if he ever had a radial nerve injury since 15 years, or it could be he lifted something heavy. There was a re-fall, whatever history you suggested. Then he had a radial.
So he had a fall actually after the primary surgery was broke. Yeah. Right. Of the radial nerve, yes, sir. Right, sir. 15 years back only. No, sir, no, sir. That wasn't recent. That was 15 years back only. He didn't have any history of trauma. Recent trauma nota, sir. No, sir. Recent history of fall nahi hai, sir.
Sampla. We'll wind up.
I request Dr. Aglave to present his innovation in axial compression.
Good afternoon, friends. Today I am going to present my new innovation, Aegis axial compression device, which is mainly used in tibia and femur fracture on table fracture compression. The present innovation related to medical devices for the improved rod fixation system for fracture in long bone. Fracture healing mainly occur by osteoconduction and osteoinduction. Osteoconduction is the physical mechanical requirement, contact or continuity of bone, and important for fracture healing, while osteoinduction is the consideration of biological, biomechanical induction of bone healing and bone formation. These factors are blood circulation and soft tissue preservation is more important in osteoinduction aspects. Non-surgical treatment, mainly cast application, emulsion with external splint, we can do. And surgical fixation, we are doing plate fixation and rod fixation. But in this method, the small gap in fracture fixation can be very harmful and can lead to non-union. Healing of the callus tissue is affected by trace. Surgical fixation is a method, plate fixation is a surface fixation. We can give compression with the help of dynamic hole by putting eccentric hole near fracture and then giving compression. Another method is with the help of Muller device, extra screw put on either side of the plate, and with the help of device we can give compression. And third method is also available. We can put extra screw behind the plate and application of clamp over the screw and end hole of the plate, and we can achieve the compression. Back. पुढं चाललंय, बॅकला जायचंय. बॅक स्लाइड, प्रिव्हियस स्लाइड. ते पुढं गेलं नाही, पुढं चाललंय सगळं. नाही, अजून मागं. हां, येस. हां, इथं. With the help of surgical fixation, we can get better anatomical alignment and give osteoinduction effect. It modified the torsion stability. Interlocking intramedullary fixation gives rotational stability, reduces phase fracture gap at the fracture site, and reduces implant failure. But if there is gap, then implant failure, screw or rod breakage can delay and lead to union, non-union. Ideal implant, so there is a narrow, either implant can do narrowing the fracture gap, eliminate the micro motion, provide dynamic compression, shears the stresses and reduces the motions. This is the intramedullary nail previously, which provide dynamic compression across the fracture site, which is help of compression members such as extension or compression spring or biocompatible rubber or elastic band. But drawback is that technically it is complicated, time consuming surgery, increases the inspection rate and difficulty in removal, and cost is also more. Then there is some newer method, they came after that word. There is long bone fracture where interlocking screw rod combination have a stepped diameter with semi-peripheral shoulder at the juncture of two diameter of the two or more effectively apply compression fracture site. Here is showing elliptical like hole. So we can after tightening the screw head make a compression at the fracture site. And there is also another one is, here is a screw having two tip and screw thread extending between the tip. At each of the tip connection portion, the screw has driver. Screw thread is used to cutting vertical bone medullary canal. Due to screw driven connection of the both the end can be driven from each end of the cortical. This allows method to be used in which screw is threaded into the one portion of bone fragment. Then after connecting further bone fragment at this fracture site. But technically, close reduction is more difficult. Can't pass device work with guide wire. Operative time is more. Removal difficult and more chances of implant failure. Then there is some newer device which are come. These are having compression blocking screw, which has to be added prior to attach the jig of the nail system. And after interlocking with instrument like long screwdriver, we can tighten the blocking screw and can achieve the compression. But drawback main is that it can obliterate the medullary cavity and can't pass guide wire. So long bone such as femur, tibia, fracture reduction is difficult without guide wire. So reduction and nailing become difficult. Humerus we can do with that method also, but in long bone it is difficult. Then there is a newer invention some. This is the compression device with an external compression pin. After distal interlocking of oblong hole interlocking, the pin is inserted into the conical bolt and compression can be achieved with the help of hex slot. For that, the threaded part is made in the pin upper end inside the conical bolt, which increases the diameter, the thickness of the conical bolt and making jig bulky. As the compression pin and conical bolt have threaded part, cleaning it is also challenging, but the problem is solved with the Aegis compression device. Then there is newer some method like barrel compression conical bolt. The AO Yogeshwar and some other company, they have invented conical bolt which have barrel and spring. After distal interlocking, we can tight that conical bolt and it make pressure over the proximal screw which is in dynamic hole, and that can give compression. But this is also the non-cannulated part, so we can't pass it over the guide wire. Main cause of non-union is bone gap and lack of compression. Common treatment for non-union is bone grafting and compression, but the compression is over the plate with extensive screw, or it is Muller device, that is surface compression, but it is not bicortical, that is not sharing the equal load on both the cortices. So thinking about intramedullary device compression, that is axial compression, but study shows compression screw which would be inserted over the jig, it will make compression. Compression screw design and conical bolt design will complicated and make more thick conical bolt with heavy bulky jig. So invented simple device can be matched with any company's nail system without changing more nail design or conical bolt and jig bulky designs. This is Asia's axial compression device. It is looking very simple, not having any thread. So insertion, removal, cleaning, sterilization is easy and it is accommodating very less space. Silent feature, no threaded part, can match to any nail company system without any modification except the length of the device. Attachment is simple and removal is simple. Cleaning, sterilization is simple, slim and small, so require little place to accommodate. Cost effective, made up from hard material, so durable. How control compression is superior than the impaction compression. Impaction compression or reverse hammering compression after distal interlocking causes transient compression and elasticity of the soft tissue leading to destruction of in some extent. Sometimes due to impact and force or reverse hammering, shattering of the fracture or displacement of the fracture occur because of force is not controlled. However, in control compression, the force remains constant. Slowly but surely, constant compression is achieved with continuous and sturdy compression. In impaction compression, minor fracture or shattering can be happened due to sudden stroke, but control compression force under CM guidance can provide good compression without shattering or displacement of the fragments. How it works? After interlocking of nail in distal fragment, we have to interlock nail at oblong hole of the nail. Introducing of device in conical bolt of nail with the help of head of for introducer, conical bolt with tommy compression instrument pushes interlocking bolt in distal direction and pulling nail on proximal direction. As distal interlocking bolt, previous slide, as distal interlocking bolt holding distal fragment in static mode will be pulled proximal direction with the nail, but proximal fragment remain at the same level, causes compression at fracture site. See here, before compression, there is a gap in head of introducer and slot for Tommy bar. And after compression, it goes downwards. After interlocking, the distal interlocking bolt, 2 or 3, we lock the oblong hole screw in proximal portion, and with the help of edges compression device and introducer of head using Tommy bar, we tighten the head of the conical bolt, which give an axial forces to the proximal bolt. The distal fragment is pulled in proximal direction, causing compression at fracture site. After complete compression, we lock the proximal part with a static bolt. So the compression remains stable and does not decrease over the time. It is useful in transverse and short oblique fracture, where the chances of non-union are higher, as transverse and short oblique fracture have less surface area and contact area for union is minimal, and if there is any large gap or non-union can occur, the compression force can facilitate healing in periosteal region as the end are closer, leading to greater osteogenic potential due to the compression force. The design is simple, so it must keep in a cavity of conical bolt, and only compression is applied with the help of introducer. No more part are needed, so the application and removal are straightforward, thus requiring less time for compression. Hence, simple design reduces surgery time. As the construction is well compressed and stable, the patient can bear weight earlier, achieving early mobility, which produces osteogenic signal to form more bone than usual, thereby reducing the healing time. It is useful in short and transverse oblique fracture pattern, proximal compression at fracture site, so healing time is less. Good and stable fixation give early mobilization, increased stability and osteogenic potential due to piezoelectricity. Potential for earlier weight bearing, reduces risk of non-union, post-operative stiffness, reduces, so little need to physiotherapy, less duration of disability. Patient can join the regular duty as early as possible. I want to show my some video. Yeah. No, I am straightforwardly, I am.
Nobody is attentive now because
Yeah.
you're just boring with all those theory.
Yeah.
If you have got good thing, you show that. You
I-
go to the
No,
slide, you show the compression.
Yeah.
Don't show anything.
Yes, sir.
I'm sorry to say this.
Yes, sir.
Thank you, that's all.
Sir, I am giving direct.
Video is there? No.
Video is there. Yes, sir.
That's all. You are not becoming bigger by blaming somebody else.
Yes.
You have to give respect to them and you should become bigger by showing your things.
Sound is there? So this is AG's axial compression device. I am putting in the lumen of the conical bolt. Yeah. Yes. Yeah. Yes, sir. This, yes, sir.
Moreover, it is an additional lecture we have given you a chance to present. Not even informed earlier to us.
This is transverse fracture mid-shaft tibia.
Distal interlocking was completed. Proximal interlocking, we have put only the screw interlocking bolt in the oblong hole. And now we are going to compress the fracture site with the aegis compression device. This is the aegis compression device. Now, with the help of introducer, chain of introducer, we are going to compress it. With the help of one bar, and we are slowly control compression we are going to achieve. Now see the fracture side, how beautifully fracture gap is going to reduce. Slowly, fracture is going to reduce, and final compression of the fracture was achieved. There are next two.
Where you push that dynamic screw put a bolt put in the dynamic hole, you push it down,
Yeah.
then nail comes up.
Yeah. But it is only for tibia and femur. I am invented for tibia and femur because nailing without guide wire in tibia and femur is difficult. We can do nailing in humerus, but tibia and femur is difficult.
But different size of the dynamic knocking from the top of the jig
Yeah.
might be different for different companies.
Yes, yes.
So you have
So
to have different
length, that's I have mentioned, the length is variable only, but rest thing is same. So we can match this device to any company.
I agree. Only compression of the oblong hole, which is approximately 4 to 5 mm. That
Yes.
much only you can gain,
Yes.
not more than that.
Ha.
So gap of less than 5 millimeter is suitable for this device.
Yes.
Not more than that is not applicable.
No, what can we do? We can do slight reverse handling or
You
manual.
are told reverse hammering is causing damage, fracture, splintering.
Slight we can do, na?
That is, if that is
Slide
possible
we
to
can
do, then this is of no use. When I can get the same as Kiran Prani's device. Kiran Prani's device. Kiran Prani's device is there. He is doing this with a locking bolt from the top. What you have done is same. And second is you do lock the upper static hole after this.
Yeah.
Huh?
See,
Then
I have
Kiran
done,
Prani uses.
I have done cases.
No, Kiran Prani, what is nail he is there, he uses the same maneuver what you have done with the help of the top nut. And later on he locks the static also. It is the same maneuver. I thought you could get extra compression more than 5 millimeter.
But
So the restriction here
for
is
that we have to change the design of the nail. Then and then we can.
oblong hole cannot be made more than 5 millimeter, otherwise it will be a weak spot. 5, sir.
5 millimeter.
5. You cannot achieve more compression than 5 if you.
After careful putting the compression and manual, we can do nailing. And जे final compression आहे ना ते आपण ह्याच्यावरती करू
सर
शकतो.
तुम्ही जे आपण बॅकस्लॅप करतो त्याच्याने जे गॅप आहे we do it as much as possible looking at the Siam picture. Second, in Kiran Prani's that compression is maintained with that bolt top nut continuously. मला वाटलं more than 5 is not, your device is also not suitable. 4 to 5, not more than 5. And he has agreed कि backslapping first, second.
Non-union can be happen with 2 to 3 millimeter gap also.
I have not understood. It is smooth.
Yeah.
At the top there is something.
Yeah.
On that top cap.
That is giving compression. Play video. Video all have X-ray and all these things. See the things. This is mid-shaft tibia fibula fracture with butterfly fragment. Tibia interlock nailing done and distal interlock was done with freehand technique. Proximal interlock with interlocking bolt at oblong hole of the nail. Now see the compression at fracture side. See carefully how beautifully fracture is going to compress. The butterfly fragment is also get engaged in fracture side and get compressed. This beautiful, full controlled axial compression you can get with the help of AJ's axial compression device. Thank you. अजून दुसरा एक व्हिडिओ. Another video, it can be played. Today we are going to see fracture
some gap at fracture site we can see.
But you have already put static lock there.
Not, it is the blocking screw, polar screw.
Have you got that thing here?
No.
Which company is making that?
I am made from local. Saffron company have given, but it is under testing still now.
Thank you, Dr. Aglavi.
Thank you. Yeah.
I request Dr. Ankush Kendre to present a case of forearm non-union.
You are from where? You are from where?
You can control this?
ऑब्लॉंग होल 5 मिलीमीटर से लॉन्ग अरे वीक होतो है नाही चालत 2 ऑब्लॉंग होल कर पहिला एक ढकलायचं मग आलोय घालायचं बाकीचे काढून टाकायचं वरती घालायचं अजून ढकलायचं नाही शकतो जेवढं करायचं
Good afternoon, teachers. I am Dr. Ankush Kendre, junior resident from MIT Latur. I would like to share a small case which we received in our OPD. She came on 21st of October and she was operated 11 months back. This is the X-ray when she presented. There is titanium nail for radius and square nail for ulna. Actually, she was operated 3 months back, where the tense nail from ulna was replaced with square nail because it came back. This square nail was actually initially it was a titanium nail, but it got replaced with a square nail 3 months back. Even after that, patient complained of pain. Close, close nailing. There was the history was given by the patient because we don't have any past record. She said it was a closed fracture, and she was operated for with close reduction. So the diagnosis is basically it is established non-union of left both bone forearms following failed intermedullary nailing. Basically, she was a 35 years old female, left both bone forearm fracture, no medical comorbidities, and persistent pain and disability for the last 11 months. Clinically, there was tenderness over midshaft radius and ulna, crepitus was present, there was no swelling or deformity, elbow and wrist movements were preserved, and neurovascular status was intact. Now, why is this case important? It basically highlights the failure of intermedullary nailing in forearm fractures because it actually does not provide the rotational stability. Okay, sorry, sir. It demonstrates progression to established non-union, and it emphasizes importance of rigid fixation and bone grafting. Now, background in short, both bone forearm fractures require anatomical reduction and rigid fixation. Union rates exceed 95% when the principles are respected. Intermedullary nailing provides limited rotational stability. Non-union usually reflects mechanical instability or compromised biology. Now, this was her X-ray in January 25, 2 months post-op. Sorry for the quality, but it was how we received. Here you can see both are tense nails. There is sustained fracture of radius and ulna treated with intermedullary nailing of both bones, inadequate rotational and axial stability. Now, what should be the foreman?
How many of you do this retrograde or top entry from the ulna? How many of you do it? I have never done one. I always take the side entry from the radial side of the proximal end of the ulna. So This is the commonest mistake. Yeah, yes, probably only people from Solapur use the side entry. Anywhere in India, whenever I go, everybody takes the top entry.
Yes.
I remember when I was
Yes,
I
sir,
was
it
Dr.
actually.
VMIS student, we had presented somewhere in 1984-85, side entry for ulnar nail. And previously when I was doing square nails, I used to use radius square nail only because side entry you require that flat surface. And we have never used ulnar pointed square nails since 82-83 when Dr. Iyer taught us. One L-wire paper was there and second was this side entry for ulnar nail.
So, what should be the further management? How should we manage this patient?
What is your thoughts? What is your thought?
So we.
What you might have given some thought how to manage this. So what was your planning to manage this? We
So-
are asking you rather than you asking us.
So like we have been discussing since last 2 days, we have to look for the contact alignment stability, which here is not possible. So we basically.
Contact compression.
Contact compression, yes.
Compression, alignment, stability, and
And stimulation, yes. So we removed the failed intermedullary implants. We prepared the non-union sites, and open reduction internal fixation with LCDCP plating was done for radius and ulna. Autologous iliac crest bone grafts were used. This was immediately post-op. Radius was fixed with a 8-hole LCDCP and ulna was fixed with 10-hole LCDCP. Compression achieved at the non-union site. Bone graft harvested from the right iliac crest. Post-operatively, on radiology and protocol, restoration of length and alignment, rigid fixation was achieved, good plate position and compression, upper elbow slab immobilization was done, IV antibiotics and analgesics were given, early mobilization of shoulder and elbow, and physiotherapy was initiated. This was the 1-month follow-up X-ray. Pain was relieved, there was stable fixation, progressive signs of union, and there was improved functional outcome. This is the functional outcome of the patient. So the key learning points and conclusion: intramedullary nailing is biomechanically inferior to for the forearm fractures. Plate fixation remains the gold standard. Revision surgery must address both mechanics and biology. Rigid fixation with bone grafting prevents non-union. Thank you, sir.
And this sentence, that is inferior or something, we differ. We have, myself, Dr. Shiv Shankar, 95% patients we do because minimally invasive introduction as well as removal.
Yes, sir.
For plating, both times you have to have large incisions, soft tissue. And though people say that our patients start using their hand, do you really feel that with such 2 large incisions, edema, pain, anybody will use his hand for first 2 or 3 weeks?
No, sir.
I don't feel so.
No, sir.
Shiva, just to have discussion, why were you against that entry from the center of the ulna? Or what?
It backs out very easily and people cannot sit like this.
Agreed. That is the one point where you can...
Student's elbow.
Bursitis is commonest thing. In the side entry also, bursa does form.
No.
Irritate. Agreed. When the patient sits like this on the table. Yeah, I agree.
Even radiant side also.
Yeah.
Exactly. That is also important. 3-point fixation is better. And definitely, point of elbow, I have seen nails coming out, we push them in, again they come out. You cut them, it still comes out.
Yes, sir.
The fracture is not united, you cannot remove the nail.
Yes. Thank you. Thank you, sir. Thank you.
I request Dr. Shiv Shankar, Dr. Kothadia and Dr. Bhandari sir and Dr. Adarsh Mehta sir to felicitate the chairman.
जेवढे काही राहिलेले एसओएसचे मेंबर्स आहेत तेवढे या आता स्टेजवर मावळे एवढेच राहिलेले आहेत.
बरं झालं आपण 4 वाजले इथे चालू केलं. Hello, sir. There is yet one event is waiting. Sir. Hello, here. We have to present the best paper award yet. After that, we'll take a photo.
Before you conclude,
Yes, sir.
Srinivas,
Yes.
we would like to felicitate you, and we would like to, with the full applause, we would like to appreciate your efforts and the grand success of this STM 2026. You have made something very important changes in the SOS. Out of that, I would like to mention, he has totally made it digitalized. Totally digitalized, filling of the form online, and payment, receipts, certificates, and membership also, and applauds to Srinivas. Without you, it could not be possible, for your untiring effort, and he did not lose at any time. And not to miss Praveen and Anurag. You should also come here. Praveen, where is Praveen? Praveen कुठे आहे? Praveen Swami and Anurag. या दोघांना पण felicitation करायला पाहिजे. These both two people have made totally all banners, etc. They have made personal care, and they were both right and left hand. Yes. All the banners have been all designed and got it done by Anurag and Praveen Swami. So applauds to three of them, without whom the success would not be there. President, शेवटचा हातभार लावल्याबद्दल, संस्थेला हातभार लावल्याबद्दल धन्यवाद. We called him, forced him to come here, because without you, SOS would look empty. Yes.
Now from this year we have started, IR sir has donated for STM, SOS, and from that we are giving best paper award for postgraduates every year. So today's winner is Dr. Neeraj Somavanshi, yes. Congratulations, Neeraj. Yes.
टॉपिक तरी सांगा काय आहे? The topic of Neeraj Somavanshi was refracture and long-standing non-union of shaft humerus with implant failure and radial nerve palsy treated with revision, IM nailing and bone grafting. What he presented, that was the paper there.